tube feeding. Among the patients who died of following thrombolysis, most experienced seizure, vomiting, and decreased sensorium during the infusion itself. Despite stopping the infusion, the outcome were negative. In patients who had vomiting without seizure, 2 out of 3 experienced immediate hemorrhagic transformation, while 1 developed after 3 days. However, all 3 patients were successfully discharged. Out of 34 patients who presented within window period, 19 underwent thrombolysis. Among the remaining 15 patients, 5 did not give consent from their families, 4 had improving weakness, 2 faced unavailability of resources, and 4 showed signs of raised ICP. Padma et al. Did a similar kind of study and found 65% patient had a notable improvement of NIHS more than 4 at the end of 48 hours, while small vessel ischemic stroke were more common in their study. S.R. Sharma et al. Also shows the similar result, while K.A. Salem et al. Found 51% of his patients were functionally independent at the end of 6 months. While Raymond C.S. Sit found that overall mean symptomatic ICH and mortality rate of their patient treated with IV thrombolysis were 5.6% and 14.7%, while mortality rate in our study is around 21% due to symptomatic ICH. Average administration of RTPA in their study was 175 minutes. In our study, it was 200 minutes, 200 to 210 minutes. Conclusion, our data showed that early administration of thrombolytics in cases of mild to moderate stroke is associated with better chance of significant drop of NIHS score, improved MRS score, and minimal risk of hemorrhage. However, concerns about the hemorrhage, lack of expertise in thrombolysis among healthcare workers, and need for specialized ICU facility and staff training are crucial for better outcome in stroke patient. Video. There is a small clip of 25 seconds. This was a cardioembolic stroke which was improved while thrombolysis was ongoing. Permission was taken from the patient.
नाम की ये हाथ उठाई दियो इदो
नहीं मैम प्रॉपर स्ट्रोक. That highlights the importance of the early detection, better management, and early administration of thrombolytics. So I conclude. Thank you for this opportunity to present the paper.
Congratulations.
Thank you, sir.
Excellent work you are doing.
Thank you, sir.
I have a couple of questions to you. Number one, did you analyze what percentage of patients comes to your hospital within the window period? Do you have any data?
Yes, sir.
Yeah, can you share
sir,
us?
total 34 patients were came in window period, sir.
No. What percentage of patients? There are hemorrhagic stroke, there are ischemic strokes. You had 444 patients during the study period, right?
Yes, sir.
Those 444 patients were stroke patients, right?
Sir, those were ischemic strokes, sir. And
those
around similar number of
stroke.
patients were hemorrhagic strokes, sir.
So 444 were ischemic stroke.
Yes, sir.
And in the same period, how many of them were hemorrhagic stroke?
Sir, it's around 500 to 600, sir. More than ischemic stroke, sir.
So almost 55-45, right?
Yes, sir. Hemorrhagic were more than ischemic stroke, sir.
Hemorrhagic was more than the ischemic stroke. Very good. And out of that 444 stroke, 34 of them arrived within the window period. So the number of patients coming within the window period is very less, right?
Yes, sir. Yes, sir. It's around 9%, sir.
9%. So when I did this study, so around maybe when I did this. Around 30 years ago in Guwahati, then 5% of the patients were reaching the hospital within the window period. So it has improved, but very slowly.
Yes.
From 5%, now it has become 9% of them reach the hospital within the window period, right?
Yes.
What was the most important challenge that you faced while taking up this study? What was your challenge?
Sir, my first challenge is to convince my other colleague and to my medicine resident and to get rid of that taboo of the hemorrhage. People, not even the general people, even the resident, medicine resident, most of my colleagues, they are very much afraid. Why to do this? If patient had a hemorrhage, who will take the responsibility? And why you want to initiate this program? Better to let go, let them do the ecosprin and continue the therapy. Sir, I remember when my first case came at around 8 a.m. on the 1st March of 2023, I myself carried the trolley from city center to my center because no one was ready to give their name with to do. So there were challenges, sir, but since this year, sir, 2024, as I am getting the good result, out of, sir, till date I did total 24 thrombolysis, sir, after August. Out of 24, I personally did 22 thrombolysis, sir. So now the acceptance is more because we have so many ICUs in GMCH. Few are getting admitted in medicine ICU, few are getting admitted in neurology ICU. When they are seeing the outcome, yes, patient improve, there's no need to worry about the hemorrhage. There are certain parameters. You need to control blood pressure. If you are seeing there is a rise in the ICP, you have to give mannitol timely. And when the outcome, now the outcome are very good, sir. Out of my last 10 cases, only 2 were died. So now they themselves is getting, yes, we want to do the thrombolysis. But sir, the major problem came at which I face from the patient party. It's very hard to convince, sir. Patient already come at you around 2 to 2.5 hours. There is a little window of 1 and 1.5 hours. That time you have to convince the attendant ki, sir, eto apnar debo lagibo. Then we have to tell them there is a chance of hemorrhage. And then they told, sir, kiba hole to ki koriba. So that crucial 1 hour is very, very important because they are very much acceptable. Patient had a MI, give thrombolysis. But when it comes to a stroke, they are very apprehensive. What will happen? What will happen? They are not worried about what will be the outcome. Because, sir, they know MI हुआ है तो patient मर जाएगा. But they don't worry. Stroke हुआ है तो they will चलेगा, ऐसे ही चलेगा. So we need to change the perspective of general population also that stroke is equally important. And if we treat in the time, patient can walk.
Very good. Do you intend to continue this work?
Yes, sir. Yes, sir. My aim is to at least till I finish the residency, I want to complete 50 cases.
Very good. Excellent. This 1,000 patients of stroke, both hemorrhagic and ischemic stroke, during what length of time they arrived your hospital?
Yes, sir. Sir, maximum time of presentation is 10 to 12 hours, sir. Those who come from the periphery, it's around 10 to 12 hours, sir.
And your study duration was?
Duration, sir, this study was done for last 1.5 years, sir. It's continuous. It's a prospective study, sir.
Yeah, so that means in 18 months you had around close to 1,000 stroke patients in your hospital, right?
Yes, sir.
Okay, very good. Excellent. I must congratulate you again. Please pursue this.
Thank you, sir.
Okay, very important.
Thank you, sir.
Yeah, hi. Yeah, Dr. Akshay, it's a nice presentation. So I have 1 or 2 questions for you. So you are looking in your study is post-thrombolysis NIHS versus the MRS, right?
Yes, sir.
So you, in your subgroup analysis also, you checked for pre-thrombolysis NIHS versus post-thrombolysis.
Yes.
And you said that post-thrombolysis NIHS. When did you check the NIHS, post-thrombolysis? What is
48 hours, sir.
After 48 hours?
After doing the initial CT, 24 hours, then again 24 hours, sir, I have taken the 48 hours.
No, in your data, the analysis data, you taken NIHS up to the 48 hours of thrombolysis, am I right?
Yes.
Okay, so any particular reasons for taking thrombolysis NIHs after 48 hours?
Sir, other studies done in across the India, which I have referred in my, they have taken 48 hours, sir. They have taken the NIH score after 48 hours, and drop of the 4 is they have taken it as a positive result or a successful thrombolysis.
Yeah, absolutely. That is how we look for actually. When you do thrombolysis, post-thrombolysis, you need to have a very intensive care in the stroke unit, where you say that post-thrombolysis patient is provided, it's a 4 units drop in the NIHS score. But at the same time, so have you checked for the pre-thrombolysis NIHS versus post-thrombolysis NIHS
Yes, sir, I have checked, sir.
in subgroup analysis?
Yes, sir. I have checked pre-NIHS, pre-thrombolysis and post-thrombolysis, sir, and I have found statistical correlation with them, sir. That was significant, sir. Correlation was a strong correlation comes, sir, with p-value less than 0.001.
Yeah, no, because at the end of the day, NIHS is, it's just a scoring where it defines how severe is the stroke, right?
Yes.
So more NIHS is naturally you to have the less outcome of MRS.
Yes, sir, definitely, sir. In our study, we have found that the rise in the NIHS score pre as well as the post NIHS will directly affect the functional status at the time of discharge, sir, with positive correlation.
But I would be more, interesting if you look, say, for example, very high NIHS, but they have a very small area of involvement. Say, for example, you see that central circulation MCA is involved. So there is a small area of involvement, maybe cardioembolic or where, but the patient is having very, very high score of NIHS because of aphasia, because of, complete paralysis or all these things, and post-thrombolysis is dramatic improvement. So just look into that data of where you have a very high NIHS, you thrombolized, because I think thrombectomy was not performed in your all these cases, right? Even in LVO, it was not performed. Am I right?
Yes, sir. Thrombectomy
Was not offered. Okay, fine. So in this group, you just look into the high NIHs where you have thrombolized, and there is a very good outcome. And if you look into this imagings of these patients, might be you have whether it's a large hemispheric involvement versus a small area involvement, then you can compare this to one, because that's a number. And do you have any idea what thrombolytic agents have you done the subgroup analysis for thrombolytic agents which is being used?
Sir, as we are working in the government setup, we have altiplase in our government supply, sir. Second agent is tenecteplase, but that is not available in our supply, sir. So we haven't used the tenecteplase, sir.
Okay.
And I saw some studies, sir, and they show it is non-inferior to altiplase. It is not superior, but it is non-inferior to altiplase, sir. The result was same.
Yeah, altiplase and tenecteplase both are very well defined now. We can go ahead and do the thrombolysis. Tenecteplase has wonderful data now. It's easy to administer as well, because just to see what is the drugs. So there are so many subgroups analysis you can look into this one if you have very strong data from where you can find, because rather than just only post thrombolytic NIHs and see the MRSs, that is something you know also. Okay, it is going to happen, right? Okay, thank you.
Thank you. Thank you, sir. Thanks.
So, wonderful presentations by Dr. Akshay. So, we had multiple platform presentations actually, but President couldn't reach till now. So, because we're also having in the second half, we're also having platform presentation. We'll look into that one, if that possible, right? So, we'll move to the second session, that is the most interesting, and the day 3 is primarily for that one, that is like Mission Brain Attack. That's an initiative from Indian Stroke Associations, as I said. So we had a wonderful cycling event today in the morning. So that's supposed to, we'll be taking a short break, and after that we'll be starting the sessions of Mission Brain Attack and an initiative of Indian Stroke Associations, and there are lots of interactive sessions and panel discussions as well. Just a short break, thank you. Okay, so welcome back. So we have another platform presentation. So I invite Dr. Debashish Hoda to present his case, which is a very unusual cause of stroke in a young person. So what are the things we should look for? So I invite Dr. Debashish to present the case, and also request Dr. Nomal Bora sir and Dr. Nirmal Suya sir to chair these sessions for this one. Thank you.
Hello. Good morning all. I will present a case of recurrent stroke, and we have take almost 6 months to find out the cause, and later we solve the issue of the recurrent stroke with intravascular and interventional management. This is the patient details. That is the AK name. That is the 32-year male, occupational IT professional, premorbid, MRS is 0. He was fit and fine. Suddenly, he has sudden onset slurring of speech with weakness of the right upper limb, lower limb. That is a acute stroke on July 2023. Then NIH was at the presentation is 14 by 24. GCS is full, and there is a slurring of speech, and verbal response is not adequate. Then this is the timeline of event. He has reached the home at night after the office hours. Then stroke onset at the 10 p.m. Then the hospital arrival after within 2 hour 15 minutes. Imaging done within 20 to 25 minutes. Then we rule out based on the CT scan, we rule out the hemorrhage, and there is no comorbidity, not on any medication. So straight away go for thrombolysis at 1:10 a.m. IV thrombolysis, so door to needle time was 35 minutes. Then we shift to the cath lab because there is some subtle hyperdensity in the MCA from the CT scan. Then the puncture done at 1:35 a.m. and door to puncture time was 80 minutes, and recanalization done within 105 minutes. And this is the MRI image. That is the DWI showing the infarct. Now this is the flare image. This has not picked up in the flare. So we have a time. This is the SWI image showing the clot in the left MCA, and that is this is the angio image. That is the left MCA cutoff. Now straight away we go for the DSA. And this is the DSA we have taken. Now this is the left ICA, that is after thrombolysis. There is some branch occlusion, and with the TPA there is some opening of the main branches of the MCA, but there is subtle pointer. We have the pointer. And this here there is a stagnation in the blood flow, but it does not completely recanalize. So we go ahead with the mechanical thrombectomy. This is the micro air cross the lesion, one of the branches of the MCA. Then we do the Solumbra technique, that is the stent assisted, along with the adapt technique, that is the aspiration. This is the post-procedure CT scan, and he has no permanent deficit in the CT scan. And this is the story. We have successfully chased the story, but interpretation that attempted MT was done with simple aspiration. Intra-arterial, we have used some of the intra-arterial thrombolysis and successful TK3 mechanization achieved, and patient discharged on with MRS2 on day 5 and discharged with dual antiplatelet. The story begins now. The second episode again occur after on the dual antiplatelet, right-sided weakness with slurring of speech lasting for 1 hour, complete recovery on hospital arrival. NIH on arrival is 0/42. GCS was full and clinical diagnosis was TIA was made. And that time we have also chased the MRI. There is no acute DWI or flare changes. So it is, we confirm the diagnosis of the TIA. Then we try to escalate the dose of the ecosprin to 150, Plavix 75, all the extensive workup we have done at this time that was came negative, and long-term halter was advised to root out the cause. Why this young patient is suffering like this multiple times. The third episode again occurred 3 to 4 months back, similar episode of TIA lasting for 1 hour. NIH on arrival is very low, 1/42. Improve on the next day. We added Clexon to have a no recurrence during hospitalization. Then extensive workup again done after 6 months, still it is came negative, and we have also extended our vision to transesophageal echo to rule out any PFO in the young patient. Then this episode also there is no DWI changes or there is no flare changes, and the interpretation was discharged with MRS 0 within 2 to 3 days. We thought of clopidogrel resistance or labeled it as cryptogenic stroke. But after 6 months, he has similar episode of TIA, multiple episode of crescendo TIA occurring over last 6 months. NIH is 2/42, recovered within 2 to 3 hours, no clinical deficit. That time again first time we have done as a mechanical thrombectomy, we done the DSA. Now we have planned again for the DSA to look for what is happening with him. Now the MRI brain is done, that is also DWI negative, but still we go ahead for look for the cause and extended our investigation to DSA. Now the DSA done. You look at this, there is a stagnation of the blood in the carotid bifurcation near. This is the catch point in our DSA. This is the left MCA that has previously infected, and this side again creating the symptom, and there is stagnation of the blood in the this is the left CCA run. There is clear stagnation of the blood here. This is the cause of recurrent stroke for this patient, young patient, and now we have done repeated the right side angio, complete the angio. Still he has a similar type of stagnation of the blood in the bifurcation, CCA bifurcation, both on the left side and right side. Now though we have gone through the recent paper, what it could be, that is the one of these is carotid wave syndrome or carotid stump syndrome, but this is most likely the carotid wave, bilateral carotid wave is there, which causing multiple episode of TIA. First episode presented as a stroke and we have successfully recovered with mechanical thrombectomy, but even after that on antiplatelets or dual antiplatelet, he still have the multiple episode of TIA symptom. Now the interpretation, that is the significant stasis noted in the bilateral carotid bulb suggestive of carotid wave, and we planned for the left carotid stenting because it was the symptomatic side in the prior setting, and the symptom, recurrent symptom is the left side. Then we go ahead for the DSA for procedure. This is the guiding sheath showing the stasis in the left CCA bifurcation. There is stasis of the blood here. Then we go ahead with the stenting and we advance the embolic EPD, that is the embolic protection device, kept at the distal point because there is high likelihood of clot migration. Then we do the stenting. Now we pass the stent. Here we have successfully stented the carotid bulb. There is still some stasis, but that leads to the less embolic phenomena from this side. Post-procedure CT was done. This was clearly fine. There is no deficit, but there is some previous deficit of left MCA infarct. The final outcome, that is the successful left carotid stenting, discharge on dual antiplatelet, MRS on discharge is 0. Now again, he has after 2 months, he has a similar episode, but on the other side, sudden onset left-sided weakness, slurring of speech lasting for 1 hour, clinical diagnosis of TIA plus. Now this is the possibility of the right-sided symptomatic carotid wave. Now we done the MRI. There is showing some subtle infarct in the right side. Then we again try to counsel him for the other side stenting to get rid of all this symptom, recurrent symptom. Then we have done the right CCA run. There is showing stasis in the carotid bulb. Now we advance the embolic protection device the same way as we done in the last left ICS stenting. This is the embolic protection device right in the cervical ICS. Then the right-sided CCA run showing significant stasis. 2 minutes. Stasis in the carotid bulb region. This is the cause of recurrent thrombus formation. Then we successfully done the both-sided stenting, right and left stenting for the bilateral carotid wave. Now the post-procedure CT scan looks fine. Thank you. This is we have completely stent both the carotid in view of the recurrent TIA and one episode of complete stroke with successfully recovered with mechanical thrombectomy. Thank you.
Any questions? Vikram, you have any comment on this case?
Bilateral carotid wave.
Bilateral carotid wave presented as a recurrent stroke, finally got caught.
Yeah, so if it is carotid web, I think we should stent it.
Yeah, we have stent the first one and left the other one, thinking of the activity. Then again the other side becomes symptomatic, so no, then we stent the both side.
Yeah, correct.
So, how common is carotid web presenting as stroke, and why it was not picked up when you did the DSA first time?
Yeah, we have missed it, and it was there in the left side when we go for the mechanical thrombectomy. But at that time, we have in a rush to do the thrombectomy, so we missed up that part in the last year.
So, lesson is that you should be looking for everything right on the beginning, not to miss out, because if you have picked up at that time, you would have removed the clot at the same time you would have done the stenting.
Yeah.
Good. Thank you. Biplab, any further presentation? Yeah, because we got some physicians coming, so 10 o'clock time, so we start at sharp 10. Yeah.
Good morning, everybody. From the platform presentation, now we move on to a topic which is like a passion of ISA, mission brain attack. Just like heart attack, time is tissue, same is for brain. And to chair the session, I'd like to call upon Dr. Numal Bora and Dr. Anand Vaishnav to kindly come on the podium and take your seats. To present on the topic, we have heard Dr. Nilmal yesterday also on his mission of stroke management, and he will be talking on mission brain attack, an initiative of Indian Stroke Association. He is the president of the organization as well.
I have no presentation. Good morning. You want to say something, Chairperson?
Good morning. I think this is something that, growing up, I've been in the field of stroke for 24 years, and I think stroke is never about one person. I think it's more, I think there are multiple stroke warriors, and I think in order to win our victory against stroke, I think it has to be a grand team effort. And I think who more than Dr. Nirmal Surya, to give a presentation regarding this mission that we are trying to do across the country.
Thank you.
Sir, the podium's yours.
Thank you, Chairperson, Dr. Bora, my very close friend, long-standing, and Dr. Vaishnav. It is always a pleasure to be here in Guwahati and be with you whenever we visit here. And thanks to Dr. Biplab to do this. Now, what is mission brain attack and what is the aim and idea of launching this? So Indian Stroke Association on 12th of May launched a program which is mission brain attack from none other than the place called Varanasi, the constituency of our Prime Minister, Mr. Modi. And idea is that this mission brain attack should focus on end-to-end care. This has been done in association with the Association of Physicians of India, and which is a joint program, whereby what we have been doing is we are trying to train the physician to take the IV thrombolysis as one of their fold, how they have been doing it, IV thrombolysis for cardiac heart attack. So to train them, give them confidence that how best they can be understand and learn to use the intravenous thrombolysis drug for the stroke. So mission brain attack is aimed to train them and provide end-to-end care, which has got 3 arms. And the first arm is primary prevention, which is stressing upon control of blood pressure, diabetes, obesity, smoking, alcohol, and other risk factors. So that's very, very important, because by just controlling, primary preventing this, we can reduce the stroke incidence significantly, which has happened in the Western world. The middle arm is to train them about, sensitize them about IV thrombolysis in golden period, which is 4.5 hours. So if any patient who has the symptoms suggestive of stroke, so we tell them how to identify, be fast, and you all know about the be fast. I don't have to stress upon to you, but be fast. If you have anything like that, immediately get a CT scan done. And if the patient has, you have ruled out hypoglycemia, blood pressure is not very high, and CT scan is normal, he's an ideal candidate if he has come to you in 4.5 hours for IV thrombolysis. So this is what we have been training them, and then also sensitizing them that suppose you have given the IV thrombolysis drug, patient has not improved in another half an hour time, and CT scan has not worsened, please do the MRI and send them to a place where there are expert intervention neurologists are available, so that if he is a candidate for mechanical thrombectomy, he can undergo the mechanical thrombectomy. So the middle arm is acute management consisting of IV thrombolysis, and in those where there is a artery occlusion or large vessel occlusion, go for mechanical thrombectomy. Then the third arm, As you all know that there are nearly 1/3 patient after the stroke have the severe disability, another 1/3 have mild to moderate disability. So nearly 40 to 50% patients are left out with disability in spite of the best available treatment. And for them to provide a rehabilitation, which is equally important, so they have to go for a proper rehabilitation. It's just not moving the hand or the leg. And we're also sensitizing them that proper rehab is what required. So now, by now, we have done the 7, and this is the 8th session. We started from Varanasi, then we have in Udaipur, then we have in Bangalore, Vikram was there, then we had in Aurangabad, then Hyderabad, then Nasik, and last Sunday we had in Indore, and today we are having it in Guwahati, where many of the physicians are on the way and joining from all across the Northeast. What is the impact? You will ask me what you are doing, how it is impacting. So I must tell you that after our regular series of this session, at least in Varanasi, the 6 to 7 patient has been thrombolized by the 5 doctor. Similarly, in Aurangabad, there are 8 thrombolysis. In Nasik, nearly 5 to 6 thrombolysis has happened. And what is good is that I'm told yesterday that in Indore, MP, there are 3 patients who has already been thrombolized in last 1 week time. So I think Mission Brain Attack is creating a confidence into the intensivists and general physician. As you all are aware that India's population is 1.42 billion, and we have 4,000 neurologists, about 1,250 stroke specialists, and most of them are placed into the district area, in the urban area. So district area and rural area are not having many neurologists, and time has come when the physician has to take the responsibility to treat the acute stroke, to prevent the disability, and ISA is very happy to take this forward of this initiation, and I'm sure this is going to have a long-term impact over a period of time. ISA also want to build up the telestroke app, which will help the physician along with API, which most likely we are going to release during the annual API conference at Kolkata. We are working on that so that all the physicians across who are the member of API will have an access to this app, and they could connect with ISA. ISA will delegate some of the doctors who voluntarily will be able to help on the rotation basis to guide these physicians to take the thrombolysis. And I think time has come when we need to do the required number of IV thrombolysis at least across the country. So in this mission, I must thank that we have 2 more initiations going on. One is for the patient awareness program, where we are teaching the patient, and the program is each one teach one. That's any person who has suffered from the stroke, keep on teaching other 5 people that these are the things which can happen in the stroke and you need to take care. So I must thank MCure who has partnered for this Mission Brain Attack and each one teach one initiation, and we are definitely going to take it forward. So with that note, I start the Mission Brain Attack Assam chapter, and I thank you all for being part of it. Thank you very much.
Any questions, comments from anyone? Dr. Biplab?
So thank you, sir, for this initiative which has been there. Indian Stroke Association has been always the flag bearer all this initiative. Today morning we had an interaction sir has flagged off cycling event which is so well attended, and when we received all the cyclists over here, they were so enthusiastic. And day before we had a press release and press conference during the interactions. So the more and more people are getting involved now. They understand the gravity, the magnitude of problem we have now over the years. Because stroke is something which is affecting more and more young persons now, rather than it's like a, we have been talking on day of inaugurations and all this. This is what is happening. And this is really the time where not only the Indian Stroke Associations, I mean, like we should have an understanding, we should with the government itself, because at the end of the day, when you think of doing something for us, for our family, even somebody who is going to take care of children, fathers, mothers, it is the main young generations who are in the 20s, 30s. So people are getting a stroke in this age group now, very frequently. Dr. Bikram is here, everybody, you all there. So you all agree, in my hospital, everywhere, it is like 40-50% patients who are in these age groups, who are the pillars of the family, for the society and the nations, absolutely. So this is something where we need to do, and this is a wonderful program, which is the initiative from the Indian Stroke Associations, Mission Brain Attack. And we are privileged to have association with Indian Stroke Associations as like this initiative of We Care Stroke, which is a non-profit organization. So we are having nearly thousands of stroke survivors who are actively part of this initiative. And based on this one, we are doing more of an awareness about strokes. We are trying to build up in local languages the symptoms identifications like BFAST, as Sir has already mentioned. So in Hindi, it's already been done, Bachao. So in Assamese, Okhomiyatami, we have done Bosam Bulikon. So these are the things which we have already made, and that we have received the government trademark for that one also. So I think this is a collective effort should come from each and every one. It's not like it's my effort or ISA effort. It should come from everyone. And it's going to make a lots of difference down the line. Thank you, sir.
Thank you, Biplab. You have rightly pointed out on very, very important points, and I must congratulate and thank you for the cycle pedal for the stroke. It was wonderful. I was talking to the 30, 40 young and old, both cycle rider, and when I cheered them, they got really excited, and I also mentioned that you should be the ambassador about talking to the stroke. And suddenly when I push off, there's one gentleman came that, sir, I want to talk to you. And I could see that he had a left-sided stroke. So he said, I had a left-sided stroke last May. Will I get better? I said, you are already putting an effort. You are already much better. He said, but still hand is weak. So, you know, already people are looking at you. It is only we need to shout and create an awareness among the society that don't miss out on time. I think many people yet are not aware that there is a magic drug which can be given in 4.5 hours and that can cure the stroke. I think this is the time has come that we understand and we tell them that this is available. Once people know that this is available, they will definitely ask for it. And for physician, I think they should be more and more confident. Don't be scared that it will cause hemorrhage. If you have a patient who had a TIA or stroke, CT scan is normal, blood pressure and blood sugar are normal. You will understand from various lectures now. You should be confident to give it, or you should talk to the neurologist and without wasting time, help the patient. That's my advice to you. Thank you, Biplab.
Thank you so much, sir. For the next talk, I'd like to call upon Dr. B. Sinmon. He is from Nigrim's Shillong, and she'll be talking on thrombolysis, indications and precautions.
Yeah, so a very warm Sunday good morning to each one present in the hall. I initially would like to thank the association for inviting us. In fact, I would like to thank the organizing committee to bring this program to Northeast India, where thrombolysis is still a hurdle, interventional therapy is still a hurdle. I come from Nigrim's, it's an institute, the central institute, but we're a budding neurology department. We've just started the DM neurology course in 1 year. And so we've just started thrombolysis in the last 1 year. We've thrombolized around 12 patients, out of which 2 died, and the other are doing quite well with a good MRS score after 30 days and 90 days follow-up. So yeah, today I will be talking on indication and precaution of thrombolysis in stroke. So I would like to give another name to this topic, the fragility to be handled in thrombolysis in stroke. So thrombolysis is one of the best agents available for treatment of acute ischemic stroke. But it is a very fragile drug. We need to handle it, and we need to know all the things, the precaution we need to take to handle this fragility. So this is the pyramid treatment of stroke. You can see the available treatment of acute ischemic stroke available. So if we see this pyramid, the oldest drug is aspirin, but the absolute risk reduction is only 1%, with the number to treat around 80. When we compare it to the the maximum absolute risk reduction, that is the endovascular therapy of 31%, with the number to treat of only 3 to get a positive response. Thrombolysis, it varies from 5 to 15%, with the number to treat varying from 10 to 15. But the largest stroke trial, the number to treat has reached 50 because of various other things. So these are the trials in thrombolysis. If we see, thrombolysis has been tried since the year 1995 and so on, out of which only 2 trials has given benefit, the NINS trial and the ICAS-3 trial. But the largest trial was the IST-3 trial, but this trial did not show benefit, although a post hoc analysis showed that there was benefit of thrombolysis in comparison to placebo. The risk of hemorrhage has various trials, but it's 6 to 8% among the trials that has shown a positive effect. So when we do a meta-analysis, there are around 12 trials that we can take into consideration, and there's definite a benefit to thrombolysis. But the most important thing is the benefit if treated within 3 hours. That is the most take-home message. So what are the indications of thrombolysis in stroke? Number 1, you should have a clinical evidence of stroke. The CT should rule out hemorrhage. We should know the time from onset or the time when last well known, and the age and the severity of stroke. So when it comes to neuroimaging in stroke, that is, initially in the earlier years, a CT scan used to be performed to only rule out hemorrhage or to see those patients who are at risk of hemorrhage, that is, a malignant MCA infarct. Then gradually, the imaging shifted to identifying occlusion, a proximal occlusion, so that patient can benefit from endovascular therapy, and even your timing has shifted from 4.5 to 6 hours. But gradually over the years, now the thing has changed. Now again we go to the brain tissue, but here we are checking for viability of brain tissue, and this can be done up to 24 hours. So the image has evolved in acute ischemic stroke care. Now, from time is brain, we have come to imaging is brain, where places where everything is available, an MR perfusion or the CT perfusion is the investigation where we see the salvageable brain, and further we see an angiogram if there's an occlusion to decide whether the patient to go for EVT or to go for thrombolysis. So now what are the indication of thrombolysis in stroke? The class 1 indication, that means these are the indication where benefit is much more outweighing the risks. So we know within 3 hours of stroke of more than 18 years, there is no further age exclusion within 3 hours of stroke. And it is also recommended for severe stroke symptom, that is an NIHS scale of more than 22. Beyond 3 hours, up to 4.5 hours, class 1 indicated in below 80 years. In more than 80 years, it is class 2A indicated. Those patients who has a malignant MCA territory, it is not class 1 indicated. However, there are certain consideration, that is blood pressure has to be lowered down, sugar has to be corrected, even in the presence of early CT changes, or patient is on prior antiplatelet, or an end-stage renal disease, it is class 1 indicated. It is class 2A indicated in more than 80 years or in mild symptom within 3 hours. Class 2B indicated in mild symptom presenting beyond 3 hours, in severe stroke beyond 3 hours, or if your patient already has a pre-existing disability of MRS more than 2. So now what are the precautions or the things you need to know before you thrombolyze? So there is class 3 contraindication, class 3, that is either there is harm or either there is no benefit as it's divided into two. If it is beyond 4.5 hours, there is no harm, but there is no benefit unless you can do a CT perfusion or an MR perfusion to see whether the brain can still be salvaged or not. It is class 3 harm indicated if the CT scan is showing hemorrhage, in ischemic stroke within 3 months, severe head trauma within 3 months, presence of intracranial surgery within 3 months, GI bleed within 21 days. If you clinically suspect subarachnoid hemorrhage, even with a normal CT scan, it causes harm. If your patient has low platelet or a deranged coagulopathy, if your patient are on anticoagulants, and others like presence of an aortic dissection, infective endocarditis, and intracranial neoplasm. Now, what are the relative contraindication? That means these are the indication where you have to decide case to case, where benefit should outweigh the risks. So class 2A will be when benefit is 2 times more than the risk. Class 2B is when benefit is 1 time more than the risk. So you can still take this patient for thrombolysis. If there is early improvement, you can still take the patient for thrombolysis. If your disability present in the patient might harm him, for example, presence of hemianopia, seizure at the onset. Once you rule out that this is not a TOTS paralysis, you can take the patient. You have to correct sugar and take the patient for thrombolysis. Patient with coagulopathy, if you don't know the case, you can take it case-to-case decision, or the INR is less than 1.7. In case your patient has done a lumbar puncture or an arterial puncture of more than 7 days, in case of major trauma or surgery, more than 14 days, but here we know that their risk of bleeding will be there in comparison to the benefit. In menstruation, it is class 2A indicated. In presence of extracranial arterial dissection, it is class 2A. Intracranial arterial dissection, it is class 2B. Now, when it comes to certain neurosurgery topic in the presence of a stroke, if there is an unruptured intracranial aneurysm, if it is less than 10 mm, class 2A indicated for thrombolysis. But in case of giant intracranial aneurysm, it is not well established. In vascular malformation also, it is not well established. If you get microbleeds in your neuroimaging, if it is less than 10, it is reasonable. But if it is more than 10, there's an increased chance of intracranial hemorrhage. Extracranial neoplasm, it is recommended, class 2A. In case of acute MI, it is class 2A recommended, even if the patient has to go for coronary angioplasty or stenting. In case of a recent MI in the last 3 months, they have been divided into 3 categories. The non-STMI is reasonable. STMI in the right or inferior myocardium is reasonable, but in the left anterior myocardium is class 2B. Presence of any heart disease, pericarditis, or thrombus, it is reasonable, but if it is severe stroke, the benefit is uncertain. If it is a procedural stroke, or your patient in CTVS ward has developed a stroke, it is reasonable, and we have to just apply the eligibility criteria that we apply. In presence of systemic malignancy, it is not well established, but they say that if the life expectancy is more than 6 months, it is reasonable to thrombolyze this patient. In pregnancy or early postpartum, that is within the 14 days, benefit is more than the risk, but there is an increased chance of uterine bleed in this patient. In certain ophthalmological condition like hemorrhagic retinitis, it is reasonable class 2A, although there is increased risk of vision loss. In sickle cell anemia, it is beneficial. In presence of drug abuse, IV drug abuse, and unless there is any other contraindication, it's class 2A. Now, when it comes to stroke mimic, the most important stroke mimic is hypoglycemia, and TOTS palsy, which needs to be excluded. So we give a 25% dextrose and see for correction. If the patient fails to improve and we do not want to delay treatment, it is class 2A recommended to thrombolyze the stroke mimic case. So as we all know that we should do no harm, and every brain that we try to save should be safe. So we need to know how to handle things with care. So what we are very scared of is serious adverse event. There are only two serious adverse events. One is angioedema, for which we should be ready to intervene. And the second thing is intracranial hemorrhage. But all intracranial hemorrhage is not dangerous. Only the symptomatic intracranial hemorrhage is dangerous. So a patient who has any neurological increase in NIH's deficit by more than 4 points or death within 7 days is defined as symptomatic intracranial hemorrhage. So hemorrhagic transformation is divided into early and late depending upon the pathophysiology. We need to know the radiological classification of intracranial hemorrhage. It can just be a small petechiae, which is usually seen in all our malignant stroke if you do a serial imaging. It can be a hemorrhagic infarction type 2, where there is confluent lesion, like this. It can be a parenchymal hematoma, but less than 30%, or a parenchymal hematoma of more than 30%. It is the parenchymal hematoma type 2 that is the most dangerous, although parenchymal hematoma type 1 with a fall in NIH scale is also considered as symptomatic intracranial hemorrhage post-thrombolysis. So there are various risk factors that we know that these can lead to hemorrhagic transformation. But the things that we can touch is an uncontrolled hypertension, hypoglycemia, hypoglycemia. Although various studies have changed all these risk factors or all these warning or all these precaution, but there's still a lot of confusion. So can we thrombolyze despite stroke or despite warning? So this is a study that has been taken from the archive where 6,000 patients had one warning or contraindication and 1,946 were thrombolyzed. So they saw the primary outcome of MRS at 90 days. Most of these patients showed a favorable MRS except for those on dual antiplatelet and mild symptom of NIHs less than 6. But when they saw the risk of ICH within 4 days, there is increased risk of ICH in these patients with a warning. But we have to take this data with a pinch of salt because here even a petechial hemorrhage has been taken as an intracranial hemorrhage. Although the highest rate is age more than 80, presence of dual antiplatelet or patient on oral anticoagulant. Now, further, they did a meta-analysis of 55 studies to see whether there is any intracranial hemorrhage in the presence of risk factor. So the odd ratio definitely showed a positive when there's higher age, higher aspect score. But the most important is in this study, they have given the importance of renal impairment, congestive heart failure, atrial fibrillation, then anticoagulant, which can increase the risk of intracranial hemorrhage. But when it comes to discussion, these associations with these factors were modest and they were unlikely when we take or when we measure individually to predict that these patients will experience an ICH. Most important is hypertension. We need to lower the BP before thrombolysis. We can use IV drugs. Also, some studies say that use of IV drugs to lower BP can increase the risk of symptomatic intracranial hemorrhage post-thrombolysis. So we need to remember the indication. We need to remember the class 3 contraindication. We need to remember the precaution and what are the measures we can do to reduce the symptomatic intracranial hemorrhage. Although no convincing evidence that these people who are at high risk of post-RTP ICH will not benefit from the treatment. So we need to keep this in mind, and just like Sir said, we need not to be so scared about the intracranial hemorrhage that will happen. We need to understand only the class 3 contraindication. So with this, I would like to thank the organizing committee, and this is a race against time. Just like the BFAST is for identifying the signs and symptoms of stroke, I think the BFAST is for us in the emergency department to decide which patient and how to go ahead with the treatment in acute ischemic stroke. Thank you, sir.
I think that was excellent. I think any questions? I think I really liked your two, the meta-analysis of the ICH and then the other one where you looked at in spite of contraindication, don't worry. So I think it's very important, I think we get too much worried about hemorrhage, as Dr. Surya mentioned, in finding reasons not to give, I think, and I think those were excellent. I think I love the first plots.
So I think even if we do a serial neuroimaging in a malignant MCA stroke who has presented beyond the thrombolytic time, most of them goes into hemorrhagic conversions, sir. It's just that we don't do unless they become symptomatic or so. So we need to really not get worried about small petechial hemorrhage or a confluent petechial hemorrhage, sir.
Absolutely, absolutely.
Yeah, can I have a question, please? Yeah. Dr. Suman, you have a wonderful presentation. Thank you very much. So first of all, I have a question for you. You said in your first two slides that you had, once you did the thrombolysis, you had patient didn't survive, two patients didn't survive. Am I right?
Yes, sir.
Right? So is it because of thrombolysis related complications?
No, sir, I think it's because our indication were not right, sir.
No, is it because of within the 24 hours patient had thrombolysis related bleed or hemorrhage?
Yes, sir.
Okay.
One patient had a bleed, one patient must have had a bleed, but went lama, sir, because there was a drop in the NIHS scale.
Right,
And so they
right.
refused to further investigation. But I think the two patients that deteriorated because of thrombolysis, I think we made a wrong judgment during thrombolysis indication, and we mismatched the benefit to risk ratio. So it's very important, I think. That's why I said we have to be fast in that 30 minutes that we get to decide which patient and which not. So at least we get to save the patient or the brain that we try to save, sir.
Yeah, right. So I think there are lots of, physicians and others are there. So I'll just put questions to ignite the mind. Like if Indian Stroke Association president is there. So there is always a debate. Whenever we come for a CMA sort of things, this debate is already going on over the years. Who can thrombolize a stroke patient? Whether I'm authorized to thrombolize or not. That's the main behind, scary. Any doctors in the emergency, they are scared to thrombolize is one of the most important things. When you take a consent, you're going to tell that like 6% is can have an intracranial hemorrhage and this sort of things. And then there is a scarcity. If hemorrhage happens, the scenario in India is, all well. It's not a uniform system. That's very practical, and let's be very honest. But honestly, we need to down the line come from the government or somewhere where ISA and Indian Academy of Neurology can a step. Who can legally take a step to thrombolize? For me, as far as I understand, a qualified MBBS doctor.
Yes, sir.
Posted in the emergency can go for thrombolize. Please correct me if I'm wrong. That's one thing I believe. But how much medically in India, I don't know. That's one thing. Because at the end of the day, neurologist is not there in every corner. It has to be from the emergency doctor who has to take a decision. Yeah, yes, you can discuss with a neurologist. You can send your CT scan if you're not able to, scan this one. That's number one. But thrombolysis is to be given. And let me give you so much of example. There were, as I said, it's not uniform. Months back, there was a judgment came, maybe in Chennai, I'm not sure. Patient came in the ER, and thrombolysis was deferred because consent was not taken, and thrombolysis could not be done. But this was, as per the rule, this should be avoided. You should have done thrombolysis even without consent, and that's what is being done by in Europe. Even for thrombectomy, if I'm not wrong, thrombectomy they don't take it. It's a life-saving procedure. You need not to take consent.
Yes,
we take consent here. In spite of there are so much of confusions and all these things, I think we should come up with some idea where we have to take a step at some point of time. Yes, right? This patient is thrombolized. Yes, for everything there isn't complications can happen. If you drink lots of water, there is a complication. So complication is going to happen for everything. But we are doing what is the benefit versus risk, and that's true that the message should go to also the administrations, because if you have a judge where you say ki, why didn't you thrombolize and you are being punished? And where someone say you are taking thrombolysis and bleeding has happened, and then there are so much medical legal issues. We are in between actually. So you, as a Indian Stroke Association, I appeal to them. It's not only this. They have to take it forward and take a strong step to the government to take a very uniform, where we are very much clear idea what to do, what not to do. Thank you.
Right. So you have put up a very valid point, and I think who should thrombolize? Question is, if there is a cardiac arrest, who should give the resuscitation? So these are sort of an emergency. In one way, you can say it is an emergency. So whosoever is available should take care of that. But I think when it comes to the intravenous thrombolysis, there are certain norms which has to be followed. And I personally feel that any hospital or institute where there is a CT scan, that's a must. The person should be able to understand the CT scan that there is no hemorrhage. The person who is giving IV thrombolysis, not depending on the other, I think he should be able to at least judge that. He should be able to take a decision on common things about, as we said, blood pressure, diabetes. So I personally feel anybody who is well trained to read this could be a general physician or an intensivist who should be able to take the responsibility, number one. For a MBBS to expect, unless he has been trained in the stroke unit, he has worked under the neurologist and he has a backup from some of the stroke expert on the tele-stroke that yes, you go ahead. I think it may be too much because once they start doing something which they are not trained for, may be a problem. But physicians, why? Because many of them are still treating heart attack. Many of them are already been using intravenous tenecteplase for last maybe 10 years or 20 years. So they have a confidence of using it in a person. Whether it was for the heart attack or for brain attack is entirely different. So I think we should at the moment focus on district hospital or a hospital where the CT scan is available, sub-district or PHC, and where the physicians who are able to see the CT scan, understand about the general care for the patient, about the risk factor, and can give it. I think this is my take at the moment. I would think of beyond this, maybe once the physicians are able to take over.
So I think the 2018 AHA guideline has allowed thrombolysis by anybody in the presence of telestroke. You just need a neurologist to interpret the CT scan, that's it, sir, or a radiologist or anybody. And sir, the baseline is only the sugar and the BP and the time. There is no other class 1 investigation that is required, sir. So
Think that even today, out of 4,000 neurologists, honestly tell me all 4,000 are giving IV thrombolysis?
yes, sir.
So let us first tell each and every neurologist to take it forward.
True, sir.
Why even neurologists are not giving IV thrombolysis when patient is coming in the golden hour? Even they are, some of them are older style, are scared. So we must first tell every neurologist that do it. And when they are going to do it, then they will pass on to the other people straight away.
So especially with tenecteplase, I think I encourage all the MD physician that it's a very easy drug and, you know, very simple. It's very different from atiplase, and the fear has gone down by 50% with tenecteplase, which I think the MD physician should just do it without fear. Thank you, sir.
Yeah.
Yes, sir, matter of time, sir.
Yeah, and another question. So you during your presentations, you said some of the patients had, you know, hemorrhagic transformations, and everybody is scared of that. So I feel hemorrhagic transformations after thrombolysis is a normal process of healing. You give a thrombolysis, there's the recanalizations, but the recanalizations may be slightly delayed. There is the infarct area, so there will be recanalizations and there will be hemorrhagic transformation. This is a normal pathway of healing process which is going to happen. And I find in every hospital, not only yours, every hospital, you send the image next day. If you do an MRI then, very interesting, if you do an MRI on day 2 or after 24 hours of thrombolysis, invariably it will be reported multiple hemorrhagic spots or hemorrhagic conversions is seen. Do a CT scan, simple CT scan, you would not see the hemorrhage, number 1. Number 2, if you see a hemorrhage, if it is a HI1, HI2 grade, yes, even PH1, where there is no mass effect, in my ICU, or my ICU team might be here in the critical care, please don't get scared by seeing and bleed there. This is a normal process. If the bleed is having mass effect, then only we are going to, totally stopping the antiplatelets. We continue antiplatelets actually in patients who are having hemorrhagic transformation, need not to be, but you need to take a track, how it is doing, how it is behaving. If you have a mass effect and all these things, we need to come to know. It's not like hemorrhage ho gaya, so haath upar kar do, aisa nahi hai. So we need to understand how much hemorrhage you have, hemorrhagic transformations. Right. Thank you.
Yes, sir, because hemorrhagic transformation, the pathogenesis itself tells us that this can happen without thrombolysis also, sir.
I think we move on.
Yes, thank you, sir.
Thank you.
I congratulate Dr. Sinmon for initiating the thrombolysis program in our hospital. She is from Meghalaya, which is a neighboring state. I think Dr. Nirmal Surya would be delighted to see that the movement has started in other northeastern states as well. And great to hear that a teaching program has also started in neurology. We have all thrombolized with streptokinase without any fear for ST elevation MR, interpreting ourselves without any cardiologists, to be very honest. It's just that the fear has entered more and more as time has passed by, and probably the fear is more about litigation. So if the laws come clear, I think we will see more initiatives being taken in more hospitals. For the same line, talking more about thrombolysis, we have Dr. Manoj Kumar Mahato, who will be talking on beyond the window time. Can it be extended and how to decide on these patients? Because we know a large number of patients do move on, come late from 3 to 4.5 hours. Is there something beyond 4.5 hours you want to talk? I invite him for the talk, Dr. Manoj Kumar Mahato.
Good morning, respected chairpersons and dear colleagues. Today I am talking about acute ischemic stroke thrombolysis beyond the usual timeline, that is 4.5 hours. So, if you go through expanding the therapeutic window for acute ischemic stroke, we are there are a lot of research going on regarding new agents, new approaches, and over a decade, especially for the last 3 years, the individualization of stroke care has revolutionized. And there is concrete changes to acute care happening now. We are doing late thrombolysis for a few selected patients based on the MRI, the diffusion flare mismatch criteria. But one thing is remain same, that is time is brain. So we should not waste time by thinking of the therapeutic module, but we have to go for a specific protocolized treatment. So, what is the evolution of therapeutic window in acute ischemic stroke treatment? If you go back to 1988, patient presented with stroke symptoms. There was a head CT in a few centers in all over the world. It was diagnosed as acute ischemic stroke, and they used to admit the patient, and usually conservative management was followed. So, in 1998, there a bit changed after this permission of the altiplage. By 1995, that it can be used in acute ischemic stroke for thrombolysis. So, but the time window was within 3 hours of last known normal. So, if head CT suggested of acute ischemic stroke, if the patient is eligible for TPA, go for IV TPA. If the patient is not eligible for TPA, so admit for conservative management. If you come to 2008, so that window period a bit extended to 4.5 hours. Again, the protocol almost remains same. Go for CT scan. If it's acute ischemic stroke, assess the eligibility of the patient for thrombolysis. If eligible, give thrombolysis. If not eligible, go for conservative management. So, but by 2018, there is a paradigm shift of the stroke care. After a few endovascular trials, which are very positive, which came around 2015, so it was showing that even we can treat the stroke after 6 hours, we can treat the stroke after even 24 hours. So from that time, the protocol of the stroke treatment has been revolutionized. So if a patient comes with stroke symptoms in 24 hours, what was the protocol? So if it's suggestive of acute ischemic stroke, if the patient is last known normal period is 4.5 hours, the patient is eligible for TPA, we can give TPA or we can send the patient to endovascular shoot. For stroke mimic, we can decide for other therapy, and we should do hyperacute MRI to to segregate the patients or to isolate the patients, whether the patient is having actual acute ischemic stroke or not. So this is the evolution of treatment. You can see. So in 1995, that Altiplase was like got permission from FDA for acute ischemic stroke, and gradually in 2015 there are a lot of endovascular trials which came with good positive results that resulted in good outcome in stroke intervention. And in 2018, we started like thinking of beyond timelines, that we need to increase the timeline of 4.5 hours to certain to extended level. So in 1996, we were IVTPA for less than 3 hours. We extended the time window after RICAS-3 study in 2008, and intra-arterial therapy started around 2013 to 15. And now it's time to extend the time limit, because we already extended the time limit for endovascular therapy for up to 24 hours. Some people are doing even beyond 24 hours in European countries. Now it's time to extend the time window for thrombolysis therapy for acute ischemic stroke. The thing is that if we consider like a patient comes around 4 hours of stroke onset, we usually, if we do thrombolysis with Altiplase, so that Altiplase dose will finish around 5 hours. So it's already extended. I have started the Altiplase therapy at 4 hours, and I am continuing this Altiplase for 1 hour, next 1 hour. So it's already extended. So that means we can do thrombolysis for this kind of patients, which are like border zone patients. And nowadays, after coming of this tenecteplase, we are using tenecteplase all over India. So like we are, and this is very simple drug to administer, and we are giving this drug to every eligible patient. So how we decide regarding this extended time window? We generally decide based on the MRI flare diffusion mismatch for this extended time window thrombolysis. So these are the ESO 2021 updates. If patient comes with acute ischemic stroke for less than 4.5 hours duration, IVT with Altiplase is recommended. If a patient comes with 4.5 hours to 9 hours, thrombolysis is not recommended. If a patient comes with 4.5 hours and with 4.5 to 9 hours, but there is CT perfusion mismatch, or there is like diffusion flare mismatch, the IVT with Altiplase may be given to this patient, but quality of evidence was low, but strength of recommendation was strong. So if a patient comes with like last known OL for more than 4.5 hours and who have MRI diffusion flare mismatch, and for whom MT is either not indicated or not planned, IVT with Altiplase may be given. So, but if there is in patient on awakening from sleep who have a CT or MRI core perfusion mismatch within 9 hours from the midpoint of sleep, and for whom MT either not indicated or not planned, so IV thrombolysis was not given. These are the like questions by the ESO we need to address. Usual recommended dose for IV Altiplase is 0.9 mg per kg body weight, but now we are giving with tenecteplase 0.2 mg per kg body weight as a bolus dose, and that's all for all patients. So extending time window means the salvageability of brain tissue largely depends on the degree of collateral perfusion of the ischemic territory. Individual patient variability in diffusion perfusion mismatch volume on advanced imaging will direct subsequent treatment. Given the recent data, the clinician and radiologist should be prepared to screen and administer thrombolytic therapy or endovascular therapy within 24 hours of stroke onset. Time is surrogate for stroke viability. The majority of individuals, in fact, in a predictable time pattern such that the risk of revascularization outweighs the benefit after 6 hours post-stroke. So many individuals within the extended time window will not have a favorable mismatch, but perfusion imaging allows us to find those individuals who do. So there are 3 scenarios I will describe. So one patient, like if he was last known well at around 8, the patient came to emergency around 4:30. So that means the patient already came beyond time window of thrombolysis. So what was earlier followed, that we will go for only conservative therapy. If otherwise eligible for MT, we will go for mechanical thrombectomy for this patient. Second scenario, a patient at 4:40 p.m. the caregiver discovered the patient and called the emergency physician. So you can see that on say last known at 3 p.m. discovered at 4 p.m. came to emergency at 4:30 p.m. Imaging done at 5 p.m. and TP was administered 5:30 p.m. So it's an like ideal case to administer the TPA. So now last known well a case was last known around 8 a.m. He came to emergency around 1:30 p.m. and we do do this MRI imaging. MRI flare mismatch was there, so we started thrombolysis by TPA. So only one guiding thing for late thrombolysis is MRI diffusion flare mismatch. So this is a therapeutic module for endovascular therapy, like less than 6 hours, NCCT aspect less than greater than 6 and no signs of ICH, CTA revolves LVO, mystactine approach, go for endovascular therapy. And this is beyond 6 to 24 hours, we should go for CTP or MRI diffusion mismatch criteria, and we should go for endovascular therapy. This is for the endovascular therapy. And these are the studies of interventions during extended time windows for acute ischemic stroke. Initial 3 studies, these are based on this endovascular therapy, but you can see this study by Shom, Thomala and Ma et al. All these studies are showing favorable outcome with diffusion flare mismatch criteria. So they mostly targeted the wake-up stroke population. Few trials are going on, like positive trials, THOS trial and Wasabi trials. They are also targeting this wake-up stroke and unknown last known period thrombolysis, last known period time. So there are 2-3 new studies came out recently. One is this is a extend investigators. This study was done by extend investigators. This is thrombolysis guided by perfusion imaging up to 9 hours after onset of stroke. So in this randomized trial involving patients with stroke and salvageable regions of brain detected on imaging, 39.4% of those who received altiplage had no or minor neurologic deficit at 90 days as compared to 29.5% of those who received placebo. So this trial was stopped at 73% of its intended recruitment target. The conclusion of this trial is that among the patients in this trial who had ischemic stroke and salvageable brain tissue, the use of altiplage between 4.5 to 9 hours after stroke onset or at the time the patient awoke with stroke symptoms resulted in a higher percentage of patients with no or minor neurological deficit. But there was more cases of symptomatic hemorrhage, cerebral hemorrhage in this altiplage group rather than the placebo group. Another study, the timeless study, this study recruited tenecteplase for stroke at 4.5 to 24 hours with perfusion imaging selection. So their conclusion is that tenecteplase therapy that was initiated within 4.5 to 24 hours after stroke onset in patient with occlusion of the MCA or ICA, most of whom undergone endovascular thrombectomy, did not result in better clinical outcome than those with placebo. There is a chance of increased symptomatic intercerebral hemorrhage was similar in both the groups not receiving this tenecteplase and the groups receiving the tenecteplase. And this is the recent study from China. They recruited 516 patients. Their target of the study was that those patients who are not capable to come to higher center. So what will be the treatment protocol for them? That they recruited 516 patients, and 264 patients are randomly assigned to receive tenecteplase and 252 patients receive standard medical treatment. So treatment with tenecteplase resulted in a higher percentage of patients with a modified Rankin scale score 0 to 1 at 90 days than the standard medical care. Mortality was like 13.3% with the tenecteplase group and 13.1% with the placebo, the standard medical group. And the incidence of symptomatic intracranial hemorrhage within 36 hours after treatment was 3% in tenecteplase group and 0.8% in the standard treatment group. So explaining the time window for acute ischemic stroke is time still brain? Yes. Each minute destroys 1.9 million neurons, 14 billion synapses and 7.5 miles of myelinated fibers. We need to think about this neuronal loss, and metrics for acute stroke treatment should be onset to dot time. We need to reduce the onset to dot time, also dot to needle time should be reduced. And we need to work across the departments. Frequent repeated education of the physician and staff is required for this late window presenters, and a valid protocol should be developed in all hospitals regarding the treatment protocol of this late onset patient. So with the individualization of acute stroke care with a longer time window for treatment, we offer a greater proportion of patients discharged to home or inpatient rehabilitation instead of nursing home. However, to maintain optimal clinical outcomes achieved in clinical trials, substantial collaboration is required on both institutional and system level. We must think beyond departments, beyond institutions, and even beyond hospital networks. Thank you.
Thank you very much, Dr. Mahato. You had given an excellent presentation with lot of informations, with optimism regarding the treatment of strokes beyond the window period. Now this subject is open for discussions. Any questions or comments from the audience is solicited.
Hello, I have a question. Do you follow any agent of choice like altiplase, tenecteplase for beyond window, or you whatever is available you do it with extended time window?
No, within time window generally use tenecteplase, and for like borderline case 6 or 7 hours we use tenecteplase.
Tenecteplase.
Yes.
But Indian guideline actually up to 4.5 hour, I think.
Indian guideline is up to 4.5 hours, but you know, if I plan for MT, I generally prefer tenecteplase because it reduces my time. I give a shot of this tenecteplase and I sit the patient to cath lab. That's easier for me to organize everything. Otherwise, you know, if I start altiplase, the thing what will happen? It will take 1 hour, and for MT generally we need at least 30 minutes. Within 30 minutes we can regionalize most of the cases. So we don't want to waste time for that thing. Even the trials are coming out that there is no major difference between this hemorrhage, symptomatic hemorrhage between the tenecteplase group or between the no tenecteplase group. So tenecteplase may be given. Most of the recent trials that are coming, they are showing that there is, though there is no extra benefit, but no harm at all.
Okay, thank you. Thank you, Dr. Mahato. Any other questions or comments from the audience? Okay, so anyway, it's an excellent work. I'm sure by following this principle, you'll be able to help many more patients than what happens in medical science. We treat people and we kill many of them. We do not treat people, then also we'll kill many of them. So medicine is very, very dynamic. What looks impossible today becomes a reality tomorrow. So what you have started today, probably it will open the window for saving the lives of millions of people across the world. Thank you for your beautiful presentation. We move on to the next paper.
I thank our chairpersons and the speakers for this session. And what we have learned is probably individualization is the way forward. Clinical trials do not do that. They will give you 3 hours, 4.5 hours, because they have to have a protocol in place. And we, the treating physicians, will realize over time that there could be people on either side who might do better. For the next session to chair, I'd like to call upon Dr. Vikram Hude, Dr. Somnath Prasad Jaina, and Dr. Debango Bora. If you're here, kindly come on the podium and take your chair. And again, we come to that individualized decision. We have used the NIHS score. I was just talking yesterday, sometimes it's difficult to score that as well. Two people may score it a little differently. And here we are going to talk about thrombolysis in low NIHS score, how to reach a decision. And for that, I'd like to call upon Dr. Apratim Chatterjee.
Very good morning to all of you, respected seniors and chairpersons, and special thanks to Dr. Biplav Das and the whole organizing team for this excellent conference we are having here. So today my talk is on the thrombolysis in the low NIHS scaling for stroke, and this is a special topic because with evolving times, we have seen that guidelines are to be followed, but cases are to be individualized. So we'll start with what the urging questions are, move to evidence, then maybe move on to some cases. So can you see the presentation? So somebody has to show the presentation. Presentation is not being portrayed. ये वहाँ पे नहीं आ रहा है ओ ये आ रहा है ना ठीक है okay. So we have a very famous saying in Bengali, so I am a Bengali, which is said like Mosha marte kaman daga, which means that sometimes it's like bringing a big firing a cannon for killing a mosquito. So is it like that? So low NIHS stroke may not be that disabling, may be disabling, may not have a huge deficit for the patient. That is why it is a low NIHS stroke. And then should you thrombolize? Should you at all attempt to reperfuse the vessel? So, but then why are we to discuss about this issue if it is not that important? Because it has been seen that minor strokes, which as defined as NIHS less than 5, they constitute almost half of the ischemic stroke cases. 1/3 of such stroke patients, though considered too mild for thrombolysis, were actually diseased or disabled at 90-day follow-up. These patients may have a risk of stroke progression, and therefore reperfusion is an important consideration for these patients. So what are the scenarios we may face when we have a patient of low NIHS? The first, is it a disabling one or is it a non-disabling one? If it's a non-disabling one, is it having a large vessel occlusion or it is without a large vessel occlusion? So this is the NIHS stroke scale, and it's an 11-point scale. We usually are used to define also the disability, we will come to that, based on these points. But mind you, these may not be all inclusive, and strokes may have significant disability even with normal NIHS. For example, a patient having only facial palsy, nothing else, no weakness. You may have a NIHS stroke scale as less as 3, 2 or 1. You may think that okay, it's a less of an NIHS, why should at all I reperfuse? Now think, this is the face. A face as important as in this person, and having a disability even though minor to you may not be minor to her or to her career or to her image. So it's a huge disability. Contrary to my face, where it's such, it doesn't matter how it looks. Or suppose you have a person who is a driver, even say by profession, or it's his or her need, and you have a vision like this, so difficulty in vision, nothing else, no weakness, nothing, everything fine. This is significant disability for her profession, for her daily needs. a person as high cognitive ability as professor, but the other image showing dementia, you know the famous movie called Black, and a person having cognitive disability post-stroke, having other things improved, is a significant disability of a person of this caliber or a person involved in academic activities or in cognitive abilities. So even these things are not well portrayed in those 11 points of your chart. So NIHS should not be the only criteria for assessment of your decision making of whether or not you should give importance to open the vessel up. Now moving on to evidence. So the first very important study, or rather the randomized control trial, came in 2018, known as the PRISMS trial, which there was no confusion if there was disability, which we have already demonstrated that significant disability, you should thrombolize. Question is, what about if it is non-disabling stroke? So trials started coming up. The PRISMS trial was one such, where it assessed functional outcomes in non-disabling strokes, and it assessed between the alteplase group versus the aspirin group, but clearly did not demonstrate a significant benefit for alteplase with minor non-disabling acute strokes. Remember, this study was halted before. The point which was raised was delayed recruitment. Multiple criticisms came by, though this was a very well standardized RCT, that why it had to be stopped. Perhaps not in favor of alteplase, perhaps not in our economic favor. That is why perhaps had to be stopped. But the important point is no added benefit. Number two, significant hemorrhagic rate. Now, imagine a patient with a minor non-disabling stroke, you are reperfusing with alteplase, and suppose he lands in those 4 patients out of those 100 having a symptomatic hemorrhage. It is difficult to justify. So, this was not having any extra benefit in that trial. So, next was a very important trial, 2023, the Aramis RCT, which assessed and which had a very important message that the dual antiplatelet therapy compared with intravenous alteplase, it met the criteria of non-inferiority at 3 months. So even in minor strokes which are non-disabling, you may have almost a similar sort of an outcome with dual antiplatelet with lesser chance, slightly lesser chance of symptomatic bleeds. Then came the Tempo 2, this time in ESOC it was also discussed, where tenecteplase was tried in minor with LVOs. Again, no benefit, possible harm from treatment with IV tenecteplase. So patients with minor stroke and intracranial occlusion should not routinely be treated with intravenous thrombolytics. Now, can you predict that these are the minor strokes with large vessel who may have further deterioration or early neurologic deterioration or progression? Yes, if it's a proximal occlusion or if it's a large thrombus burden. These are the patients whom you might consider reperfusing in a minor non-disabling stroke. So, this September issue of ESO published this meta-analysis, which I found very useful to discuss. It accumulated all the data we had so far in minor non-disabling strokes, including the RCTs. You had 1559 patients in the alteplase group versus 1205 patients in the control group, and alteplase did not provide additional benefit compared to the medical care without alteplase. So, Khatri et al. RCT of prisons, Chen et al. Of Aramis, and multiple retrospective and prospective observational studies were brought in, and this meta-analysis had something important message. When considering reperfusion therapy, differentiating between disabling and non-disabling is important. Remember, the trials had various criteria of classifying disability. That's why I spent 3 slides in describing how disability looks. So in prison's trial, it was said that if a deficit, if unchanged, would impede the basic activities of daily living, it is disability. In Aramis trial, it showed that it was based on elements of NIHS score. However, consultation with the patient or available family member also should be taken into consideration considering the disability. So disability criteria varied among trials, and moderate to severe leg or arm weakness, total aphasia, visual field cuts might be considered clearly disabling even though an NIHS of less than 5 is there. So it is very clear, NIHS, it doesn't capture all disability, cognitive function, truncal ataxia, depression, not captured. Significant ADL can be hampered. But one more thing needs to be pointed out. So you can argue NIHS of 1 or 5, 1 to 5. What about 4 to 5? What about even in the minor group, the higher NIHS? What to do with them? So the pooled data revealed no additional benefit even though a small group in this study. However, it had no added benefit with IV alteplase compared to conservative management. So minor strokes may be that with LVO may be the tip of the iceberg. 10% patients may have LVO with mild deficits. Early neural deterioration may appear in 20% in untreated. Low NIHS in M1 occlusion, not rare. IVT may not also be sufficient. So some data also for EVT for this group are coming up. Just 2 slides for the guidelines. So what does the guideline say? For the ESO till now, for acute minor disabling stroke, less than 4.5 hours, yes with thrombolytics. For acute minor non-disabling stroke, no thrombolytics, but consensus statement says that if you are having a large vessel with this, the expert consensus panel had a recommendation to go with thrombolytics. So for patients with acute stroke, less than 4.5 hours, rapidly improving sign who are still disabling, for them also all thrombolytics can be used. 8 out of 9 in the expert panel gave the opinion. So this was also held over in this ISOC meeting. What does the AHA guideline say? Almost similar. For till 4.5 hours, yes. For non-disabling strokes, no. No consensus statement like ISOC. Just 2 cases to demonstrate decision making. The first one, 48-year-old male, came within an hour. He came because his wife was a nurse, very well primed. Themselves said, sir, it's a stroke, look at it. Only facial alleviation and slurring of speech, NIHS was hardly 3. Now in our hospital, in the stroke pathway, we have CT angio at the same go. This was a CT scan. Something interesting you can already see here. And the CT angio obviously shows large vessel involvement, and not only that, tandem occlusion. So right at the origin of the ICA and at the terminal part. Now, what to do? We are an empty capable facility. So whether to call those questions came, but talking about thrombolysis here, we thrombolize because we follow the bridge protocol, and we did it with tenecteplase. And just after the thrombolysis, even the facial deficit and the slurring improved right at the emergency with no new disability later. Not seen? CT next day. However, you can see some hypodensities in the right temporofrontal cortex, though it was not significant disability for the patient. Patient was discharged, even joined his profession as a school teacher. No slurring remaining. However, the CT scan the next day and the CT angio. See, had we not thrombolized this patient, thinking it was a minor stroke, not even done a CT angio, what would have happened? The artery would not have opened, and you see the ongoing progression in the imaging, the patient would have deteriorated. So at least you could have opened the large vessel even with a single tenictyplase. So just last 2 minutes. Now, you may not open the full vessel. The full vessel did not open up. The distal M1, the clot was there, occlusion was there, but the brisk collaterals came in and the major deficit was altercated. So this is one such scenario, and the last scenario is this patient, where the first image I am showing you is the image she came with, like it was an M1 occlusion, we knew from the beginning, but it was such a mild deficit. She was able to lift her hands, there was no weakness, and there was only mild facial droop. That was all the weakness she was having. Now she came to our hospital in the evening, we examined her, followed her, till night, 12 o'clock, everything was fine, just keep her, I told her, okay, supine bed position, the sit-up test was negative, probably collaterals are so good, so low NIHS, we are not doing anything. We are going keeping a close watch. At 4 o'clock in the morning, I get a call from my hospital, immediately do come down, there is a deficit. So when we went, we did a CT, there was already basal ganglia hypodensity building up. Immediately it was beyond the window, so immediately we had to take for the cath lab. We opened the vessel, but after 4 hours, the area which had already the infarct formed had a reperfusion bleed. Though she was discharged, but this could have gone bad. So the idea is to conclude that minor stroke, if disabling, thrombolize, no doubt. In non-disabling cases, if it's an LVO, you may still thrombolize, still think. Still individualize each patients and assess the disability not only by NIHS but also by profession, by experience. Remember, 5 fingers, each individualized function, each individualized identity, and each stroke case is different. Try to identify the pathophysiology, the functionality the patient has to go back to, and then take the decision. Thanks a lot.
Yeah, excellent presentation, Pradeep. So I think majority of physicians are here. How many of you like NIHS scoring? Can you lift your hands? See, no one likes. Correct. So in cardiology, there is no scoring as such. Correct. So if a patient comes to you with chest pain, you do ECG and thrombolize. So in neurology also, we are evolving to that. So what is required when a patient comes to you with stroke is only 2 things. One, check RBS. If it is hypoglycemia is not there, do a CT to rule out bleed and thrombolize. Okay, so don't go into this high-end discussion about low NHS, LVO. You will get confused, and at midnight, 1 o'clock, if someone calls you, you tell you go to Biplab, he will do everything. Okay? So we don't want that. We want you to take away the fear. And you thrombolize. Nothing will happen. If you thrombolize 100 patients, 1 patient or 2 patients will develop bleed. So you remember these things. Do a plain CT, do RBS, check BP, and thrombolize. Okay? Remaining majority of those contraindication, low NHS, see, I am an interventionist. For me, 2 fingers are important. Correct? So middle of the night at 2 o'clock, you can't decide whether it is disabling, non-disabling. If a patient has come to you, you thrombolize. Now people will ask question, why you are not thrombolized me, rather than they will, if means afterwards, why you are not thrombolized, if they ask you, it is very difficult to defend yourself. So in that way, please don't think about NIHS, don't think about LVO, all those things. Okay, if a patient has come to you with disability, okay, and check RBS, check CT and thrombolize.
So, sir, it's an excellent talk. As I say, is NIHS score. So, in this part of the Assam Northeast part, maximum, this NIHS score basically done by the emergency physicians. Like, I am an emergency department, doctor, physician. So, maximum emergency department don't have NIHS scores scoring industry. Even in Apollo we have. But most of the, I don't know other hospitals, but most of the hospital they don't. And the next catch is that most of the hospitals physicians, they don't know how to do the NIHS score also. And it is very difficult in the do the NIHS score when their patient is aphasic. Even there are lots of catches there. So by fall, they make it more high and make it more low also. So I think thrombolysis should be done based on the SR8 in the 3 parameters is RBS, BP and the CT scan. So if we stick on these parameters, then definitely the thrombolysis. And next thing is the fear of doing the thrombolysis. Main thing is the benefit. Last few days ago, I shared a case. Few days ago, one surgeon came with a paralysis of the left hand. He is a doctor. I asked them go for the thrombolysis. He himself refused to do the thrombolysis because he thought just a minor, I have paralysis only. After doing the physiotherapy, it will be, but I don't want to do the thrombolysis. The doctor is refusing to do the thrombolysis. How can we expect the other common people to go for that? That awareness also is very less. So I think we have to do, we have to go more further for the awareness, and we have to treat the emergency physicians basically for the thrombolysis and many things. So thank you for your presentation. Thanks.
Can I have a question, please?
Yeah. Any questions for? Oh, yeah.
Question means, as Dr. Vikram has already highlighted, one of the most common thing which find, among us, neurologists, neurosurgeons, physicians, ear medicines, like this patient is having mild weakness on the right side or left side. I've done a CT scan, and CT scan is absolutely normal. So that's why I have not done thrombolysis. That's the main, in every some of the things where it comes up, the main, CT scan तो normal था, उसको thrombolyze क्यों करना है? CT scan तो normal था, किसी को stroke है, और भी जल्दी करना है. CT scan में आपको कोई भी infarct का signs आ गया, ischemic changes आ गया, which you can easily make out, then it's a relative contraindications based on so many other things. Then comes the complex scenario, कि करना है नहीं करना है. So one of the dictum we need to understand, if patient is coming with in your ER or in your clinic with symptoms of weakness, you should take these patients for thrombolysis. It is normal, that's a very good sign. Also, another dictum is that you can thrombolyze stroke mimic. It's better to over thrombolize rather than not thrombolize thinking, no, this is a stroke mimic and it does not look like a stroke. Later on, it's a stroke. Okay, so thrombolizing and authorizing a person to thrombolize by you, it may be a stroke mimic. No medical legal issue. Medical legal issue will come if you miss to thrombolize a patient who is actually a stroke patient. I'm telling you this is because it's a very simple. It's like a stroke cardiac patient with chest pain coming in the ER. And if you don't thrombolize and if you refer this patient to other hospital, every patient is now, every people is getting, having this idea. They know what should be done and you have missed to do that. That's a medical legal issue is going to happen. And same thing is happening also now. It will be more now if you don't thrombolize in a patients who are eligible for thrombolysis in a stroke patients. That's I think one message should go. Apratim is a wonderful, portrait of images and other thing. Well, lovely presentations. Just one thing I just add. Suppose you have a MCA, a floating thrombus, and NIHS is low. That's a floating thrombus. Sometimes there's a dilemma. Would you like to go for thrombolysis or thrombectomy in such a scenario?
That's what I demonstrated. So we demonstrated 2 such cases. So if it's we can see that M1 is occluded. What we do in our protocol is quick CT angio because there's hardly it's the same go. We don't wait for creatinine, nothing else. So hardly takes 2 to 4 minutes time, and then you get to know whether how much amount of the what is the aspect score, and whether you have an LVO, whether you have an occlusion. So you have an occlusion at the M1 and you have a low NIHS, very low NIHS. I would, if it is within the window, I would take the decision by the same way. Like if it is causing, even if it's a low NIHS, if it is causing disability, I would allow thrombolysis. If it is non-disabling, absolutely non-disabling, I would keep a close watch. If there is, I would do a sit-up test to see the collaterals are failing or not. If it is at all having any signs of deterioration, I would go for revascularization, either in the, if within the window by thrombolytics. If, if it satisfies my thrombectomy criteria, I will go for thrombectomy. So reperfusion always better. Obviously, there is always a chance that the patient might bleed post thrombolysis. There might be a possibility of something going wrong even in a low NIHS for after a thrombectomy, but that is very minor in in good centers, and I think we should not deny the patient of. That's why I showed two scenarios, two different results.
Hello. Do you consider between low NIH in anterior posterior circulation?
Yeah, so all the data which we have showed are predominantly of the anterior circulation, because that's what the evidence is. But the posterior circulation things are pretty tricky, because it's the symptomatology for posterior circulation presentation is so huge, and it has been found that patients presenting initially only with vertigo symptoms, gradually building paresis, often get missed, very commonly missed in the emergency, even as a stroke. So in the posterior circulation, taking these decisions merely by NIHS won't be right, number one. Number two, that if it's large vessel in the posterior circulation, you have to open it up. You have to open it up, whether it's by thrombolytics or by the thrombectomy. And with the more and more trials, being an interventionist, however, I would press on the idea that in our intervention field also, with more and more days passing, we are seeing that even if having even in CTs having already hypodense areas, we are having good results at the end of 3 months if we revascularize. So revascularization should not be denied at any cost.
Any guideline for low NIH thrombolysis in pregnancy and menstrual phase?
I could not find. I'm sorry.
Thank you so much for your presentation. We will invite next.
So we have been talking only of hemorrhagic complications, but let's talk about hemorrhagic stroke itself. Let's get a surgeon to talk about it. I invite Dr. Shamim Ahmed, who is a consultant neurosurgeon at my hospital, Apollo, on hemorrhagic stroke, indication for surgical intervention.
Good morning, everyone. Today's topic is very common in neurological forum, basically a hemorrhagic stroke. My part is basically a decision making. As a surgeon, should we go for the surgical intervention of a stroke patient, hemorrhagic stroke? And if yes, what is the type of surgery we take and what is the timing of the surgery? So hemorrhagic stroke is basically bleeding into the brain by rupture of the blood vessels, and approximately 10 to 15% of all stroke belong to the hemorrhagic stroke. Hypertension is the most common cause, as you all know. It is one of the deadliest among all the stroke types in terms of morbidity and mortality. Unfortunately, it is higher in the Asians. Northeast India itself is a hub for the hemorrhagic stroke. And hypertension basically is the most common cause of the thing. So common pathophysiology is basically long-standing hypertension and cerebral amyloid angiopathy. These constitute the most of the hypertensive and the amyloid angiopathy-related bleeding. The secondary pathologies may be the vasculopathy, or maybe some hemorrhagic conversion of a stroke, or maybe venous thrombosis or coagulopathy. But common spectrum is chronic hypertension and the amyloid angiopathy in elderly. So what happens in a long-standing hypertensive patient, the lipohydrolysis, and that lead to a macroaneurysm in the distal vessels, and sudden bouts of rise of blood pressure can rupture, and that causes the hematoma formation, and then usually the ICP rises and the secondary injury settles. The most common already discussed these parts, it's putaminal bleed, but other part like a brainstem, thalamic region, posterior fossa are also not uncommon. So algorithm for management is based on the ACLS protocol, any trauma protocol, or maybe emergency neurological protocol. But few things we have to keep in mind. One is the assess the alertness, because this is very important to decide about the clinical thing. What is the optimized blood pressure and any baseline coagulopathy that need to be corrected. Other major concern from surgical point of view is the hematoma expansion, because a hematoma may be small, but over a period of 3 to 6 hours, it might expand, and most of the hematoma expansion is seen up to 3 hours. And nowadays, with the MRI finding, we can definitely judge what is the hematoma timing, whether it is acute or subacute or chronic hematoma. Even CT scan also can give an indirect idea whether it is a hyperacute or a chronic hematoma. CT angiography finding a spot sign is very important, because that usually signifies there is probably a vascular lesion. If the hypertense finding is there in the hematoma core, that might be due to some underlying vascular pathology. And calculating the volume is a Broderick's formula that we know. ICS score is one thing that if you can count based on the ICS volume, the ventricular extension, whether tentorial location is present, whether it's elderly above 80 or the GCS score. So this ranges between 0 to 6, and 30-day mortality can be counted from the ICS score. So basic part of the ICS management is blood pressure reduction, anti-edema measures, reversal of coagulopathy, and probable surgical intervention in some cases. So surgical involvement as a neurosurgeon in a hemorrhagic stroke is basically mostly for the prevention or treating the secondary damage caused by the hematoma due to raised ICP, and also any definitive leak is there, so we can treat it either endovascular or surgically. So usually the surgical indications are there. It might be a combination of the few parameters like a hematoma volume more than 30 ml in a supratentorial location, or maybe a midline shift of more than 5 millimeter, brainstem compression, deteriorating neurological status, whether it is a superficial or deep. Again, controversy is there in the deep-seated hematoma, and age, comorbidity, and other factors are also important. Timing is another factor. I'll go through the literature, whether they were doing the ultra-early surgery, or delayed surgery. That again, a variety of recommendations are there. So again, these remarks suggest that the early surgery performed between 6 to 24 are probably the best timing. But again, there are proponents, opponents for the ultra-early and the late surgery. And the newer thing is a stereotactic surgery. Within 48 hours of surgery, if you do some navigation-guided endoscopic evacuation, it has some promising values. So the spectrum of surgery can be open craniotomy to a decompressive craniotomy with or without hematoma evacuation, maybe a navigation-guided stereotactic endoscopic evacuation, and maybe minimally invasive catheter placement and targeted thrombolysis. So what are the recommendations? The trials of surgical evacuation that is initially we found in 1961, they have clearly showed surgery has rather worsened the outcome in the deep-seated hematoma evacuation cases. And in 1989, another that endoscopic surgery came, they initially promoted that carries a better outcome, but at the same time, another group found the surgery over the conservative management has no benefit. So this is the 2005 multicentric trial, the STEACH trial. In this found, they have conducted this trial over more than 1,000 patients in 83 centers among 27 countries. And these are randomized studies. What they found, there is no overall benefit of early surgery when compared with the initial conservative treatment. And then the STEACH 2 trial came after almost 9 years in 2013. Again, this is from 27 countries in 78 centers. And So stage 2 trial again says early surgery does not increase the rate of death or disability at 6 months and might have a small but clinically relevant survival advantage for patients with spontaneous superficial ICH without any intraventricular hemorrhage. So there is probably some benefit in superficial hematomas if you do early surgery. So next is the endoscopic evacuation. That is in 2008. They say that image-guided, basically navigation-guided endoscopic hematoma is a promising minimally invasive surgery, and they have defined some criteria whether this is better or good. But as per their studies, it seems to be some benefit is there, especially when the hematoma is more than 60 ml, and when they are trying to reduce at least up to 30 ml, 50% of the hematoma evacuations. So minimally invasive stereotactic puncture and thrombolysis could be indicated in patient harboring hematoma between 30 to 60 ml. And in the context, the same volume range cites patients in an admission score of GCS of 9 to 4. So not in a very good comma score, they try to evaluate this thing. Infratental hematoma, rather the controversy is less. The indications again vary based on the site of the bleeding. Usually cerebellar hematoma more than 30 millimeter or a volume of more than 15 ml with deteriorating neurological status, brainstem compression, associated hydrocephalus, they are the candidate for the surgery. So meta-analysis that matched the 152 patient who had surgical hematoma evacuation with 152 patient who had a conservative management. So in surgical group, they found the increased probability of survival at 3 months, and overall probably favorable functional outcome is there. In supratentorial hemorrhage, in deep-seated bleed, the controversy is still there, and indications are not very clear as of now. So reserve the surgical therapy for patients with life-threatening mass effect from the supratentorial ICH. And the routine recommendation is not advocated in surgical evacuation for supratentorial hematoma. So again, open craniotomy, stage 1 and stage 2 are well described. The stage 1 says no benefit, stage 2 say in superficial bleeds, ultra-early surgery may have some benefit. The major advantage of this, rather the proponents for this study, they say it is a well-designed, well-powered studies and multicentric, multinational there, and very low rate of missing any follow-up data. But the major weak point that they have taken the patient, approximately 1/4 of patient, 25% of the patient, they underwent initial conservative group, and when they deteriorated, they are taken for the surgery, especially when they are more than 50 ml of the hematoma size. So role of open craniotomy for early hematoma drainage after intracranial hemorrhage is remain a hot topic for debate. Neurological plasticity is another thing. It might be different for different patients. Decompressive craniectomy, again, this is another thing that is taking interest nowadays, whether we do only decompressive craniectomy or with or without hematoma evacuation. MISTI trial is basically they have tried to evaluate in 506 patients in a minimally invasive way. The catheter is placed and to decrease the hematoma size and by a targeted thrombolysis. So now this study is important in 2019. They have a multicentric study. Originally they have collected the data from the stage 1, stage 2, and the stage trauma protocol, the randomized trials, where this is a standard meta-analysis shows the more favorable outcome in patient, non-significant although, with a surgery presenting the GCS of 9 to 12 in a moderately comatose patients. And the ranked analysis shows the similar pattern of result for both spontaneous and traumatic ICS. Surgery was harmful for small lesion, whereas increasing benefit for the larger volume of the hematomas. So in conclusion, this meta-analysis with categorization showed significant benefit of surgery when the hematoma is big and the GCS score is between 9 to 12. In 2022, 2 years back, this guideline for the management of patient with the spontaneous ICH, and they also showed the minimally invasive procedures, the supratentorial hematoma and the intraventricular hemorrhage compared to the medical management has demonstrated some reduction in the mortality. So this probably have evidence of the improved functional outcome in these patients. And other are the basically minimally invasive procedures like intraoperative stereotactic computer-guided tomography, including the endoscopic surgeries. They also tried to evaluate ICH of more than 20 ml, ICTAS within 48 hours of evaluation, and initial data were promising. A variety of studies are there, and most of them are now coming up with a minimally invasive surgery in the stroke hematoma cases, with a conclusion remain favorable or doubtful. And these are the recent multicentric trial going on. This is the INVEST trial, SCUBA, DIST, MIND trials. These are ongoing. EVACUATE and MIRROR trial also enrolling the patients. The data, the final outcome is still not arrived. So what are the open-end questions from the neurosurgical point of view? What is the optimal time of this hematoma evacuation? What is the maximum clot removal amount? Should I remove radically or in just evacuate decompression? And what is the optimal hematoma location we should target? Superficial, deep-seated, posterior fossa. And candidates who are likely to respond to minimally invasive surgery. Is it for all or some relatively late presentation cases? So what I can derive these take-home messages that meta-analysis showed more favorable outcomes, although non-significant, with surgery if the GCS presentation at time is 9 to 12. And corneotomy for early hematoma drainage after intracranial hematoma remains a hot topic for our neurosurgical patient, because we get referral, should we go for surgery, should not we go. And minimally invasive procedures in nowadays, they are showing some reduction in mortality, although in a class 1 evidence, the data are still doubtful. And for all surgery, for all kind of hematoma, surgery is routinely not recommended. And coming to the recent advances, probably navigation-guided endoscopic surgery has some promising role in future. Thank you.
Thank you for your beautiful presentation. I have a few questions which are pragmatic in this regard. Do you prefer to evacuate hematoma in all cases, or the side of bleed decides whether you remove it or not? Whether a left side basal ganglia bleed, you will remove it? And whether you use any specific hemostatic agents if at all you do an endoscopic procedure?
Yeah, first of all, routine hematoma evacuation, spontaneous hematoma evacuation, we don't do. It's not recommended. We do operate, we are a little bit more towards surgical candidate if the hematoma is large, the comma score is good, patient clinical sensorium is not that bad, 9 to 12, and if it is in the dominant side, non-dominant side, and if the hematoma is superficial location, and in posterior fossa. In deep-seated hematoma, we usually reserve not to go ahead for surgery. Coming to right to left, yes. Right-sided, we should be more aggressive. Left-sided, again, you have to see the status, where it is located and whether the presentation is, other parameters are suitable for surgical candidate or not.
Excellent presentation. I have one question. How soon and how fast you need to reduce the BP?
Timing of the surgery.
Blood pressure, how fast you need to reduce and how low you need to reduce?
Yes, sir. That, again, we initially optimize at the earliest if possible. If we are planning for surgery, blood pressure optimization is required at the earliest. But based on the critical care management, how fast they can do it. If you try this, hydrolyzing is one option. We found quite good blood pressure reduction. But how fast is tough for me, but definitely in hypertensive crisis, we don't like to go for surgery.
Vikram, I think there is a seminal paper in ICH, which was published in 1990s. Everybody should read it. The moment you start reduction, exactly opposite of ischemic stroke, after intracerebral hemorrhage, earlier the better. So if patient comes at 2 hours, at 3 hours. So I think I would strongly recommend you to read the paper from the Cincinnati group, whether what happens when 1 hour of somebody arriving, how much does the hemorrhage increase? And if you look at within 24 hours, there is a 40% increase in hemorrhage. The battle is lost. So the earlier the better. I think that's probably if there's one paper you should reach, I think, in intracerebral hemorrhage is that one. Any comments? Why wait? Not even a minute.
Correct. So I think there was a recent trial on the ICH and early reduction in the blood pressure. So that's why I just asked.
Yes, sir.
Very good, Dr. Samim. Your paper had lot of useful information. It's a very good review. Thank you so much.
Thank you,
for
sir.
sharing so many informations regarding this very important problem. We are still not sure whether we are doing justice to these patients by not operating or by operating. It's a big dilemma. When the STITS trial was being undertaken, Professor Mandelo, who was my contemporary, we met in Heidelberg. Then he was preparing for this trial. We were a participant of that. And Professor Mehta, my senior in AIMS, was the largest contributor to that trial. And you have displayed the results of that. Then after that, the STITS 2 has come. Still we are in a dilemma. I'd like to know your personal experience. How many of these intracerebral hematoma you have operated? And what is your recommendation? I stopped it in my hospital. I told my neurosurgeons that I cannot bear this pain. You are operating on this patient, he remains in the hospital, he becomes vegetative. Who takes care of him? Who bears the financial burden? It's a big dilemma. Then consciously, we stop doing surgery for these patients. Even in STITS 2 trial also, I called up Mandelo for one of the patients who stayed in the hospital ICU 3 months. Without surgery also, he would have stayed. That's a different story. I asked him, who bears the cost of these patients? Mine is a private hospital. It's not a public hospital that it runs on public money. He said, we can't help. Medical Council of Great Britain do not help patients outside Great Britain. I said, then I will not be a part of this trial. I withdrew from the trial. So what is your personal experience? I'd like to know how many you have operated and what is your recommendation today? Forget about all these papers.
Okay. I think based on my small experience, deep-seated hematoma, elderly person, definitely no. Superficial hematoma, younger person with a GCS score of 9 to 12, if it is a mass effect is there, I like to go for surgery. Secondly, posterior fossa bleed, cerebellar hematoma, probably the threshold is low for me. Overall outcome is, as you said, is really disabling, whether immediate mortality or a long-term disability. Who will take the burden of this? It is not only the successful discharge from the hospital. What is the long-term thing we are giving by doing this surgery? Increasing the morbidity, or you are delaying the death process? Thank you, sir.
Sir, I think in Calcutta and this side, hemorrhagic stroke is more common than ischemic?
Yeah, I'm going to deliberate on that. I'll share my experiences.
Okay.
From Calcutta, there was a landmark paper was being published by Syamal. He's no more today. He was the head of the Department of Neurology in Bangalore, okay, the alumni of PGI. So he did that study, got it published in the Stroke Journal. So there also, he revealed that the intracerebral hematoma number is almost equal to the number of ischemic stroke. Before that, Guwahati from our side, we established that, yes, it happens. So I'm going to present a paper, probably. Okay. I'll share my experiences.
And that is because we met one of the minister from Northeast. He was in Delhi. He told that is because of the excess salt consumption here?
We don't know. We don't know. Excess salt consumption is clear in 2 areas. One is the tea garden. The tea garden laborer till today mix salt in tea instead of sugar. So naturally salt consumption would be higher, number one. Another, when I did an epidemiological survey in and around Kamakhya temple, there the Kamakhya Prasad is being distributed every day. So Nirmal also went there today in the morning. So during noon time after puja, they will distribute prasad. And with prasad, they will give salt, plenty of salt. So I got lot of hypertensive patients in that area. But it does not mean that we get too many stroke intracerebral hemorrhage from that area. That's a vicinity of around, say, 2,000 people. I did that study going house to house. We could not establish the direct relationship. But there was an ICMR study being published from Assam that is called, what is that called? What autopsy study. The most common cause of death in the northeast region was stroke. So cancer comes next, first comes stroke. That is true. Even yesterday, when we are in the probably last phase of our year, so we are discussing, so out of my batch of 100 whom did MBBS together, how many of us are alive? How many of them passed away? And because of what? Then we were discussing that the most common cause of death in this region, whether you are a doctor or not doctor, is stroke. That's true. It's a very dominant problem.
Yes. Thank you.
Thank you so much, Dr. Shamim. With this, we close this session, and now we move on to the panel discussion, which is all about individualization, my stroke pathway. And for the panel, I'll call upon Dr. Vikram Hudaid. Yeah, you can stay back. Dr. Anand Vaishnav, Dr. Apradim Chatterjee, and Dr. Numal Bora. Yeah, Biplav has asked you to be in the panel. Okay, I think the panelists can start.
Yeah, good afternoon, everyone. So it is a panel discussion and it is interactive. Okay, so we want to know from the audience how many people are thrombolizing for stroke. Can you raise your hands? Okay, I think around 7, 8. And how many people have access to CT? CT is available in your center, I think. Okay, so all of you who have access to CT are thrombolizing? Or few people, you have access, but still you are not thrombolizing. So what is the hurdle you are facing? Why you are not thrombolizing? So that itself will tell what pathway we need to follow. So pathway in stroke is outside the hospital and inside the hospital. Okay. So outside the hospital, because it is a painless condition, and as sir told, it is a leading cause of death. So I think we should have good network of ambulances who will recognize the stroke, and they should shift to stroke ready hospital at least for CT and thrombolysis. So it is an important topic. So, and thrombolysis in India, it is more, thrombolysis is a old topic now, means it is more than 20 years now. And in India, less than 2% of patients are getting thrombolysis. Okay, so what are the hurdles? The hurdle is, it is a painless condition. Okay, people don't recognize the symptoms. Okay, people don't know that it is a treatable condition and it is a preventable condition. People don't know what to do next. So after recognition of symptoms, calling the ambulance, shifting the patient to the stroke center, and in stroke center, what we need to do. So those things we need to discuss. So as a community, that's why I think Dr. Nirmal Surya sir is going all over India to promote mission stroke thrombolysis, brain attack. So it is important as a community, we should know that it is a treatable condition and a preventable condition. So that is for general public. Now coming to intra-hospital stroke pathway. So I want sir to talk about it.
Stroke pathway, okay. So I feel comfortable talking in standing position. That's why I'm standing anyway. So I thought I'll do this in the next 20 minutes when I am supposed to present a paper. But anyway, you have given me an opportunity to have a little bit of more time to share my thoughts with all of you. It's an experience of last 40 years, you can say, regarding the pathway of stroke. First, probably, what you should know, how many people get stroke in your community that you are serving? That's important information all of you should know before you start treating stroke. We have a network of 6 million people here, where we have got direct touch with them on a day-to-day basis. You know 6 million people generate how many strokes in a year? 10,000. So almost 1,000 stroke every month you have access to. Okay, 1,000 stroke every month. This has been proved also. About 25 years ago, Nirmal, we had conducted a stroke awareness program. Entire Guwahati was painted red during that campaign. And out of our own hard-earned money, we spent 70 lakhs rupees. There was a lot of criticism within my hospital. Why did you waste this much of money for creating stroke awareness? Then one of my colleagues asked me, sir, what is the guarantee that you have created stroke awareness? How do you know it? You have wasted so much of money from the hospital. So how do you know? Yes, right question. How do I know? Then one of them suggested that you create a stroke help card and sell this card to these people. If they have become aware of stroke, they will take help of this card. The card was, you buy this card, pay 500 rupees. If you get stroke, come to GNRC, everything would be free. Everything would be free. So, we created a card, cost was only 500 rupees. And in 3 months' time, we sold 100,000 cards. That means a Guwahati city with a population of 10 lakhs during those time, 1 lakh people, 10% of the people purchased these cards. Okay, purchased these cards. Then in next 1 year following that year, we found out that out of these 100,000 people who had procured this card by paying 500 rupees, 163 of them had turned up to the hospital with symptoms of stroke within first 24 hours. So you got the incidence of stroke. We had incidence study before that also. It was validated from this. Stroke awareness is very important. You must go and talk to the community. Stroke pathway number 1. That's what we have learned from our own personal experience. You must go and talk to the community, invest something into the community, in making them aware of it. Then create something which give them confidence to come to the hospital, that I will not have to sell my land belongings and all. 60 million people in this country go from middle class to below poverty line because of hospitalization expenses. Private healthcare is expensive. It is scary. People are afraid of coming to the hospital. Only top 10% of the people in this country can afford private healthcare. I operate a private healthcare system. I know the pains. I know the pains. I know the pains. I understand the agony of managing healthcare in the private sector. Not that smooth. Hardly 10% of the people can afford to spend that money without any difficulty. For 90%, they are clueless where to go, how to go. And ultimate destination is the public hospital. Look at Delhi. Look at my alumni hospital, All India Institute where I was trained, the Guwahati Medical College where I was trained. Still, the crowd has not diminished in spite of so many private hospitals, whether it is in Delhi or in Guwahati. That's the ultimate destinations for 90% of the people of our society. So we must create a mechanism by which you can make it easy for them if you want to get stroke. If you are happy with treating 10% of the stroke that the community has, then you do whatever you are doing. You don't have to change anything. You don't have to change anything. If you want to do your practice based on 10% of the population, they can afford, they can spend money, but there will be intense competition amongst the private healthcare provider who can grab how many pies of this 10%. Remaining 90% cannot come to you. So you have to create a payment mechanism for these people. That is second stroke pathway, affordability. There has to be a solution for affordability. Otherwise, we'll remain doctor for a particular selected community of people. That's not a good thing for any one of us. Number 3, it should be accessible. Awareness, affordable, then accessible. Means there must, now what happens? He thinks that he has stroke, he will contact someone. He will say that, okay, come. You need to do a CT scan. He will send it to a 50 kilometer away for a CT scan, and report would be available after 24 hours. So you lost all the opportunity of managing stroke. That happens in large majority of these patients. So we must create a mechanism by which the moment the person feels that I might be having stroke, there should be a mechanism to carry the patient to a place where stroke treatment can be given. Stroke treatment can be given in a place where a CT scan is available, where the CT scan can be interpreted by the doctors who are available there, and it must remain open 24 hours of the day. 24 hours of the day. I think that should be number 3. It should be accessible. Then, next is available. Available, what is available? 2 things. One, the infrastructure, like you were putting the first question, a CT scan is a must. Some biochemical tests would be needed. Then, manpower. Machine is important, machine can be purchased easily. But having people who know stroke, understand stroke, who can manage stroke, not necessarily he needs to be a neurologist. Around probably 25 or 30 years ago, I was attending a World Congress of Stroke in Edinburgh. There were 2,000 participants. So they said that, okay, you tell us who are you. Then you'll be, I was surprised. Out of the 2,000 participants, from across the globe who were interested in stroke, only 23% were neurologists. Even in global forum, 77% were non-neurologist physicians who were caring for stroke patients. So one need not be a neurologist to take care of stroke, but he should be interested in stroke. He should be able to understand stroke, and he should be able to be available to help stroke patients, because it is 24 hours. So I think that's what is needed. So that is part of universal health care. Let us speak, Nirmal, let us speak universal stroke care. We speak of universal health care. Let us speak of universal health care, or stroke care. Universal stroke care should be awareness. Universal stroke care should be affordable. Universal stroke care should have accessibility. Universal stroke care should have the component of availability, both machines and manpower. That's what I think.
Thank you. So actually, so sir told a very important point, and he has done excellent work. So main issue is in India or all over the world, car insurance and bike insurance is compulsory. Okay, so we need to consider our bodies as a vehicle. Okay, so we do regular health checkup for the car and bike, correct? Every 10,000 kilometers. But yearly health checkup we don't do for our body. We don't buy insurance for our body, which is very valuable vehicle, correct? So government can't provide health treatment for all. So NHS in UK has failed. So it is a responsibility of individual also. So Sir has done beautiful work by distributing stroke card. So in that, you should make them compulsory that every year they should do health checkups. So I think prevention of stroke is more important than thrombolizing or doing thrombectomy. Because by doing thrombolysis, thrombectomy, we can save around 50 to 60% of patients. So it is important in this area, at least to bring down the stroke from number 1 cause to at least number 2 or number 3. So I think in that aspect, because we don't have many stroke units in this area, preventive health checkup is more important, and I think you should make those people who have card compulsory annual checkup where they should check their BP, sugar, and obesity, obstructive sleep apnea, carotid Doppler. These things are more important, sir. And if these things are controlled, you can prevent stroke. Because if it is a number 1 cause of death here, I think all those people in one time they will use their card. So I think it is not sustainable for the hospital to provide free treatment. I think if in India all 142 crore people put money of around 100 rupees or 200 rupees every month, then government can cover the health of all the people. So it is important for people also to know that how they buy insurance for the car and the bike, they should also buy, and because of the numbers what we have, the premium can be reduced significantly. So that is one thing, and Sir told about the outside the hospital stroke pathway. So I request Apritim to talk about, once a stroke patient comes to the stroke ready hospital, and now there are, ISA is doing certification of those stroke ready centers. So how a patient pathway will be there inside the hospital?
Thank you, sir. So as rightly said, though we have various accreditation parameters now very well organized by the Indian Stroke Association. So we have also, I will quote the stroke pathway we follow at Manipal Hospitals, Kolkata, in our hospital setup. So whenever we have developed a sort of a brain code, some code brain, which is a common 4-digit number, which starts right from the time the patient has been picked up by the ambulance care and is being followed up by your emergency, the reception facility, which once the patient is coming or has arrived in the emergency with the features suspected of a stroke, which may be picked up by the emergency RMO or anybody trained in the stroke pathway in our hospital, can dial that number, and immediately what happens is a code brain team is being announced, which involves the neurologist on call, the neurointerventionist on call, radiologist on call, the surgeon, the critical care team, even the technicians, the CT and the MRI room technicians, they are all informed that a stroke patient, a code has been announced, and in our hospital we have kept it till up to 24 hours. So any onset of stroke, any onset of the symptoms of BEFAST, be fast as you know, presenting to the emergency by the clinical feature, and even before going to the CT, if it is having a BEFAST symptoms, the code brain is being activated if the onset is within 24 hours, and then the patient, the timeline has been already given by the ISA guidelines, how much time the emergency team will spend to assess and to activate, and how much time the patient should be inside the CT. So we have 20 minutes by which the patient should be kept inside the, introduced into the CT scan machine. And then inside the CT, usually our stroke team arrives. If it's in the middle of the night, we have a representation, usually the RMOs or some of the team members, who comes down to the CT immediately when the patient arrives in the CT room. And in our hospital, we have kept a CT angio. Still, we don't go for CT perfusion in all the cases. We go for a CT angio without wasting time on creatinine. But before we do that, in our protocol, as I said, a sugar testing is mandatory, and just a quick history taking. 5 key symptoms we said: the onset, any previous comorbidities, any important drug history, and these histories can be taken while the patient is being shifted to the CT scan. So just simple information, we have a stroke group. Immediately the patient's 5 or 6 histories to be given in the stroke group. Patient is to be moved to the CT. CT immediately is to be posted in the PACS, CT angio, and in the group we have all the interventionists, the radiologists, and the on-call neurologist who takes the decision that okay, we can immediately thrombolize. So the stroke nurse usually brings the thrombolysis vial right in the CT room so that the time is not wasted again the patient to shift back to the emergency and thrombolize. So once the CT rules out a bleed, if it satisfies the criteria, you thrombolize in the CT room, and then in the CT angio, if it's a large vessel, the patient is moved to the cath lab if it satisfies the MT criteria, and of course the consent and the other things. We work in a private setup, so the financial counseling is also important. Those things are at par, and then otherwise the patient is taken to the stroke ICU. So this is how we deal with the acute stroke care till up to the ICU.
So this is how a comprehensive stroke unit works. So the stroke care can be divided into primary and comprehensive. So what Apritim told is a comprehensive stroke unit where you have state-of-the-art facility for doing everything. But coming to a primary stroke unit, so thrombectomy out of 100 patients may be required for 5-6% or 10% maximum. So what it is important for all of you to know is a primary stroke unit, okay, and thrombolysis. So that is how things will evolve. So for primary stroke unit, so you can create a WhatsApp group, okay, WhatsApp group of emergency physician, and as Nirmal Surya told, that we can give cover from ISA for if any help is required. So that is how a few states they have started thrombolysis, or neurologist within this city can give you guidance. So what is required? So I told that's what NHS need not be done by a doctor. It is not required. You can train your nurses in checking the NHS. So again, don't go by NHS. So what is required if a patient comes to you emergency is if it is a stroke, you activate the code and you do RBS. You should know when is the patient last seen normal and do a CT to rule out bleed. So these 3 things are will solve around 90% of the problems. Okay, check your BP. So if a patient comes, you ask when was a patient had onset of stroke, check RBS, check BP, shift to CT. There is no bleed, you thrombolize. So this is the fastest way of thrombolizing, and the emergency doctor whom you should train, they should be able to thrombolize. So emergency physician can thrombolize, or the physician who is in that hospital can thrombolize. You thrombolize. So earlier, if a young patient comes, if BP is normal, you can safely thrombolize, nothing will happen. So the chance of bleed is more if patient's sugar is very high, if there is a large vessel occlusion, if the damage is more. In those patients, you should be careful. If he's a young, he doesn't have any risk factor, his BP is normal, his sugar is normal, please go ahead and thrombolize. The chance of him bleeding is very less. Okay, and don't worry about bleed. So bleed, I think it happens in real world experience, it is around 2%. Okay, so it is very, very rare. So please go ahead and thrombolize. So the stroke pathway is, if a patient comes, you check RBS, you do a CT, check BP, last seen normal, and thrombolize. So I think in India, the fastest record is in Pune, 11 minutes. So that is how fast you need to thrombolize, and you should keep a record of the timings. So when the blood was drawn, and when the CT was done, how much time is taken for thrombolytics to be given. So this is the door to needle time. It is important for you to document. Please don't put a Riles tube, don't put IV fluid, a Foley's catheter. So you're wasting time. Okay, just put 2 IV lines. In one, you can draw the blood, in second, exclusively for thrombolytics. And so again, in India or all over the world, now thrombolytics is moving towards a tenecteplase because it is a bolus injection, ease of use, the recanalization is better in large vessel occlusion. So if you don't have neurointervention unit, I think if you have a perfusion scan, you can do thrombolysis up to 24 hours now. I think that will come in the guidelines. So don't hesitate to thrombolyze a patient up to 4.5 hours time. There is no problem. If sugar is normal and BP is normal, please go ahead and thrombolyze.
So with the permission of the chair, can I? Yeah, Lakshmi, Dr. Lakshmi Narasimhan here. Sir. With the permission of the chair, on the outside, my hearty appreciations for Professor Bora to the wisdom which he has summarized the whole pathway. As I'm from Chennai, and I've been the stroke nodal officer for the Tamil Nadu state for the past 20 years. So at the onset, when I realized the most important, the block, whatever you say, the bottleneck would be money. Money in a governmental setup. As you know, sir rightly said, the affordability. The people running away from hospitals because they don't have money. I realized that when I approached the government, there is no dearth of money. The National Health Mission and presently is very much willing to help you in non-communicability, especially in stroke. There's so much of money involved. So with that money only, I was able to establish a basic stroke ready center, 37 hubs and 50 spokes across the state. And there's no dearth of money, I'm telling you. When even a comprehensive stroke center, we were able to establish 8 of them, including a biplanar cath lab. The national health, and second thing is, now the insurance sector, governmental insurance. See, we have both a state government insurance as well as the central government insurance, both are there. Both have a package for stroke thrombectomy. Package is 3.5 lakhs in our state for a stroke thrombectomy package. For a stroke thrombolysis package is varies between 60,000 to 1 lakh. So what I'm trying to tell is, with that money itself, the government is able to buy the resources. Whatever being done, they take the money. They have now ensured all the 6 lakhs people, and then most of the things, the government doesn't have a recurrent expenditure at all. It comes from the insurance because they have done a bulk insurance of all these things. What I'm trying to tell is, what is required is one young neurologist who is willing to invest his time and coordinate with people, and already existing successful models are available across many states, being replicated, starting from Padma, starting from the Himachal model, the Delhi model, the UP. There are so many models are there, whichever is convenient. Even the Calcutta, I was coordinating with Biman Kanti Rai. See, based upon the regional needs, you just modify whatever modules which is available. I think you should be able to get a good thrombolysis network in Northeast. Thank you. I'll be more than willing to help anybody in this regard. It's my life passion.
Sir, even old neurologist is also okay, sir. You should be passionate about it, that's it.
I think the house is resonating in the right directions. Yes, what comments you are making is very, very inspiring. That's true. The person is more important than money and the machines, right? The drive and initiative and willingness to help people in times of need is what is very, very important. Regarding money also, yeah, I agree. Now, I was looking at the PMJY scheme in government of Assam. Out of 1,800 procedure, because of the financial constraint, they have reduced it to 300 only. But in spite of that, For thrombolysis in PMJY, they pay 60,000. So you can very well do it within 60,000 rupees thrombolysis. But what is happening is patients are not reaching on time because there is no awareness, no publicity. We are not able to do that. That is why they are not. Then in the thrombectomy, in the PMJY scheme, they are being given 1.6 lakhs. That's not a bad amount of money, probably. It can be done within that amount of money. Yes, these are available, but what is not available or lacking, that is also not zero, I think. The kind of people, the number of people I saw presenting papers doing so many good things in stroke, all youngsters. Yeah, these are very inspiring. It may be slow, we need more in numbers, but that's okay. But many of you are doing it and doing it in the right way. I'm sure a lot of people will be benefited. Yes, financial difficulties can be overcome, provided we work little, probably extra. That is needed.
Hello. So now how many of people will thrombolize with confidence? Can you raise your hands? I think now the people have reduced their hands. I thought every one of you will start thrombolizing.
I wanted to add on to one very important point, and I think all of you are here, and as far as I'm concerned, I feel that biggest challenge what we are facing is not for the doctors. It is the awareness about the symptoms of the stroke in the community. I mean, somebody want to sell a cigarette or alcohol, you put the hoardings all across the city. Only place where I could found some good city awareness about the thrombotic or stroke ready hospital. One is Chennai and one is Hyderabad, where there were banners on the road by certain hospitals which says that we are ready for the stroke, thrombolysis available. Whether it was Apollo or which hospital, I don't know, but they were right there on the roads. I think we somehow or other with the government need to create about the awareness of stroke symptoms in common people. See, even if there are 5,000 or 10,000 people who are ready to use the stroke, the number of stroke across the country are too many. If we can create awareness among 1.42 billion population, or even the youngsters in the family about the students, the college boys, and if they know that what the stroke is, and if they can bring their parents, their family early, I think that way we may be able to reach out to large number of people and serve large number of people. Because even if 5,000, 50,000 people, if they don't get the patient in time and to a proper place, so we need to create a mechanism of creating symptoms with the government, with the organization, with our own hospitals, with our own community, that this is a stroke, this should be seriously, these are the symptoms, maybe short video of we talk of BFAST in the meeting. Show me anywhere in the society, show me any common area where BFAST poster has been kept. So I think we all need to take this very seriously, that we need to create these symptoms all on our Facebooks, all on our social media. We need to stress upon to the society, take stroke seriously. Whether you come to me or anybody, that is a different aspect. We should not promote that, but we should say that take stroke seriously. These are the symptoms. Try and create this awareness.
Nirmalji, stroke BFAST standees are available free of cost in National Health Mission. They provide free of cost. You can take it and place it anywhere in the railway station. We have done it in Central Railway Station. We have done it in all the parts of the department. All OPs we have done. The standees are available free of cost. BFAST. That's for the youngsters to know. Across the country, it is available. The standees where you can take it from order it from the NHM and then keep it in any place you like.
I think the panel can keep going on the floor.
I think it's time to close the session. I think awareness is very important. I think each of us, sitting here, we need to be champions. I think we have to change the mindset. Don't worry about, just do it. Well, I think, thank you. Thank you.
Thank you. Thank you so much. We'll be moving ahead for a topic which is more specific to the northeastern part, I invite Dr. Numul Bora to talk on understanding stroke in the Northeast, opportunities and challenges for the neurologists. And for the session to chair, I'd like to ask Dr. Anand Vaishnav and Dr. Nirmal Surya. Yeah, you can be seated on the floor.
Moderator, Dr. Nirmal Surya, President of the Indian Stroke Association, my senior and esteemed colleague, Dr. Vaishnav, distinguished delegates, speakers, moderators, clinicians working in various capacities, students, nurses. It's a privilege on my part to stand in front of you and share my thoughts about my experience of stroke in the Northeast region. I have been given this opportunity by my organizing secretary, Dr. Biplab Das. He told me that, sir, you need to speak on stroke. You need to tell us about your affordable health mission. So, what I am going to share with you today, not necessarily each and every one of you will like it or you will follow it. So each one of us has got a different way of approaching a problem. It depends on time, it depends on situation, it depends on the environment and the ecosystem where we work. I came back to this region in the year 1984 as a neurologist, and we had only 2 neurologists in the Northeast region for almost 60 million people. You can imagine. I had a job in Guwahati Medical College, and I was asked to work as an anesthetist. So there was no opportunity for me to work as a neurologist. So my choice was either I continue as an anesthetist or I leave this region and go somewhere else where better opportunities were available. I did none. I decided to try on my own when opportunities were not available for me in the government sector. I am very careful in spending money, even today also. I saved 5,000 rupees out of my residency program in All India Institute of Medical Science. I was telling one of the residents I met after presenting his paper, I was telling him that, okay, so you are 10 years younger than my eldest daughter who was born when I was doing my DM neurology in All India Institute of Medical Science. At that time, our salary was 1,800 rupees in All India Institute as a senior resident. But even out of that 1,800, so I saved 5,000 rupees when I came back to Guwahati, and with that 5,000 rupees, I thought of doing something in neurology on my own. That's how the journey of neurology and my career as a neurologist started in Guwahati. So, I would like to introduce you how Guwahati is. It's a area where there is enough rainfall, 150 to 250 centimeter. It's only 150 meter above the sea level. It has got two river valleys, mostly Brahmaputra. I don't know whether all of you had the opportunity to see it. Other is the Barak River, two river valleys, and interspersed to it small hills and mountains. It's a beautiful place. Whenever you look at this place from above the sky, I always remember about Switzerland. I find that it is more beautiful than Switzerland, but we are not able to maintain it. That's our tragedy. But Assam and the Northeast is much, much more beautiful than Switzerland. I was crisscrossing Scotland because the British used to say that it is a Scotland of the East. I was trying to find out the justification why they used to say so. Then I found out that yes, it is really so. It's much better, much more beautiful than Switzerland or Scotland. Anyway, so when I came here as a neurologist, I always say that you must know your patient, and beyond that you must know the community from where the patients are coming out. I came here as a neurologist. There was no neurology in this region before that. And there were plenty of patients who came to see me in my chamber. During those times, I came out of medical college. I had no regular earning. My consultation fees for a patient was 15 rupees, Baba. So I started neurology with 15 rupees consultation fees here in Guwahati. But I was curious to know how neurology would be at the community level. They may not be able to come to see me. They may not have resources. They may not be aware of it. So I must go out to the community and see the prevalence of neurological disorders in the community. That's what I did. I used to see 5 days patients, and 2 days I will go back out to the community. I start at 5 o'clock in the morning, come back at 9 or 10 o'clock, going house to house and examining each and every patient. And this result is of that time, my community survey. So I wanted to understand how many neurological problems are there in the community and what percentage of them are able to come to see a neurologist. If you look at this, 0 to 12 years, febrile convulsion 23 I got, the total population number was 2,699, this age group of population. Headache was 19, delayed milestones 18, cerebral palsy 9, epilepsy 8, ADHD 4, and stroke was 1. Because this is younger age group. Then next age group you look at, age group 13 to 18. There were 1,737 people, and headache 41, headache increases, epilepsy is quite significant, vertebrogenic pain, mental retardation, and I saw 2 stroke patients. Okay, 13 to 18 years. This is Northeast, Assam. Then I come to 18 to 64 years of age group. 18 to 64 years of age group. There were 10,669 people. And I get how many stroke here? 13 stroke. Stroke can happen at any age. But as you grow older, more and more stroke patients you get to see. These are informations from community, not what you get to see in your chamber, in your hospitals. Next, when I look at the people 65 years and above, only 5% of the people in the Northeast live beyond 65 years. Okay? In rest, today, all over India, around 17% of the people live beyond the age of 65 years. But during those time, that means from 40 years from now on, when I did this survey, I found out that only 5% of the people live beyond the age of 65 years. And out of 721 people I met, going house to house, and this is the only study in the world, an epidemiological study, which was conducted by a neurologist himself, along with his resident doctor staff. They were too good. They will start with me at 5 o'clock. They will start with me at 5 o'clock and come back to their home at 10 o'clock. No complaint. They are all established neurologists today. So they were with me, and we got out of 705 stroke patients. This is the information about stroke. And by that time, in India, couple of other neurologists had conducted these studies in their respective areas. Abraham et al. From CMC Vellore, but the numbers were different because the methodologies were different. It was not neurologists who went to do this study. It was other workers who were trained and engaged and sent out to the community to do this survey. Only here in Guwahati, a neurologist went out on his own along with his resident staff. Gauri Devi et al. From Nimhans, Bangalore, 52. Rajdan from Kashmir, he did it. 143. Bharusa et al. In Bombay, he did 843. Then Das, this is West Bengal, after that it has come. Shamol Das has done, he is no more. 126. Then Saha et al. He was also my batchmate. He was also professor in West Bengal in one of the medical colleges. He did it 147, and the Guwahati, Dr. Bora et al. In our study, we got 922 stroke, prevalence of stroke. That means if you go to the community, these many strokes are available. They are stroke survivors. They are stroke survivors. Then we did an incidence study. Incidence studies, those patients who were having stroke, we subjected them to CT scan, we subjected them to MRI. Then there were only 2 incidence studies done in India till that time. One was done by Abraham Vellore, but the number was too low, 13.2. Our study was 163 per lakh per year, and worldwide was 150 to 300. It seems closer to the world global studies. So I think that the way we did it, it was much more accurate than whatever was done in other areas. The mortality of stroke in India, population-based study, age adjusted stroke death was 91 per lakh population per year. We had done this study in 3,905, and there were total 10 stroke deaths. We compared the population to the US population of 1970. Then what we found in this study, there was, in fact this study, this slide again, till that time there was no ICU, stroke ICU. Stroke patients were treated in the wards. There were a lot of mortality. For the first time in Guwahati in 1991, we established ICU. Before that, there was no ventilator in Assam. I saw people dying like flies. You can imagine, many of you, those who are youngsters, will not be able to imagine, is it possible to run a hospital without an ICU? Without a ventilator. But during those times, from 1987 to 1984 to 1991, there was no ICU in Assam, not even in medical colleges also. When the first ICU started, then we started treating these patients better. We were able to keep them in the ICU and look at the mortality of stroke. Before the ICU was started, in fact, there were 54.8%. After ICU, in fact, number came down, but hemorrhage stroke number increased. And mortality from 22.95%, it decreased to 15.22%. So when you treat acute stroke in intensive care unit, it certainly brings down mortality. This study clearly shows it. Then we had published a paper, a 5-year retrospective code. What happened to these strokes when they go back to the community after 1 year, after 2 years, after 3 years, after 4 years, 5 years? We traced these people after 5 years and tried to find out how many of them are still alive, how many of them have died. Among the patients, 38% were diagnosed with ischemic stroke and 61% were diagnosed with hemorrhagic stroke. And about 30% of these patients died in the hospital within 0 to 4 weeks after the index event, while 27% died during the follow-up period of 5 years. 27% of them died. At home, approximately 21% of the patients experience a recurrent stroke over the next 5 years, which turned out fatal. The quality of life was seriously affected in 32.4% of the survivors. It was seen that 40.5% of the survivors were fully independent and 46% were able to return to their occupation after 5 years post-stroke. Prevalence of severe and very severe depression was observed in 3.4% of the patients, and the majority of the survivors were aware of the risk of recurrent stroke. Physical activities as a measures for prevention of stroke were undertaken by 60% of the survivors. So, people are cooperatives. They are willing to sense, they are willing to learn, provided we have the intention to help them and we sincerely do our job, then their habits can and practice can be changed. This study shows that. We contacted them. In different layers we had done these studies. It is very difficult to trace people after 5 years. First we recruited an agency who can trace missing people. They were able to pick up some. Then when they could not do everything, first it was tried with telephone, then do it by recruiting an agency. Then our resident staff and the research team hired a card. Every day they will go out in the morning and look for these people, and finally they could do it. Risk factors of stroke. That's a community-based study. You see what happens. Participants were 3,905 and the participation rates are very high. People usually cooperate. You don't get it. Your other studies in many other countries, this much of people's participation you don't get. But here in Assam or in India, people are very, very cooperative. They usually cooperate with the research studies. 89% of the people had participated in these studies. 13% of the patients in these regions are smokers. 1.7% are alcoholic. Diabetes, there is an error here. When we collected the blood samples, it was during those times, the preservative was not very developed. So by the time the samples reached the hospital, it was late, there was glycolysis of the samples. That's why the sugar level was low. So it should be 10%, but it was found out to be 1.4%. And 24% of the people were hypertensive in the community. This is almost at par with the other national studies, 24%. And hyperlipidemia was seen in 0.92 patients. And there was another study, homocysteine. There was a belief that homocysteine causes stroke. So ICMR had given a project that you do a community-based study on homocysteine. We did it very sincerely. We had 970 people, 567 male and 403 females. The age bracket was 35 years onwards. Then we got the mean homocysteine level in male was 20.015 and in case of female it was 16.119. So homocysteine level was little higher in males than in females. It was almost same as in other studies done in other places. Also, we did vitamin B12 estimation and homocysteine level relationship. Then we found out that when a particular stage, the vitamin B12 levels comes down, then the homocysteine level tends to rise. There is an inverse relationship between the two. We also did case control study in case of stroke. We found out that in case of hemorrhagic stroke, patients tend to have more homocysteine level than in case of ischemic stroke. There was no significant increase in homocysteine level in case of ischemic stroke. Then another, so I was telling you incidence study that in the stroke card we got it at 165 and in community we got at 163 incidence. Then the mortality of strokes in the community we found at around 45%, but when they came to the hospital, the mortality of the ischemic stroke was 6% and the mortality of the hemorrhagic stroke was 23%. This was better than the many other international studies. I was visiting at that time Europe. This paper was presented in Heidelberg University in one of the stroke conferences. At that time, the stroke mortality was more than 20% across the world. So this mortality, if you average it, 23 plus 6, it comes to around probably 14 or 15%. It was much better. It was much better. Then quality of life, 60% are independent at 5 years, and 16 in the hospital, those patients who are discharged from the hospital, we found out that they become normal, 16% become normal, 12% died, 32% they are independent but not normal, and 40% at the end of 1 year they remain dependent. Age and gender, that's a very interesting information. Look at the last line. When you look at the patients coming to the hospital, 72% are male stroke patients, 28% are female stroke patients. That is in Assam. Sinman's experience may be a little different. In Shillong, do you have any data? Sinman, you are here? Dr. Sinman, neurologist from Nigrim. She was presenting a paper? No, she's not here probably. Okay. Anyway, so if you come to the community, then you find that male-female ratio is 45 to 55. You know why it happens? When somebody becomes sick, there is financial constraint. It is the male who gets priority in treatment. Females are ignored and neglected. Ignored and neglected. Say, no, don't come to the hospital. They get stroke. They get stroke. Not that they do not get stroke, but they are not being brought to the hospital because they do not have money to spend for them. Then your community and hemorrhagic and ischemic stroke ratio is almost 50-50. This was discussed and debated number of times. As you come from west to the east, number of hemorrhagic stroke tends to increase. Studies from China also says that, studies from Japan also says that. In the west, in Europe and America, you start with 15% hemorrhagic stroke, 85% ischemic stroke. As you come to the east, in Japan, it becomes almost 60-40. In China also, it becomes almost 60-40. But in the northeast, including West Bengal, it's almost 55-45. Ischemic stroke is around 55 and hemorrhagic stroke is around 45. Why it happens? One, uncontrolled hypertension could be one factor. Uncontrolled hypertension, because the health awareness is much lower in this part of the country. It also depends on the density of the doctors in the community. If you look at globe, there are countries in the world where there are 8.4 doctors per 1,000 populations. 8.4 doctors per 1,000 populations. That means 84 doctors for every 10,000 population. Global average is 13 doctors for every 10,000 population. Global average. Then come to India. We have six doctors for every 10,000 people. Come to Assam. We have only 3 doctors for every 10,000 people. Assam and Northeast. We have less doctors, so less service to the community. So they tend to have uncontrolled hypertension, untreated hypertension. That may be the reason why they get more hemorrhagic stroke. Then distribution of the strokes are more or less same like any other part of the country. So I would not like to take more time, but if you look at the risk factors at community level, 12 to 13% of the people are smoker, but when they get stroke and come to the hospital, if you look at these people, then you find that around 46% of them will give history of smoking. Around 66% of them will have associated hypertension, these stroke patients, and also hyperhomocystinemia, ischemic stroke 59%, hemorrhagic stroke 70%. Community it is 56%. So I would not take much time. This is where this is very important observations. The carotid artery thickness at the community level as well as at the hospital patient, stroke patient. 79% of the patients who were admitted with stroke had thickening of the carotid arteries. But at the community level, we did this in 1,000 patients, 1,000 people serially. Carotid artery thickness, when we assessed through echocardiography, we got it only, the Doppler study, we got it in 39% of the patients. This is burden of stroke in India. Let me come to the Northeast. Northeast means Assam data, this one, only Assam. Sorry, I did not include the entire Northeast. 52,000 people in Assam get stroke every year. 145 people get stroke every day. 145 people get stroke every day. 6 people get stroke every hour. 6 people. And 1 person gets stroke every 10 minutes. Every 10 minutes, 1 person gets stroke here in Assam. 1 person dies due to stroke every 30 minutes. And 1 person becomes disabled due to stroke every 30 minutes. So it's a public health problem. It's a public health issues. It's a public health issues. It requires more urgent attention from people like us. Okay? Then what are the challenges? What are the barriers? Why we cannot? Already it has been discussed that awareness, affordability, accessibility. We did a Gallup survey. In USA, this Gallup survey was done. 97% were unable to name a single warning symptom of stroke in USA in 1990. And 30% of the US adults have high blood pressure, but only 5 adequately controlled it. We got 24% of our population hypertension, more or less comparable. Then we did a Gallup survey in the Northeast. My colleague Dr. Manos, who's helped me to do it. Only 46% of the people are aware of the disease stroke. They have not heard the name stroke, only 46%. 50% of the people have not heard the word stroke even. Only 27% of the people could name 1 or 2 risk factors of stroke. Only 35% of the people knew that stroke occurs in the brain. Somebody said it occurs in the heart. Somebody said it is kidney. It's like that. So less is the awareness. Then not more than 20% of the population know about the warning symptoms of stroke. They are not aware of it. Only 12% of the population know their blood sugar level. Hardly 26% of the population in general are aware of their own blood pressures. That is a reason for more probably hemorrhagic stroke. They have never checked their blood pressure. 2.16% of the population know about their cholesterol level. I have limited time. So what are the initiative that we took? Establishing a regional stroke center, setting up of stroke and heart attack prevention clinic. This initiative was undertaken 25 years ago, Nirmal, in Assam. Setting up of stroke and heart attack prevention clinic. Catch them young program for the school children. Convince opinion leaders to speak about stroke. Let the Prime Minister speak, let the Chief Minister speak, let the Governor speak, then people will listen to them. Training of doctors and paramedics to take care of the stroke patients. This was envisaged 25 years ago, not now. Stroke and heart card. That's how, this is one of my program, Catch Them Young, school program. I used to address school children. This is opinion leaders. He's the health minister. I made him to speak about stroke. I made the Prime Minister to speak about stroke. He came to Guwahati, I requested him. He was talking to a stroke patient. It came in the press. We made them speak about stroke. Then regional stroke centers. This was being done routinely free of cost. Check your weight, check your blood pressure, check your blood sugar, lipid profile, ECG. Say no to smoking as a stroke prevention initiative. This was done in probably 1996. 1996. Then, for last 10 years, I'm not consulting patients, but I'm doing something else. In order to achieve this, we took a program called GNRC MediReach. We trained a dozen young people, teach them how to do home survey, the thing that I did 25 years ago, and by administering a questionnaire, they were able to collect the disease profile of the individuals. And in this way, they were touching the lives of around 100,000 people. And what was the understanding? And there was around half a dozen doctors who was recruited from public health experience to screen these patients. And I used to go to these exercises on a regular basis, talk to these patients and understand what are the common diseases that affect them, why they become sick, what kind of treatment they need, how much money they can spend. And realization is that 70% of the diseases that these people get affected can be prevented if we help them how to remain healthy and disease-free. It does not cost any money. Prevention is always better than cure. That is number one. Number two, cost of healthcare must come down. Cost of healthcare must come down. There has not been any conscious effort to bring down cost so that it becomes affordable to large number of people. That is important. Otherwise, we'll not be able to help even the stroke patients also. So a model was created by which we had 9 building blocks in our GNRC care model: preventive, promotive and curative, primary, secondary and tertiary, and affordable, accessible and sustainable. This is private, na? It does not run on any grants or contribution from the public, so it must be sustainable. Our expenses should be less than what we earn. So this model was studied by Harvard School of Public Health, and they published a case study on this as a unique approach. Then this was published in Lancet, this story. We created a group of community health workers. We trained 20,000 of them during last 10 years. 20,000 community health workers was trained, and their job is to go house to house, help them to remain healthy and disease-free. They carry a blood pressure machine, they carry a glucometer, check the blood pressure and glucose of the patients free of charge. They make repeat visits, and this was again published in Access to Affordable Health, a care delivery model of GNRC hospital in Northeast India. This is an international journal of integrated care published from London. They published this article. This is what the seismometer does at the community level. They are mostly over 70% of them are, we have them in all over Assam, and even these are seismometers program. Rewards and recognition program. That's what we do. We have 3,000 of them now working in Assam on a monthly basis, 3,000 seismometer. They are in charge of 6 million people. That's how I say that anybody getting stroke, this seismometer get to know. We have 60 ambulances. These are free for people. They can carry the patients to the hospital. But the challenge is then, with the help of the PMJY, as my dear colleague from Chennai was mentioning, we are into that job. By taking the help of the government, we'll try to help these people to get treatment of stroke. But only 2 procedures are reimbursed on this scheme. One is your thrombolysis, other is thrombectomy. But for procedures other than that, they don't support it. That is the problem. Stroke, only 2 procedures are being reimbursed in PMJY scheme. So this is what Affordable Health Mission is. I think I have come to the end of my timing also. Am I right?
Yeah.
So thank you very much for your patient hearing. And thank you, Biplab, for giving me an opportunity to share with the audience what I was trying to do as a neurologist. I have at the beginning said that it's not mandatory that everyone should do this. This is what I felt I should do, and I tried to do it. And I'm grateful to the conference for giving me an opportunity to share this with all of you. Thank you.
Thank you so much, sir. And now for the last, for the pre-lunch session, we have Dr. Lakshmi. We have a beautiful title, choosing between Sheila and Caribbeans, almost like the devil in the deep sea. And he is a professor at Institute of Neurology, Madras Medical College. You've heard him, he's passionate about stroke management. I invite him to talk on the subject.
Good afternoon, everybody. I think they are the last talk of this session. At the outset, I thank Dr. Biplab Das for giving me this opportunity. I love Assam. My early part of my career, I have at least served 3 Brahmaputra floods in various parts of Assam and parts of North Bengal. I have served here as a young MBBS graduate. I have served in central government service. I was here, amazed by the vigor of Brahmaputra and the modesty of lovely people here. They moved me. I have so much of connections with them 40 years down the lane. I'm very, very happy. As the sir said, the beauty of Assam is unconquerable, not properly marketed, and enormous beauty. I go back to the topic proper. The Saila and Charybdis is nothing but during the Trojan War, there was a small strait where the boats have to cross. On one side is a devil, the other side is a deep sea. It's essentially the equivalent of devil and the deep sea. The devil is the 6-headed monster on the hill cliff. On the other side, the Charybdis is a whirlwind in the sea. So it is essentially choosing between the devil and the deep sea. Such situations most of us faced. So this is exactly the monster. I'm just showing you the monster on the cliff and the whirlpool on the sea. So Time and again we get into such situations. I'm just going to talk about, because when Biplab asked me to talk about the choice of anticoagulation post-stroke and antiplatelets, it's a huge topic. So I thought 15 minutes may not. So I thought I'll choose certain clinical situations and then talk with you. As stroke physicians, difficult clinical decisions on anticoagulation, dilemma to choose between the risk of thromboembolism and the risk of bleeding. Evidence limited, need individualized approach, shared decision process with our patients, taking into account their values and preferences. You'll be surprised, I'll show you the data. First case, 8-year-old diabetes mellitus, hypertension, coronary artery disease, congestive cardiac failure, and atrial fibrillation patient on acinocomarin, developed acute onset of left hemiparesis. CT revealed a right GC hemorrhage, extensive leukoariosis, INR was 1.9. Patient has recovered well and improved with an MRS of 2. Would you restart anticoagulation? He was on acinocomarin. Would you restart? Anyone from you? Would you restart the anticoagulation? Yes or no? Would you restart the anticoagulation? He was on acinocomarin, developed right ganglion capsule, recovered well, MRS 2. Would you restart? What does the studies show? Favorable things are significant reduction in ischemic stroke and all-cause mortality from 13 versus 100 to 27.3 of untreated patient years. No significant difference in the rate of recurrent ICH if you start them on anticoagulation. So this is one of the favorable study to restart on anticoagulation. And Crohn's study, recurrent ICH is 2.56 100 patient years during a median follow-up of 16.5 months. Only 0.4% of cases, 100% fatal. No hemorrhage outside the CNS was also noted in 778 patient years. Both these studies show that definitely you can restart. One more lady, 80 years old, female diabetic, left side hemorrhage. This lady has a lobar hemorrhage. I'll come back to that. So restarting a warfarin after ICH did not increase mortality or bleeding in patients with high thrombotic risk. So this is one message which I want to say. But the story is does not stop there. There are a lot of papers for starting against anticoagulation. Although results were promising, there are non-randomized observational studies. Whatever the favorable studies were non-randomized and subject to selection bias. Unfortunately, ICH patients were excluded from all the randomized trials of anticoagulation. If you look at any trials of anticoagulation, the first thing they exclude is ICH people. So they don't give you any information. So ICH was associated with more severe clinical presentation and worse outcome compared to, see what happens if you don't start. Patient has an AF, it is going to produce an embolic infarct. The fatality rate of an embolic infarct is only 30%. Fatality rate at 1 month. Whereas ICH has a 50% mortality at 1 month. So what do you want? You want an ICH or you want an embolic stroke of a, so this is what they compared, and even the risk of recurrent ICH and ischemic stroke were to be comparable during the follow-up patients with anticoagulated related ICH. The clinical outcome would be poorer in ICH, obvious. ICH, you start the patient, restart the patient warfarin, patient developed an ICH, the outcome is going to be definitely poorer than if you don't start, patient develops an ischemic stroke. So okay, fine, then all these conflicting papers, what do the guidelines say? Grade recommendation says it refrains from making a comment on starting recommendation. I was surprised. So one recommendation says it refrains. The other person, AHA and ASA, class 2 recommendations to avoid warfarins in lobar ICH, don't touch anticoagulation, whereas you can stage 2B class 2 evidences, you can start on the non-lobar ICH and antiplatelets after any ICH may be considered. Wordings are very, very ambiguous. What I'm trying to say, youngsters, you've got a lot of work to do. Lot of areas where in stroke you can still publish papers because there's not much of evidences. So choosing again, coming between choosing the devil and the deep sea, only we have to choose whatever it is based on each patient. We have to have an individualized approach based on this. Are there any tools available for this? There are only 2 tools, as most of you know. One is the CHAD2 DS2 VASC, which assesses the thrombotic risk, and the HAS blood score, which predicts ICH in both AF and non-atrial fibrillation on population. So learn the habit of doing both, document both CHAD-VAS2 and HAS blood in every one of the patient when you want to restart the patient on anticoagulation. In high thrombotic risk, when the CHAD score is equal to more than 4, the thrombotic risk is very high, and the HAS blood risk of more, if the risk of ICH is more, if the score is equal to or more than 3. So you choose do a CHAD-VAS2 and HAS blood and then take a call. However, finding such population is difficult. These scales are not post-stroke scenario. It's not on a post-stroke scenario. This patient also had first patient had also leukoariosis. Leukoariosis, again, an independent predictor of ischemic stroke. Okay, fine, you decided to start. Do you want to start on warfarin or NOACs? The apixaban, dabigatran, edoxaban or cancerate restarting anticoagulation is preferred. NOACs were as effective as warfarin in preventing primary or secondary stroke, significant reduction in stroke for ICH. However, superior safety of NOACs over warfarin has not been established in patients with intracerebral hemorrhage. Post-intracerebral superiority is not established. Another option, remove the source of the thrombus. This is what is upcoming. You must have known that as a neurointervention group, the Watchman device has the left atrial appendage closure using a Watchman implantable heart implant called Watchman is now gaining a lot of popularity because it's pretty safe. But the only disadvantage is, again, they have to be on antiplatelet, which increases the ICH risk. So yet another question complicating the issue is how soon, when will you start? Quality of data is very low. Several timings have been suggested, 14 days to 30 weeks. So there is one thing called Diener's law. I'll talk to it in the second case. Second case is 76-year-old patient, 7 months after atrial fibrillation, later stroke on azinocomarol is diagnosed with iron deficiency anemia. Endoscopy showed a gastric polyp, scheduled removal for 2 weeks. What do you want to do? How do you handle anticoagulation perioperatively? You want to stop the azinocomarin and switch over to, normally what we do the bridging. So I was just looking into the evidences for bridging. The Relay trials, 1/4 of the patient on long-term anticoagulation underwent invasive procedure. The mean follow-up of 2 years. Dental, dermatological and ophthalmologic procedures with a low bleeding risk, anticoagulation can be continued during the procedure. A strategy used majority was bridging. Bridging VKA, the VKA were withdrawn. The vitamin K antagonist like the oral warfarin group was withdrawn. Switched over to low molecular weight heparin. 1 day prior you start and then restart using the oral anticoagulation. This bridging was minimize the interim. Was it favorable? It's a common approach for many decades. But recently, a meta-analysis, 2012 had a meta-analysis of another one in 2019 also. 34 studies, 12,000 patients. Bridging was associated with increased risk of bleeding and similar risk of thromboembolism compared to no bridging. Orbit registry again showed that the more frequent in patients on bridging. Then they said, no, now time for do a trial. We'll do a bridge trial. Randomized to bridging with dalteparin with no bridging. No bridging had reduced risk of major bleeding. Net clinical benefit is in favor of no bridging strategy. This is totally new to me. They said that methodology was not right in bridge trial. Then they're now doing what is called a peri-op2 trial. The results are awaited. So there's one more thing called Bruis controls trial. Showed that compared to the bridging therapy with heparin, a strategy of continued warfarin treatment at the time of pacemaker or implantable cardioverter or defibrillator surgery markedly reduced the incidence of device pocket hematoma incidents were reduced. So again, we are in the devil in the deep sea, as no consensus, and HAS blood is a good way to predict the bleeding risk, and then based on that, document that and then start whatever you want. Yet another strategy, start on NOAC, rapid onset and offset of action, allow for a shorter period of interruption of anticoagulation. Timing of NOAC interruption is determined taking into consideration the renal clearance. Resumption depends on the type of intervention and consequence of a bleeding complication which is likely to happen. So based on that, you decide. So prospective registry is needed, more data is needed to confirm. 82-year-old female with a history of hypertension, diabetes mellitus with acute onset of aphasia and right hemiparesis. Irregular ECG shows runs of AH. NHS score 30. CT brain showed left hemispheric edema, extensive. How soon after the event you would anticoagulate for the second stroke? Early initiation. What are the studies favorable? 1% of AF related to ischemic stroke would be complicated by a recurrent ischemic stroke within first week. First week. They say start on first week. Immediate anticoagulation with heparin was a common practice. Unfavorable. Meta-analysis has shown that immediate anticoagulation did not reduce the risk for ischemic stroke, increased the risk of hemorrhagic transformation. Cochrane analysis also showed the same. As a result, immediate anticoagulation is not used nowadays. Cardioembolism, which warrants anticoagulation, is also a predictor of increased risk of ICH due to large infarcts and a 12-fold increased massive infarcts. AHA-ASA says less than 14 days in most patients. European says that Diener's, the famous Diener's law, which says 1362, after 1 day in a TIA, 3 days following a small non-disabling infarct, 6 days following a moderate stroke, and 12 days in large infarcts. By and large, keep it large infarcts, keep 2 weeks, and smaller one, you can, based on, stratify them and accordingly. Tools again, that the two famous tools are the one to help you. Document that. Cardiac assessment, always do a TEE and a cardiac CT. Biomarkers, matrix metalloproteinase correlates with the disrupted permeability of the blood brain. Last case, 45-year-old female with mitral valve disease, rheumatic, valvular AF, echo revealed enlarged left atrium. You can see the thrombus sitting there. Warfarin, patient had developed subarachnoid hemorrhage and intraventricular hemorrhage. Anticoagulation was stopped, patient was managed conservatively. This is extensive hemorrhage, SAH and all. On day 5 of SAH, patient developed painful paraparesis, cold clammy skin with absent lower limb pulses. Since you have stopped everything, it has resulted in angiogram revealed. You can see a cutoff, infrarenal aortic cutoff. Patient was managed with thrombectomy under heparin cover, explaining all the risk, and improved subsequently, started on dabigatran 110 BD 2 weeks. Restarting the anticoagulation following ICH also requires situational stratification, as in mechanical wall, high, medium is AF, and low in CAA. So do a risk stratification based on the situation and restart the anticoagulation. Thank you for your attention. It's highly individualized. What I'm trying to tell is each one has, and based on the situations and the patient, I think you should take a call. This is again one of the devil and deep sea situation. I'm ready to take up the questions. Thank you. My dear friend Vaishnav is here. He's my old friend. We have spent lovely time with him.
Oh, same here, same here.
Neurohematologist. The only neurohematologist in the country.
No, please. So, at one simple question, I mean, again, this is truly a great topic, and then after, the Elan trial also came, which was a little bit simpler version of this. Do you use susceptible-weighted imaging and cerebral microbleeds? So if you have cortical and subcortical cerebral microbleeds, that may go in favor of amyloid versus your traditional just a basal ganglia. Even though it's a 4 or 5 centimeter hemorrhage, it's from blood pressure, that I may feel a little bit, So do you use CMBs or not?
Yeah, the load of microbleeds is another area. After the evidence, after the advent of the susceptible-weighted images, normally they take a cutoff of 10. What is your take?
I think cutoff of 10, and then if it's subcortical more, then you think it's hypertensive. There are more, cortical, then you think it's
low bar, more of a low bar. Any other questions? Thank you. Thank you.
Thank you.
Thank you, sir, for a wonderful presentation. So we move I think this is the completion of pre-lunch session. So we are going for lunch now. So we'll be, I request all the residents who is participating for stroke quiz to be here. and submit your names, please, because we're starting quiz, stroke quiz now during this lunch break. Thank you. All are requested to come back. Session will be starting from 2 p.m. and whoever wants to, join for the quiz, please be here. Thank you. Take. Participants for quiz, please submit your names, please. Yeah. From GMCH, there are 2 teams. Otherwise, we're going to unopposed winner. But there should have a minimum questions will be there to. Anyway, so next thing is also to submit your papers, the platform presentations. Residents from GMCH also requested, they had earlier presentations, they requested for the second half presentation.
stroke round, and it will have 6 questions, and we will start from this side to that side in the first round, and 20 seconds for answering. Direct questions, if you get the positive answer, it will be +20, if you will get negative answer, it will be -10. And for past questions, if somebody cannot, if passes, then it will, for him, it will be +10 and -5. For round 2, it will be case history based. Again, 6 questions. It will start from the opposite side, so from that side, this side. And again, direct questions and past questions, rules remain same. 20 seconds for answering. So next round will be anti-clockwise, that is from that side to this side. Third round will be stroke trivia round. Same rule, direct questions +20, -10, past questions +10, -5, and the last round will be the rapid fire round, where each candidate will be given 30 seconds and 6 questions. We will not shift to the next one unless you say pass. There will be no negative marking in the last round, and each correct answer will be 10. Sorry? So we will start from A, B, C, D. Only 4 candidates are there. Yes. Yeah. We'll start from A to D in the first round. So once you are ready, let me know. So first round के लिए आप ना 20 seconds का वो करेंगे. ठीक है? 20 सेकंड का. इनको बताना है 30 सेकंड नहीं है, 20 सेकंड है.
Excuse me, 20 seconds first, 20
First
seconds.
वाला में 20 सेकंड का टाइमर देना है. ठीक है?
And if you don't know the answer, you can just say pass. So you'll have more time to think for the next question.
20 seconds per question. पास नहीं किया तो पास नहीं किया तो 30 सेकंड. Timer is 20 seconds. हो गया? So let us start. Okay, wait. Okay. So round 1, Dr. Mandar will take over.
Hello. Yes. So for round 1, everyone is ready? Right. So for the buzzer team, it's ready. 20 seconds. Okay. So round 1. Question 1. Cryptogenic strokes account for how many percentage of ischemic strokes? Is it A 25%, B 15%, C 33%, or D 50%?
This is your question.
Yes. You have 20 seconds.
B 15%.
Yes. The answer is A.
Next question.
The next question to second candidate: in patients with ESUS, which types of infarcts are excluded? A. Small cortical infarcts, B. Large cortical infarcts, C. Small subcortical infarcts, or D. Watershed infarcts. 20 seconds. Your time is up, sorry. The answer is B. For the third person, SWOT sign is seen on A. Contrast CT head extravasation, B. Contrast CT angiography extravasation, perfusion CT head, or MRI angiography brain with contrast extravasation. You have 20 seconds.
B. Contrast CT angiography extravasation.
Okay. You are right. For the fourth person, before cardiovascular stroke, TIs precede in how many percentage? Before a cardiovascular stroke, TIs precede in about how many percentage? A, B, C, D. You have 20 seconds.
A.
Okay. The answer is C. Right. So first round is over. The second round will be taken by Dr. Apratim.
So round 2. Yeah. So we will be starting from you and coming this side. So the first question for you, mainly case history based. 53-year-old timer start. 53-year-old chronic smoker, history of recent mild stroke, His friend noticed he is unable to strike a match and light a cigarette. When doctor commanded him to do so, he could not do, despite adequate motor power. This condition is called anosognosia, apraxia, agnosia, abulia.
Apraxia.
Yeah, it's right answer. So next question. अच्छा जब option आएगा तब timer on करेंगे, ठीक है? So next question for you, madam. So this was the right answer. Second question to madam. Doctor was examining a patient in his clinic. Doctor, what is your name? Patient, what is your name? Doctor again, what is your name? Patient, what is your name? He is suffering from option A, timer on, echolalia, option B, palilalia, option C, perseveration, option D, paraphasia.
Option A.
I think it's right. So, Debashish. Yeah. So, third question, case history 3 for you, ma'am. A 65-year-old woman brought by her husband for evaluation does not recognize famous or even familiar people by their faces. He first noticed this when they were going through a family album of photographs. She can recognize familiar people through other clues, such as their voices. Brain MRI shows a small infarct. Injury is to which of the following areas is most likely to produce such a deficit?
Fusiform gyrus.
Okay, so I think it's correct answer. And the last question, case history 4 for you. 45-year-old right-handed man brought to emergency department, abrupt onset of speech difficulty 4 hours earlier. According to his wife, he started talking nonsense and appeared not to understand what she was telling him. On examination, he has a well-articulated, fluent and prosodic speech, but makes frequent phonemic and semantic paraphasic errors with neologisms. He is unable to name objects, but he can pantomime their use. The findings are consistent with the lesions in which of the following areas? A, angular gyrus, B, entorhinal cortex, C, perirenal cortex, and D, superior posterior temporal gyrus.
D, superior posterior temporal gyrus.
Yeah, so typical of Wernicke's, exactly. So we complete the round 2, now move on to the round 3, right, by Dr. Mandar. Yeah. Round 3 will start from this side on it.
Yes, for the stroke trivia, your questions are up. First we'll present the questions, then you have 20 seconds to answer. This famous writer suffered a left-sided stroke and died before he could complete his last books. That was The Mystery of Edwin Drood. Can you name this gentleman?
Pass.
Right. So he is Charles Dickens. Okay. Okay. Yes. Come to next question. Second candidate. Identify this famous neurologist.
This is hysteria, I think. He's examining.
Sorry?
Matlab, the patient is having hysteria.
No, who's the famous neurologist standing? Can you name him? Right.
Anybody else would like to try?
Okay.
Audience we have?
Anyone want to answer?
Any from the audience?
Yeah, Jane Martin Charcot. So, question 3 for mine. This famous American president suffered from left hemiparesis and was still a president during the last 20 months of his regime. He claims to be fame of founding League of the Nations, a predecessor to the current United Nations. Can you tell this gentleman? 20 seconds or you can pass.
Pass.
F. Kennedy.
So, no, he is Mr. Woodrow Wilson. Right. We go to next round.
So this round is a last round. And this is the rapid fire round. So here we have timer for 30 seconds. There will be 6 questions to each candidate, right? Okay. Sorry? Last round, no negative marking, but individual candidate I think will get 30 seconds and there will be 6 questions. But unless you say pass, we won't move to the next question. So if you delay, you may lose your number of questions. No negative marking, you can make your guesses. Group 1, so you are the first candidate, sir. The right hemisphere is most commonly the dominant hemisphere responsible for communication. True or false?
True.
Device surpass is used for what?
Pass.
Artery of Percheron, I think you can see all the questions. Artery of Percheron is a branch of which artery? You given the 30-second marker, right? Fourth question is infarction in which arterial territory is more likely to cause transcortical motor aphasia? And fifth one is magic empty stem embolized trials. Which neurointerventional therapy?
Infarction of anterior cerebral artery would be the...
Your answer is, to the fifth question is ACA, right? Anterior cerebral artery, okay.
Yeah.
Any other questions? So you have given two answers. First one you have said is true, right?
True.
And you have said the fifth question. Okay, so let's see. The first one was false, and the fifth you are correct, is ACA. And the, moving to the other question, surpass obviously is a flow diverter for aneurysm. The third question was artery of Percheron is a branch of P1 PCA. And the last one was for SDH, chronic SDH embolization. Now for the group 2, Mandar, if you can take this.
So for the group 2, ma'am, your questions are, a person presenting with a left lower extremity weakness most likely involves which vascular territory?
Right ACA.
Okay. For the second question, a patient with ischemic stroke is received to total dose of 60 milligrams of TPA. How much will be administered as a bolus dose? How much bolus dose? Next question, recurrent artery of Hübner is a branch of which artery?
Anterior cerebral artery.
Okay, next question, technique Solumbra is used for what?
It is a mixed technique for aspiration as well as the...
okay, and last question, as you can see, chance to trial.
Aspirin and clopidogrel.
So your answers were first AC territory, and second question was how much mg of bolus dose given? It is 6 mg. Third, recurrent artery Hübner is a branch of ACA. Second last was the mechanical thrombectomy Solumbra, and chance to trial used for antiplatelets, that is ticagrelol and clopidogrel. Yes. Yes. ACA, yes. 3 correct. So we'll go to next round.
For the third person, madam, your questions are, start the timer. An aspirin is recommended within 24 to 48 hours of an ischemic stroke. How long is the antiplatelet effect of an aspirin?
48 to 72 hours.
Okay. Second question, Perinaud syndrome results from a stroke in which part of the brain?
Midbrain.
Okay. Third question, Boach and attention trials for what?
Posterior circulation stroke.
Very nice. Fourth, lateral tentorial artery is a branch of? Any attempt for the last one?
Yeah, web device is used for aneurysm, sacral aneurysm.
Fine. So let's see the answers. The first one is 7 days. So it was wrong answer. The second answer was midbrain. She said midbrain. I think we can. For the third one, she said was, I think, did you say the third one? Boach and attention? Posterior circulation stroke, yes. Fourth one, I think you did not say. The last one you said was aneurysms. Yes, intrasaccular device. Yes, it's right. Correct answer. So, aneurysms correct tha, stroke from midbrain correct tha, posterior circulation stroke. 3 correct answer. Okay, last recommender.
Yes. For the last, you can start the timer. A patient is unconscious and is noted to have extension of both upper and lower extremity. This type of posture is most consistent in which lesion of at which level? Next question. On the finger to nose test, the patient who has ataxia will have most of the findings at the beginning of the movement. True or false?
True.
Device A68 is used for what?
Pass.
The other name of Medley syndrome stroke is?
Wallenberg syndrome.
Tension Tesla selective trials for mechanical thrombectomy, what exactly they investigate?
Pass.
Okay. two answers given. We'll see one by one. For the first question, it's midbrain. Which type of posture is consistent with this type of lesion when they have patient have extension of both upper and lower extremity? For the second question, did you answer? You said true. It's the answer is false. Third, A60S is aspiration catheter used for mechanical thrombectomy. You didn't answer this. Second last, the medullary stroke is also known as the medullary syndrome of Digenny. And last, tension all these trials you said pass. It's large core thrombectomy trials. So you gave two and both of them I think wrong.
So I think we are done with the rounds.
Yes.
Okay, so a bonus round declared by the organizer.
Yes, you can go with the bonus round.
So let's move on to the bonus round. This I think is not. This is not this one. Visual round. Okay. First question. 70-year-old male. अच्छा, start from there. ये time कितना था यार? इसका आप 30 सेकंड रखो. 70-year-old अभी नहीं start करना है जब options आएगा. 70-year-old male, known case of diabetes, hypertension, post CABG, presented with history of decreased vision left eye, especially on looking downward since 2 days. Clinical examination revealed left-sided homonymous inferior quadrantenopia and mild left hemiparesis. Well, this was the visual field charting. Identify the sign and where is the lesion. Sir, your attempt. So, identify the sign.
What's the sign in this?
And then the lesion.
Pie in the ground.
Sorry?
Pie in the ground.
And where is the lesion? Which lobe you are talking about?
Temporal lobe.
Temporal. So, his answers, where we are going to answer. Pie in the floor. He said pie in the ground. Should we take it? I think yes. And he said temporal, that was the wrong. So it's obviously parietal. It descends down. One answer is correct. One answer is considered correct. Next question.
So, ma'am, the next question is for you. You have to identify this disorder. Okay? Your timer will start now.
Moya syndrome.
Right. So, your answer is correct. So, we can go to the third person, I think. Yes.
I think it should be Moya disease.
Moya disease.
Yeah, it's okay.
You can give.
Fine, can be given. Third question for you, ma'am. 25-year-old lady underwent a VP shunt for idiopathic intracranial hypertension. The next day, she developed right hemiparesis. Her DSA was done, which showed the following. Give your diagnosis. Timer starts now. Look at the DSA. There was a hemiparesis following a shunt for an IIH.
Look at the vessels.
There is a stenosis in the proximal part of the ICA.
What's the diagnosis?
Oh, what was the symptoms?
Symptoms were there was a hemiparesis of the right side and following VP shunt for IIH. Time is up.
Dural AV fistula.
Now, so this is an RCVS. Though there are some things like in RCVS, the criteria it's good that it would have been a thunderclap headache, but taking the questions, looking at the DSA, you can find in the ECA there are evidence of spasms. It's well visible. And so the next question, question 4.
Yes, sir. For the next.
Yeah.
Yes, we can take last question. Sir, as you can see the imaging CT and MRI of this patient, you have to tell the diagnosis of this patient. So your timer starts now. What's the diagnosis? I think you have venogram, you have MRI, as well as have your CT. Can you make a guess? Okay. Still have time left.
Which area is involved?
Can you pass? So anyone wants to answer this?
Deep vein thrombosis.
You said deep vein thrombosis.
Any other options? Any other try?
Artery of Percheron.
Let's see.
Okay. So answer for this is deep CVT. It's not deep vein thrombosis, CVT. Right.
Can you just say why it is CVT and not arterial perturbation?
So it's more of like if you can CT, it's cerebral venous sinus thrombosis. Because of that, having patient having venous infarct as well as venous bleed. So arterial Pancheron is different syndrome. It's more of arterial territory.
Yes, that CT finding is very, very important. So having this picture with that CT having hyperdensity there is basically showing the internal cerebral vein thrombosis.
Yes, and arterial Pancheron there will like symmetrical bilateral thalamic infarcts you will able to see. So I think
that's up.
we can close it off.
Up with the,
Yes.
Thank you.
2 minutes we can announce the result. Thank you for everyone. Are all the participants here? 4 of them? Yeah. Sorry, 5 of them? 4. Should I ask all the participants to come in front? We have the results. This is A. Four of them are here, I think. So group A is that one. Yes, I think is group B 50. Yes. This is 100. And last is 15. Who's the fifth person? No, 4 total. Total 4 only. No? So for the group A, total marks received are 30. Congratulations. Can I have a round of applause for him? For group B, ma'am, your marks are 50. Congratulations. Group C, your marks are 100. Congratulations. And group D, your marks are 15. Congratulations. So definitely we have a winner, group C. Congratulations, ma'am. You have won the stroke and neurovascular update grand quiz. I wish you all the best and congratulations again. And also congratulations to all the winners also. Thank you.
We start the post-lunch sessions. I request those standing by the gate to call colleagues who are standing outside to be inside the hall. So it's post-lunch and it's post-stroke also. To chair this session, I would request Dr. Anand Vaishnav. And Dr. Numal Bora to kindly chair this session, and the talk will be delivered by Dr. Nirmal Surya on post-stroke rehabilitation, when to start. Dr. Somnath Jena, if he's here, yeah. You can chair this session. I'd request Dr. Bora also to come and chair this session. Dr. Mosumi. And Dr. Mosumi. Or there you can take the chair there. Over to sir.
Hello. I know it is the end of the day. You must all be tired. And by the time when they come for rehabilitation, our patients are also tired, physically, mentally, and pocket-wise also. And but there is a lot of things which can be done. And yesterday I talked about the future in neuro rehab. Today I'm going to give entire new perspective on post-stroke rehabilitation, how a journey to recovery is there. So you all know that burden of the stroke, and you know that 13.7 million affected, 5.5 million dies, and prevalence Dr. Bora has given you from this area. So important thing is, once a stroke has occurred, there is another risk of second stroke, which is from 5.7 to 51%, and therefore this is a very important point which we have to understand. Now, if a stroke has happened, what does it mean? For patient, it is end of the road. For family, it is beginning of the burden. For physician, it is looking at various interventions. For organization, is investment, and for the nation, is loss of daily. And please understand that no two strokes are alike, and no two patients react similarly to the same situation with same disability. If you look at the stroke impairment at initial and 1 year follow-up, among the various interventions like aphasia, cognition, behavior, dysarthria, dysphagia, hemianopia, hemianesthesia, hemiplegia, incontinence. So for a rehab specialist, there are multiple challenges. For a stroke specialist, is only hypertension, diabetes, look at the CT scan and give the medicine. But for the rehab, there are multiple challenges. And if you look at the kind of impairment at initial, hemiplegia 73%, aphasia 36%, dysphagia 48%, dysarthria 48%, dysphagia 23%, and incontinence 23%. But at 1 year on follow-up, look, many of them still have, 50% of them have the same disability, and that's a big challenge. And if you look at the functional level, from the disability point of view, the mobility at discharge is 80% affected, but at 6 months is 47%. ADL is from 75% to 51%. So 50% patients have affected activity of daily living. And cognition in about 50%. So cognition is something which is not improving because we do not have enough neuropsychologists to do the therapy. And communication about 35% from 50%. And bladder is definitely better from 42% to 70%. And attitude of the patient is real disability, because if a patient attitude is not toward the recovery, then that's much more disability. So what are the facts? Stroke is major cause of locomotor disability. 1/3 ambulate with sufficient endurance to be functional. Supervised training, even in chronic stroke survivor, can improve the outcome. And task-oriented practice is the useful intervention. This is what we have to look at. So how do I train my brain? And this is what is an important graph where, you know, after the stroke, you do the intensive training and motor function improves because of plasticity, and there is a improved function if you do over a period of time in post-stroke. So how the neural plasticity play a part? The direct because of cerebral reorganization or synaptic reorganization. And beyond doubt, when we have checked the cortical mapping, 65% decrease in primary motor cortex, but 40% increase in dorsal prefrontal cortex after the therapy. And you can see that various improvement is being seen through the fMRI on various parts of the body. So this is an important chart, and this tells you that how the stroke care should be. From both acute care to the rehabilitation from rehabilitation unit into the community rehab center to the family center. So this is what is ideally, and these are the protocol which has been followed at the UK, and we really need to emulate them in some way to provide the comprehensive rehab services. So what are the components of stroke care unit? You all have heard about all the three, but third part is multidisciplinary team working towards the rehabilitation, which is goal setting and linking nursing with rehabilitation training, caregivers, and providing the long-term therapy before the discharge plan is being given. So comprehensive stroke care program must have the rehabilitation at stage 4, which is very, very important and has to be part of the stroke care unit, which is lacking in our country. Again, stroke management strategies, and you could see that neuroprotection and the repair is a very important part, and you could also see that physical therapy, occupational therapy, speech therapy. So this again gives you the all three arms for the patient with end-to-end care. You have managing risk factor, you have IAT, and you have intravenous thrombolysis, and then you have drug treatment, and then you have therapy. So this is a comprehensive end-to-end care for the stroke management for the patient. Now, these are the rehab team. You have to have multidisciplinary team. And when to start the therapy, timing of therapy is very important. And now the concept has come, earlier is better. So if a patient is stable within 24 hours to 48 hours, the active rehabilitation should be started, because delay is detrimental to the recovery. This is proved beyond point. So early phase is 0 to 48 hours. So during this phase, you do the movement, passive movement, positioning of the patient, proper leg movement, and then the therapy start, which can be traditional therapy. The traditional therapy can be in the bed, therapy start in ICU, and the most important thing is the tilt table. So if a patient, even though cannot be made to sit and stand, if you take the tilt table, and I give you an example, 38-year-old male, right hemiplegia, day 7 with large intracerebral bleed, has been made to stand on the tilt table gradually, starting with 30 degree and taking over to 180 degree. So tilt table for the rehab is a very, very important, because we mobilize even patients with the tracheostomy and with the ventilator onto the tilt table as early as 7 to 10 days if they are stable. I give you an example, and mind you, why I'm giving you this example is that how important rehab is. You have heard about how thrombolysis can change, how mechanical thrombectomy can do the miracle, but we also do the miracle, and we do the miracle when everybody fails. So here I give you an example, and mind you, this is 10-year-old story. So 82-year-old female, admitted in February 13, left hemiplegia, known hypertensive, with history of stroke in past in 96 and 2003, so 2 stroke. And she stopped the antiplatelet drug, she was known, and she came with the left side grade 2 power. We did the CT and MRI. There was an acute right MC infarct, the right carotid occlusion, left parietal meningioma, and old left MC infarct. You can see that this is an acute infarct, this is a chronic infarct, this is the meningioma here, and these are the occlusion of both. This is complete occlusion, and this is partly. So patient was started sitting on the edge of bed with and without support from 5th day onward on tilt table within 1 week, and see at 20 days with one person and therapist support, patient went home walking. So 82-year-old, multiple infarct, carotid occlusion, meningioma, yet we were able to send the patient walking home at 20 days, which is, what rehab can do. So what are the criteria? When to mobilize? So these are some of the criteria when you should mobilize and when you should not mobilize. They are listed, and these are very important because this helps you to plan the rehabilitation for the patient. Now, what are the rehab methods? You may not know, you need not know, but these are the various therapies which has been available. And yesterday I mentioned some of them, but these are some of the more therapies like FES, task-specific, CIMT I talked about yesterday, aerobic exercise, gait training, NDT, BOBAT, Burnstorm, EMG biofeedback, body-supported treadmill, and specific devices which can be assistive, tele-rehab, robo, virtual reality, and imaging. So these are the body weight supported treadmill training, and these are the patient, and I give you an example. This gentleman and this treadmill we started in 2003 at Nair Hospital, which is a government municipal hospital, where I started the neuro rehab unit in 2000. And what we did, those days the body supported gear used to be costing about 10 lakh rupees. And so I donated my treadmill here. And what we did is we built up a frame here, on wooden frame on top. And these are the various belts, lumbar, thoracic, which we united. And we formed a frame which linked to this belt. And this costed me 25,000, and patient was started. This is gentleman with left-sided stroke. We gave the Botox in the upper and lower limb, and he was treated by my physiotherapist. He's now professor. He was lecturer that time on the treadmill at BMC hospital when private hospital did not have treadmill training facility. So we need to innovate as per our cost and low cost therapy. So this helped the patient with stroke who have no proper gait. And there are a lot of evidence which says that treadmill training helps the patient improve their gait and motor power. These are the robotic therapy, and robots has been used. Yesterday also I talked about 20 years they have been here. These are lower limb robot, these are upper limb robot. Yesterday also I shown you there are specific robot for finger, wrist, elbow, and for the shoulder, and similarly for the hip, knee, and this. And important thing is you can focus on one group at a time or one joint at a time. You can do the exercises which can be checked, and these are the locomote, which is most famous, and it is most effective for the training and gait. And the important thing is those patients who have less than 2 power, where you can't even stand, the knee can buckle, can be treated on the locomote. CIMT I talked about yesterday, and this is a level 1 evidence of the motor recovery in a patient whose normal hand has been tied and the paralyzed hand has to be used for 8 days. Mirror therapy also I mentioned yesterday, particularly for hemi-neglect, is a wonderful. And the mental practice is something is coming. So you ask the patient to imagine that he's moving the hand and doing the function. So this is mental imaging, and there are evidence that if you do regularly for 10 to 60 minutes, 3 to 10 weeks, the new connection happen and patient movement get better. And these are some of the evidence-based papers which says that mental practice can help patient with hemiparesis after the stroke. So another is bilateral arm training. So another, you function both the hands. So today morning when this gentleman asked me, sir, how do I improve my left hand? So I told him, do something where both the hands are involved. He said, what? I said, play piano, because your both hand will function. Both hand will function in tandem. That means you are developing the connection between the two hemispheres. Similarly, play the tabla, because both has to go into the harmony. So wherever you could function both hand on any system, start doing computer, because both hand has to work together. So bilateral arm training is something which is coming in a very big way, and these are no cost. You can easily ask your patient to do it for half an hour to 1 hour every day beside whatever therapy is doing. And Virtual reality is something which is again coming in a big way. I explained yesterday, various trials have shown improvement in various parts, both gait, cognition, and visual rehabilitation. Repetitive transmagnetic stimulation, I spoke yesterday, particularly for both acute chronic stroke as well as in the aphasia. Similarly, TDCS, again, stimulating the brain, both anode or cathode, either on the side where the paralysis is there, that is damaged brain versus normal brain, to suppress the normal brain or stimulate the damaged brain. You have to decide which way you are going to do the thing. FES is something, again, very, very important. It's very low cost. Again, it can help in functioning of the hand, or it can also help in functioning of the leg. So here in the hand, if you are doing a function at the same time when you want the hand to be in a specific position, the stimulation comes and patient is able to use that hand. Similarly, while walking, when he has to lift his foot, that is the time stimulation is being given and the patient lift his leg and walk better. So these are some of the things which can be done. Botulinum day toxin is an add-on therapy. It reduces the focal spasticity. Yesterday only, day before yesterday, I gave the patient with the right hand severe spasticity, 10-year-old stroke because of the aneurysmal in a young female, and the severe not able to open the finger and not able to hold, though the power is reasonably good. So I have given into the flexors of the hand to open the hand and also release the pectoralis and biceps. The patient immediately within 1 hour has started reducing in the spasticity, was able to hold the glass and drink the water from the glass. So problem is in releasing, and in next 1 week therapy they will do. So botulinum toxin, all of you must learn to use it in post-stroke spasticity. Occupational therapies is something which is very important because these are the one who do the activity of daily living and the hand functioning. So occupational therapy job is hand function and ADL. So they are the one who do all the things. Similarly, speech and language therapy for both aphasia, dysarthria, as well as for the swallowing. These are important, and you have to do the assessment regularly on the beginning, in the hospital, and at the time of discharge. RTMS and TCDS are the one which can help people with the aphasia. Dysphagia is something which you have to assess because it can cause pneumonia, aspiration, and nutrition deficiency. So that's important. We did a study in our resident DM. While doing DM, he has done assessment of all stroke patients who are admitted for the aphasia, for the dysphagia, and you could see that at 12% patient on discharge had dysphagia on the anterior circulation and 42% patient in the posterior circulation. So it can tell you that those who do not recover has a severe lesion, and it is the posterior fossa lesion which do not recover. Similarly, cognitive rehab is important, as I mentioned to you, and there are various interventions are available which can be done. So what are the projective predictors? You can see that length of rehabilitation is as long as patient do not regain what he has lost, the rehab has to be continued, and you cannot fix that it is for 3 months or 6 months, and MDT has to decide which therapy to be given the priority. So stroke-related disability can impact greatly on a patient's quality of life and ability to live independently. Effective neuro rehab plays a central role in the recovery of these patients. The NICE guidelines are there which can help you to plan out the therapy. MDT is a pivotal aspect in implementing effective patient-centered therapy. There is a constant need to explore novel path-breaking therapies to complement or enhance the current practice. There are several trials and novel therapies are underway which going to be the most important in the future, time will tell, and research is what something required. This new technology gives you great hope for the future, and we look forward to a great new era. These are some of the chapters. You want to read more, you can read Advance in Rehabilitation of the Stroke, Stroke Rehab, and this is the book which is PDF available free from WFNR, Clinical Pathways in Stroke Rehab, and I have also contributed one of the chapter. So those who want to learn more about the neuro rehab, IFNR textbook of neuro rehabilitation is now available. You can have it from the market. I think Amazon it will be available. Thank you very much.
Thank you so much, sir. came to know so many things about neurorehabilitation. Sir, I have a question in my mind regarding the Delhi. Isn't any difference in Western and like India? Like I read in an article that it's almost 3.5 to 5 years average. So is there any difference of Delhi in these two areas?
See, the Delhi is affected. Now, what you want to ask me is how in India it is affected.
Yes, sir. Is it more like in comparison to the Western countries?
So we do not have any data about two things, about the expenses load on the government, so how much financial loss after the stroke in this country when a patient suffer, because patients suffer and families suffer. So we don't have that data. We also don't have daily data, but once a patient has stroke, 40% patient have a disability, even at the end of 6 months and 1 year. Many of them are not going to be back to the work. Also, those, even if they have back onto the work, they are not able to efficiently work because hand function is something which is affected. So out of 100 patients, only 40 to 50% patients are back to the normal life. Rest all have some form of disability. So we really need to do a systematic study to find out how much Delhi has been affected in these patients.
Thank you, sir.
Yeah, it was a wonderful presentation as usual with Dr. Surya. I'm really inspired by your presentation.
Thank you.
Really. Now the topic is open for discussion, questions or comments from the audience. Any questions or comments? No? His presentation should inspire us to set up a...
I feel that you should develop a hospital, another one, only dedicated to neurorehab.
Neurorehabilitation. That should be done. He has been telling me.
In the Northeast.
For
I
a
think you
long
got
time.
4 hospitals, get one more for the neurorehab.
Yeah, one neurorehabilitation hospital. That's the right thing, probably appropriate contribution to the patients. Appropriate contribution to the patient. Thank you, Dr. Surya.
Thank you, sir.
Thank you very much. So you have inspired us all, probably, from this presentation.
Thank you so much, sir. And now we have the neurology ground rounds, and we have 3 people who will be presenting cases. I'd like to chair the chairpersons to stay and Dr. Rahul Barua to join them as chairperson. Yeah, and we have 3 of them, and Dr. Neelav, Dr. Mandar, and Dr. Apratim. I request Dr. Neelav to come forward. We'll be taking around 8 minutes each case, so we're expecting it to finish off in 25 minutes.
Good afternoon, respected seniors and dear colleagues. I would like to thank the organizers for providing me this opportunity. So, a 65-year-old gentleman who is a known case of hypertension presents to us with 3 episodes of short-lasting weakness on the right side of body in the preceding 5 days, each of the episodes lasting around 5 to 10 minutes. Each episode starts with weakness initially involving the lower limbs, and then it marches with involvement of the upper limb. The weakness was to such an extent that the patient was not able to raise the respective limbs and had a difficulty in making a grip. There were no associated tonic-clonic movement of limbs, loss of consciousness, altered behavior, or headache. On examination, patient had a blood pressure of 170/100, pulse was 86 per minute regular. General physical examination was unremarkable, patient was conscious oriented. Fundus were bilateral normal, no cranial nerve abnormalities. Motor sensory cerebellar examination was normal at the time of presentation. So we have an elderly patient who has presented to us with a recurrent short-lasting focal neurological deficit. The differential diagnosis include TIAs, focal seizures, migraine with aura, sometimes ecphalgic migraine, electrolyte disorders, metabolic disorders such as hypoglycemia, and in elderly patients, TFNE associated with CAA. Initial investigations, blood sugar was normal. ECG showed evidence of left ventricular hypertrophy. Echo showed grade 1 diastolic dysfunction. Bilateral carotid Doppler was within normal limits. Patient had a LDL of 70. And since he had some marching of symptoms, we also did an EEG, which was within normal limits. This is the diffusion weighted imaging. And what you can see on your left is the T1, and on the right are the FLAIR images. Now, if we look a little carefully, we can see T1 and FLAIR hyperintense lesions involving the high convexity cortex in the sulcar areas, suggestive of a subacute convexity subarachnoid hemorrhage. Now, the differential diagnosis of a convexity subarachnoid hemorrhage include RCVS, CRESS, cerebral amyloid angiopathy, CVT, cavernous angioma, avidural fistula, cocaine, and cranial trauma. Patient's angiography was within normal limits, and susceptibility weighted imaging revealed extensive cortical superficial siderosis. Presence of these findings in the SWI with a presentation of recurrent transient focal neurological episodes made us to reach a diagnosis of cerebral amyloid angiopathy presenting with amyloid spills. The patient and attendants were reassured. The patient's blood pressure was controlled with amlodipine and perindopril. Patient did not develop subsequent episodes and had no complaints at 1 month follow-up. So amyloid spells are a less common manifestation of cerebral amyloid angiopathy, and patients report recurrent, brief, and often serotype episodes of weakness, numbness, paresthesias, and sometimes other cortical symptoms, which can spread smoothly over contiguous body parts. These episodes may reflect abnormal cortical activity in response to small hemorrhages. Now, it is important to distinguish amyloid spells from the routine ischemic TIA, because if we give antithrombotic to these patients, they may develop hemorrhage in the future. So clinical features that are more suggestive of TFNE or amyloid spells include the smooth spread of symptoms over minutes and the stereotypic recurrence, that is the same pattern of symptoms over and over again. The diagnostic criteria for a probable cerebral amyloid angiopathy is an age of more than 50 years, presence of either spontaneous ICH, TFNE, or cognitive involvement, 2 or more lobar hemorrhage lesions, and absence of other causes of hemorrhage. So the message is that every symptoms that may look like TIA may not be TIA, and we should be able to distinguish between the two conditions, because sometimes if we wrongly treat them as TIA, we may be causing more harm than good. Thank you.
Good afternoon, everyone. I'll be presenting a case. He was a doctor, 54 years, male, with a past history of hypertension, cardiac history with a post-PTCA status, without any LV dysfunction, and was on ecosprin, and he was compliant. There was no addiction history, and found to have left-sided weakness with dysarthria in the morning hours. This was our patient in December 2020. He was suddenly rushed to ER. He was in window period. As you can see, the CT scan showed the old infarct on the left MCA territory, but the right side, there's not much of infarct with a significant perfusion mismatch. And on the angiogram, you can see there was the right MC occlusion. We immediately shifted him for the mechanical thrombectomy. Right M1 occlusion was there. We underwent mechanical thrombectomy. The ticket 2C recanalization was carried out, and there was no procedural complications. He was evaluated for the cause of the MC occlusion. His echo showed 50% of ejection fraction, and there was mild apical hypokinesia. Apart from nothing significant was found, and he was started on dual antiplatelet, that was ecosprin 150 and clopidogrel 75 mg, and he was discharged with a minor residual deficit. He was stable for approximately next 6 months after this first event. He resumed work, and what happened? After 6 months, he developed sudden onset confusion, one episode of GTCS followed by altered sensorium. After 6 months, this was. And he was again rushed to ER on examination, found to have NIHS of 7, and again shifted for stat MRI brain. As you can see, this time there was small embolic infarct on the left side, like insular cortex as well as some high frontal cortex area, and there was no significant stenosis or occlusion in the major of the arteries on angiogram. So IV thrombolysis was given as he was in window period, and partial improvement was noted. So what do you think in this case? The patient initially had on the right side, then on the left side. The most probable in my case was the cardioembolic, as there was some apical hypokinesia in this patient. Second possibility we get to vasculitis, hypercoagulable state, and he needs more workup. This time, because second episode he presented with GTCS. So what you want to further plan of line of investigation? Obviously you will be doing a EEG. Apart from that, Holter monitoring, transthoracic or transesophageal echocardiography, again repeat, vasculitic workup, and all of this what I told. His EEG showed some mild left temporal sharp activity without any other abnormality. Homocysteine was fine. Viral markers was negative. Cardiac markers were which is actually within normal limit despite having a mild hypokinesia on 2D echo. And second time echo showed akinetic apex with the EF of 50%. We did a 24 hours Holter recording which did not show any significant abnormality. After that second episode, he was started on Clexane 0.6 BD during admission and discharged on acetrom 2 mg. This time we shifted to anticoagulants after putting on Clexane and single antiplatelet, that is Ecosprin 75. So what exactly can go wrong again after this? So the third episode which happened immediately 48 hours after his second episode, again he had a GTCS followed by right-sided weakness. We thought it's a Todd's palsy. His NIHS was high on the right side. She again shifted to MRI and possibility of, in view of possibility of Todd's palsy again. But in this we see a large left MCA territory infarct without any much on the flare imaging. There was a gross perfusion mismatch deficit, large penumbra. We went for mechanical thrombectomy where we see a left M1 MC occlusion. The first case there was a right side, now we have a left side MC occlusion. We went ahead, had a TK2B recanalization. We had a small dissection for which he underwent a intracanal emergence stenting during the procedure, and the rest of the procedure was fine. After that we repeated the 2D scan. Akinetic apex was there, EF was 45 to 50% as before. No thrombus or clot was found. He was started on NOAC dabigatran 110 mg twice BD and ticagrelol 90 mg BD. The risk of bleeding, yes, was explained to the family as I was having recurrent stroke. This was the third episode with the incident of GTCS. Partial improvement was aphasia was found. Rest his power was maintained. He was stable for next 2 months. And again brought to ER with the fourth episode of dizziness and shuffling gait for a few minutes. This time there was no GTCS, no limb weakness. On examination was found to have power 4, grade 4 power on all 4 limbs, apart from residual aphasia from the third episode. MRI again showed a small embolic infarct, again on the left side. 3D reconstruction showed the stent artifact, but no major occlusion this time or stenosis this time. We again repeated the EEG. EEG this time did not show any much abnormality. We repeated the echo scan. Again there was some kinetic septum with the ejection fraction of same for 45% without any floating clot in LV, LA or LV. Again we changed the medication to Clexane and started on Brilinta ticagrelol 90 mg BD. He is discharged without any residual deficit this time after the first episode. So what exactly goes wrong in this patient? He was again stable for 2 months. Again, fifth time he had an episode of GTCS which was witnessed by wife, brought to ER, cord brain was again activated. This time again he had a perfusion deficit, and at this time, the fifth time, now he had a right MCM1 occlusion. We went ahead on the DSA, we had found a IC occlusion. We went ahead, opened it. Procedure went uneventful. So patient having recurrent episodes of stroke in background setting of cardiac history, that is akinetic apex, but which was not there in the first event when the patient was presented with the right MCA stroke. See, he had 3 episodes of left MCA, 2 episodes of right side. So what is the further line of investigation this patient? Repeat again Holter, transthoracic echo, hyperglobular state workup, PET scan, and all of them to find out whether it's exactly a cardioembolic or hypercoagulable or malignancy related. We rule out everything as he himself was a doctor. We again repeated the echo scan, showed again hypokinetic IVS or kinetics apex, and EF remained the same. We did a TCD also. There was no evidence of shunt. Repeat Holter monitoring for that is for 48 hours. There was no paroxysmal AF in this patient. We repeated a D-dimer, which was quite a little bit high, like 2084 in this patient. Serum calcium was fine. The rest of the metabolic workup, vasculitic workup, the detailed vascularity workup, CNK, PNK, and everything was coming normal. So what exactly what we thought, we have ruled out, not 100% ruled out, but we have ruled whatever the investigation was planned during that time. We had ruled out vasculitis, we had ruled out malignancy. The histopathology report was sent for the rectosigmoid and esophagus. It came out to be normal, nothing significant was found. FDG PET scan was done. We did not revealed any predominant significant findings. His PSA level was normal. So he was discharged finally after the 5th episode with injection Clexane 0.6 BD and clopidogrel 75. Till now, there are no recurrence of symptoms after this when he was put on clopidogrel. Initially, he was on aspirin, he was on NOACs, he was on dual antiplatelets, ecosprin and clopidogrel. But this is the last regimen after his 5th episode of recurrent stroke. We had put him on Clexane 0.6 BD and Plavix, and still now he has not got any fresh episode of stroke. So what exactly what comes in mind? What exactly we have done next? Whether we had repeated again the loop recorder for a paroxysmal event, repeat the transthoracic or transvisual echogradiography, follow up the D-dimer, why his D-dimer was persistently high, and work up for the paraneoplastic syndrome next, and just pray. I think that's what we have thought about this. Thank you.
Thank you so much. Do you have any questions?
Sir, I have a question. Sir, is there a role of cardiac MRI in such patients?
Yes, there has to be a role of cardiac. We have planned that, but initially, as he was a doctor, he was not initially more of reluctant towards the cardiac MRI, but on the follow-up image, we have planned that the cardiac MRI.
How about hypercoagulable state, I think, and I think your D-dimer of 2000, I think that needs to be followed up. And because I think it's one of those conditions, I think there's just a paper in neurology last month where they took this D-dimer related, paraneoplastic strokes, and there was no difference between anticoagulation and aspirin or whatever you give. So I think when somebody gets recurrent events, I think there's an hypercoagulable state which would come at the top of the mind, and second one would be vasculitis. I think those are the two things I would think,
Yes. Thank you. Yes.
Yeah. One, I'll strongly feel something related to hypercoagulable state, number one. Second, it could be a paroxysmal disorder which comes and goes away.
Yes.
And at that time, he throws embolus and it produces stroke. And when you examine him, it is gone, except the stroke or the infarct. You don't get to see anything. Right? It happens.
Right.
It can happen. It could be either related to hypercoagulable state or a paroxysmal cardiac disorder, most likely, because it is throwing embolus the right, left, everywhere.
True, sir.
So, probably of cardiac origin, he must have some cardiac paroxysmal disorders, arrhythmia, which have escaped diagnosis up till now. It can so happen. Possible. It happened in my case. It happened in my case. Okay, it took 5 years to make a diagnosis.
Maybe that's the reason we have kept him right now on Clexane only. He is not only on aspirin.
Treatment is okay. You are giving prophylactic treatment.
Yes.
It is working. That's why your patient is all right.
Yes.
But cause yet we do not know.
True.
Continuously look for it.
I'm planning for the cardiac MRI on next follow-up visit. Maybe it can help. Thank you.
Good afternoon again. So my last case for this was meant mainly for stroke case discussion, put in now for the grand round, but I think it will be more of a management related issue in the cath lab related to the stroke intervention. So this gentleman, this lady came 68 year aged, presented with altered sensorium with left-sided weakness and facial droop, 5 hours duration, which kept on progressing to quadriparesis once she was shifted to the CT. Some non-very significant past history. This was the initial CT scan. You can see the hyperdense basilar sign. You can see in the CT angio at the same time there is a you can hardly find out beyond the proximal basilar. And you can also see in the arch, you can see a right-sided subclavian stenosis being there. So all this we have to initially see along with the perfusion scan and the history to, since the patient was already 5 years outside the thrombolysis window, we're directly planning for the cath lab procedure, and we have to plan the arch and everything and what is there so that we have fastest access when we take the patient to the cath lab. So having this picture, we had a closer look at the CT and especially the base angio, the base axial image of the CT angio. So that's a very good estimator of the amount of infarcted tissue. Not only that, sometimes as you can see in this case, here I will show you. You can see there is a luminal filling defect here. So there is a clot, and along with that there is a preceding stenosis. So this is the diagram we have schematically drawn. So you have a occluded segment preceding that. Above that there is a clot sitting. You can find the clot, and also before that you have an stenosis. So this is a very difficult scenario for an interventionist, because if you open the stenosis, you have always a chance of the clot migrating distally. Number two, if you try to take the clot out, aspiration is difficult because it gets trapped in the aspiration of the clot is hampered in the occluded in the stenotic segment, and also while bringing the stent in the stent retriever, you may lose the clot. So, but you have no option. You have to open it because the patient is symptomatic and is quadriparating at present. So, with all these issues in mind, and with the right-sided subclavian stenosis, so left side being the dominant vertebral, so no question, we decided to go in with the left side first. You can see the stent markers here. We went in with the stent retriever, the solitaire we used, and we tried to retract the clot. But just after the first pass, this is what we found. Obviously the clot had, one part of the clot had migrated and occluded the left PCA P1, as you can see. And you can see the stenotic segment as well. This is after the first pass. We went on waiting a bit. Second run, the artery again collapsed. So the classic angiographic hallmark of what you call an ICAD, and we keep on facing such difficult scenarios day in and day out. So so what to do? So now first pass we have found out one clot gone distally, and again the artery has closed down. So again with the same maneuver we put the stent, and with the stent there, stentoplasty, with the solitaire, the stent retriever being there, we tried to take a shot, and again we confirmed that this is the stenotic segment and the P1 is occluded by the migrated clot. So what to do? Now we took the other runs. So the two things are there, whether two decision makings need to be done. Number one, whether we should chase the P1, whether at all it is worth chasing the P1. Number two, because number two is, or we should directly just put a stent and open the basilar because it is collapsing once we remove the stent. So whether we should do an angioplasty stenting of the basilar, rescue angioplasty stenting. So two decisions. So for that we took a left-sided ICA run to see how is the PCOM. Did not find, and however we could see from the leptomeningeal collaterals, from the PCA and the PCA collaterals, you can see from the MCA collaterals, leptomeningeal, you can see the P2 segment and distally being reformed. So mainly the main concern decision was at that hour, okay, we have to somehow as much as possible, if we cannot recanalize the whole part, we have to somehow recanalize the P1. We have to give it an attempt. So for that we again took our assembly in. There's a third pass, and with the stentoplasty, with the stent being there, we did a stentoplasty first. We kept the stent there for some duration, and then with the you can see the micro passing into the left PCA over a wire in the U shape. We tried to do a thrombectomy there, but we hardly could take the whole clot out. We somehow recanalized the P1 segment, which is a perforator-rich segment of the left PCA, and then we were left with this stenotic segment. Now, there was no doubt that we have opened the P1 perforator, the P2 and distal being taken care by the leptomeningeal. So to some extent the damage being recovered. This is the third and the fourth pass, already maybe like 1.5 hours into the procedure. Now the decision is to do a quick angioplasty stenting of the basilar and come out. So before that, obviously the protocol of asking the anesthetist to load with antiplatelets, having a wait of some duration. So once we took the decision, before only we loaded with, on table we loaded with aspirin and Brilinta with Ryle's tube, and then already half an hour was gone by the time we took this shot. So repeatedly it kept on collapsing, so we had to load and plan for balloon angioplasty stenting. But while doing so, there was one more thing which happened. So when we took the run after just taking this out for angioplasty stenting, you can see the left-sided vertebral dissection, and it was actually the extracranial segment. You can see the extravasation, the active bleeding during the leakage of the contrast during the taking the runs. So now we are stuck, the left side being dominant, the right side having a stenosis already, subclavian, and the left side all having dissection. So how to put, if we do not put a angioplasty stenting, there is no benefit we will get from opening the P1. So no option, but we decided, already loaded with Brilinta and aspirin, so further difficult situation. But we just after some time, when we took a run, waiting for some time, planning for putting the coils because it was actively leaking. When we were arranging the coils and everything, we took the run and we saw that, okay, the dissection is to some extent settled, there is no active extravasation then. So the decision of putting coils and occluding that part was kept in abeyance, and then we decided to go in with the opposite side. The opposite side, as I said, had a subclavian stenosis, so it was very difficult to manipulate our sheets. It was repeatedly kinking, and even with the best of the braided sheets also, it was repeatedly kinking. So we had to take with the Ampla stiff wire, and with the stiff wire we could somehow enter the right vertebral in the sheet, and then did as the angioplasty stenting of the right side. So this was the final run also taken from the left side. You can see the dissection is also settled. The stent in there, the basilar is somehow reconstructed, and the left P1 perforator region is taken care of. Of course, the P2, P3 we have to depend on the collaterals. This was the MRI repeated 12 hours after procedure and at discharge. So this is how things went with this patient. The idea of bringing this case was like, as we said in the opening slide, so prepare for the battle. So any case of thrombectomy, whenever we go in, it is not always like 10 minutes, 12 minutes. Yes, many cases we have done in 10 minutes time, we have done in 12 minutes time, but all the apparatus, anything can go wrong anytime, any moment. So you should have backups. You should have stents in the cath lab, should be well oriented. It is not always goes, very easy in every procedure. So we always should be prepared for the outcomes, the complications, and manage accordingly. Thank you.
Any questions?
Yeah, it's a beautiful presentation and a really difficult case. A few things I wanted to ask, do you regularly do a full DSA prior to a thrombectomy?
No. So the thrombectomy is an emergency procedure. So doing a DSA is matterless. So we have already done CT angio. We know the anatomy. We directly go in. The target is to open the occluded vessel. In this case, we took another run in the ICA because we had to take these decisions while we went in, because there were issues coming up.
Yeah. Secondly, if we see the initial angio, we can see the top of the basilar filling despite the clot and the stenosis.
So
do you think that is a reverse flow from the PCOM into the basilar which is filling it, or it's a flow across the stenosed and the...
It was probably a flow across the stenosed segment. It was a flow across the stenosed segment because the left side PCOM was not VA, but it was a flow across the stenosed segment.
Okay, but right ICI we haven't seen, I think, on DSA.
Right ICA was not seen, yes.
Was not seen yet, okay.
But
And
anyways,
second-
it was closing down, so we had to open up.
And when you are using a solitaire, can you deploy a solitaire or not? If the thing was closing up, is the solitaire deployable or not
Yeah,
in
so
this
this
stage?
stent
Instead
was
of
not a
going-
detachable one. We have some detachable stents, but we don't use that.
Thank you so much.
Hello. Dr. Apratim, nice case. I just wanted to ask one thing. So you have already loaded the patient with antiplatelets on the table, and you already placed a stent in the basilar. We were thinking about stenting the dissected vertebral segment also.
Can you just come up? Sorry.
Have you thought about stenting the dissected vertebral segment on the left side, the V3 segment?
Which segment?
The dissected segment, the left vertebral.
The left vertebral?
Yeah.
No, we did not, because it was the dissection was we showed in the last run was well taken care of. It was the right side was also flowing well, and the basilar was done, and it was already like 6 hours, and the patient was stable. Like the left side vertebral dissection was stable even after 6 hours, the last run which we took. So that's why we did not put it.
And is it advisable to do a check angiogram after a few days to see whether the dissection has been spontaneously
absolutely.
healed?
We are planning that.
Okay, thank you.
I think the question is for not only this case, but for most of our interventional folks. When do you use IV, tirofibam, GP2B3A inhibitors,
Yeah, so
I think trials have been, I think RCT is going to be very difficult. They've been negative, but select cases, they are being used. So I think.
Yeah, so I think we in our center are more with abciximab, but tirofiban is widely used, and the recent trials with ICAD, especially for rescue stenting, that tirofiban, as we discussed last day also, tirofiban in these cases, in these scenarios where you might have to give a rescue stent, even the patient comes within the window, that may be initially given in lieu of the thrombolysis, so showing good outcomes. The recent paper has come comparing the two.
Thank you so much.
Thanks.
Thanks to all our speakers. We come to the end of the grand round, and now we have Dr. Lakhyava Sumatari, who is here to talk on spasticity in stroke.
A very good afternoon, and actually this is not the right time to talk, because post-lunch most of the people, they go to sleep. So maybe we'll just talk, I'll try to keep you awake. So my sincere thanks goes to Dr. Biplab and for giving me this opportunity. So I'll be talking in brief about spasticity in stroke. So, and how we approach a patient with spasticity. Already the Neurosurgery sir has already covered some part of this management of spasticity in rehabilitation. So I don't have any conflict. So the objective in this talk will be probable problem identification and clinical assessment, treatment goal setting, pharmacological treatment, role of botulinum toxin, then pattern of spasticity, then muscle selection and doses. So spasticity is a upper motor neuron syndrome. It's a part of upper motor neuron syndrome. The other being like muscle weakness and improper coordination. These constitute UMN syndrome. So it's a part. It's a motor disorder which is characterized as velocity dependent increase in tonic stress reflexes with exerted tendon jerks. So it resulting from hyperexcitability of the stress reflex as one of the component, as I have already mentioned. So it can be focal, multifocal, segmental, hemispastic, paraspastic, or generalized spasticity. So when do you see spasticity post-stroke? So there are many papers, they have shown that it can appear as early as 3 days post-stroke. And if you see the prevalence of spasticity after stroke, it is highest in between 4 to 6 months, and it keeps on increasing till 12 months post-stroke. So these are the negative impact of spasticity, that there will be impaired hygiene, then impaired self-care, then there will be problem with transfer from bed, there will be bed sores, etc. And then, so how someone predicts this stroke patient will have spasticity or not? So if we can predict early spasticity, we can prevent, we can take precautionary measure, or we can take intervention so that the patient have a good quality of life. So this is a part of cell growth study. The cell growth study is stroke arm longitudinal study at the University of Gothenburg, Sweden. So actually they have found that they created a predictive model. According to this model, it is based at the 4 weeks, and it gives a sensitivity of 90% and specificity of 92%. So they found out that impaired sensory motor function following stroke is a greater predictor of this patient will develop spasticity in future than severe arm paralysis. And spasticity in early phase, that is less than 4 weeks of post-stroke, these three are the strong predictor for future generation of spasticity. So what are the patterns of spasticity we see? There are generally 5 patterns, we call them as a Hefter pattern. So type pattern 3 is most common, which includes internal rotation and adduction at shoulder, flexion at elbow, then the neutral position of the forearm and the neutral position of the wrist. So these are the common pattern of spasticity in the lower limb: adducted thigh, flexed knee, extended knee, and plantar flex, foot ankle, then equinovarus foot, straddle toe, and a fixed flexed toe. So these are the important historical points you have to inquire whenever you are going to intervene or assess a patient with spasticity. That although this is a very long list, but these are very important, that whether this spasticity is constant or it comes and goes, whether there is any tightness or related to spasm, or is there any associated pain. So these are the questions, and is there any medical history, medical problem. You have to ask all these questions before you approach a patient of spasticity. So these are the practical clinical examination sequence when you have to do. You have to observe the patient, then you have to observe the patient during active action, then passive. During passive state, you have to see the passive range of motion, strength, muscle tone, etc., and functional activity of the patient. And commonly we assess spasticity with a modified Ashworth scale. So if modified Ashworth scale is more than 2, that is 3, that means there is a considerable amount of spasticity and you have to intervene by some means. Then this is another scale for spasticity, that is called Tardieu scale. The difference between modified Ashworth scale and Tardieu scale is that Tardieu scale, you can identify this patient is having spasticity or contracture. So it differentiates between contracture and spasticity. That is the advantage. Then this is very important because you cannot leave the patient with the pain. So you have to assess the spasticity associated arm pain scale with this SAP scale. Then the most important thing is goal setting, because the presence of spasticity does not mean that you have to inject something, some agent like botulinum toxin, alcohol, or phenol. The mere presence is not always an indication or reason to start a treatment, because sometimes spasticity can be helpful. Like it can restore the circulation, it can prevent DVT, and in the lower limb, if there is spasticity in the lower limb, it can help the patient to stand. They can leverage the spasticity. So spasticity does not always mean that it's a bad thing. And intervention ought to be considered not only based on severity, but also you have to consider the functional significance and impact on quality of life. Then the first important step is the rationale for treatment by identifying goals. You have to identify the goal. So this is a useful matrix where you can approach, and we can approach with a mnemonics called SMARTER. It should be specific. What is your specific goal? Whether you want to release the right hand fingers so that the patient can use the fingers. It should be very specific what you are going to achieve. Then it should be measurable and meaningful, and these goals should be agreed upon by caregiver, by patient, and the doctor. This all have to come to a common ground. And it should be realistic goal. It cannot, it should not be unrealistic like I'm going to compete in the state level football or state level cricket after stroke. So that is not a realistic goal. And it should be time bound. There should be particular time and evaluated, and it should be revised. And this is very important. That is goal attainment scaling. This scaling, this evidence demonstrated that when patients involved in goal setting, they are more likely to achieve their goals. And you can track their achievement and you can prioritize their outcome. So what are the treatment goals? There are basic rules that the relief of symptoms. The most common is the pain relief. Then muscle spasm frequency, then involuntary movement like if there could be bellism, there could be chorea, there are some other involuntary movement associated with stroke. Then active function, the functional improvement, then the passive function like decreased caregiver burden, like ease of moving the limbs, spastic limb, handling and positioning, and routine day-to-day care like perineal hygiene, dressing, etc. So how do we manage spasticity? So this table will show you the comprehensive, the oral agent, neurolysis, botulinum toxin, baclofen therapy, and surgical intervention. So I'm going to only show a few slides on, because this is a Cochrane review. They have shown that the oral agents are not that effective. Oral agents can be tried in segmental and generalized spasticity, but they come with a side effect. So botulinum toxin treatment, these are the formulation of botulinum toxin. We commonly use here Botox and Zarbot. And this botulinum toxin approved in 2010 in upper limb spasticity, 2016 in lower limb spasticity by US FDA. So I'll just skip the trial. So what does the botulinum toxin do in post-stroke spasticity? They do not give you the strength. They will improve the basic upper motor functional activities like dressing, then some common function like opening jars and ability to use the cutlery, etc. Then they also reduces the muscle tone. This is the meta-analysis they have shown, and they have also shown that the gait velocity is marginally increased. So I'll show you this. This is the common pattern of spasticity following stroke. You can see the adducted shoulder, then the flex elbow, already I have described, then circumduction gait. So I would like to do the injection, the botulinum toxin injection under ultrasound guided, because it's most precise. Also, I prefer EMG more than the ultrasound. So these are the common pattern where you have to inject. These are the particular muscle, pectoralis major, etc. Because of time, I will not go into detail. Flex elbow, pronated forearm, flex wrist, clenched wrist, thumb in palm, intrinsic plus hand, and this is the lower limb, and equinus deformity, striatal toe. So takeaway from this talk is the early identification and treatment should be embedded in clinical routine practice, and we have to identify the post-stroke spasticity at the earliest so that we can give a better quality of life. And the botulinum toxin injection has proven beyond doubt that both works in upper and lower limb spasticity. Thank you, and this is my acknowledgement to my mentors. We did a workshop on botulinum toxin in post-stroke spasticity. I thank the organizer for supporting me in this workshop, and it was graced by Professor Vinay Goyal and Professor Sanjay Pandey. Thank you for your attention.
Thank you, sir. Do you have any questions?
Thank you, Dr. Laksha, for your wonderful presentation. I just want to know, like, do you have to repeat the botulinum toxin? What is the duration like?
Yes, it's a very nice. It's a very good question. Botulinum toxin, by and large, it works. The duration of action lasts for 3 to 4 months. So you have to repeat the injection every 3 months or 4 months. Yes, but there are newer formulations that is coming. Lenobotulinum toxin that is in the studies they have found that it lasts 6 months. That is longer acting botulinum toxin, but it's not marketed in India till now.
Thank you.
Okay, sir.
Okay.
Thank you.
Thank you.
Thank you, Dr. Lakshya. So we move for the next session. So this is for primarily for residents. So we have two presentations from resident. The platform presentations. So the first one, we invite Dr. Can I have the chart, please? Can I have the list, please? Yeah. Okay. So the first presentations will be by Dr. Subhangi. So Subhangi is here. Yeah, Dr. Subhangi, please. She will be talking on hypoperfusion related infarct, case series experience. Yeah. Your time durations will be 15 minutes, 12 minutes, try to finish by 12 minutes, and 3 minutes for discussion.
Good afternoon, one and all. I'll be presenting on hypoperfusion, stroke, and carotid stenosis and a complete occlusion. So we all know that hypoperfusion stroke is due to critical stenosis of the internal carotid artery, and according to the post classification, it belongs to large artery atherosclerotic disease. Out of this critical stenosis due to LAD, around 60.4% of the patient present with ipsilateral proximal artery stenosis or occlusion. And this occlusion of critical stenosis and chronic cerebral hypoperfusion is a potential risk factor for Alzheimer's disease and needs to be treated. So, according to the stroke classification, the predominant part of ischemic stroke is occupied by the large artery disease. So here I present 3 cases which are similar but the management is different. 66-year-old male, known case of periambulary adenocarcinoma pancreas, diagnosed in July 2024, presented with sudden onset left upper limb and lower limb weakness with difficulty speaking, and he was out of window period of more than 4.5 hours post the thrombolysis period with the NIHs of 9. Examination showed left upper limb and lower limb power of grade MRC 3/5 and 2/5 with left UM and facial palsy. MRI brain and MR angio brain and neck was suggestive of diffusion restriction in the right hemisphere with internal watershed infarct. Subsequently, DSA was done which showed near complete occlusion of the right internal carotid artery. I'll be showing the images. So, the marked with the arrow on the left is the internal watershed infarcts, and the right figure shows stenosis in the MR angio image. So this was the DSA which was done for the patient following the infarct. This shows that the left ICA is patent and the left hemisphere is forming fully with no perfusion on the right side, no cross flow as well. This figure shows that the posterior circulation is filling the right hemisphere as well, right cerebral hemisphere as well. No obvious stenosis of the vertebral artery, and this also shows the cross flow from the posterior circulation to the anterior circulation on the right side. So this right ICA was completely occluded with no flow, not even a speck of flow forward. So case 2, I'll tell about the management later. So case 2, we have a 58-year-old male, a retired army personnel with history of smoking hookah for 20 years. He presented with sudden onset left hemiparesis with dysarthria with NIHs 4. Examination showed left upper limb power with MRC of 4/5 and lower limb power of 4+/5 and left UM and facial palsy. MRI brain again showed an internal watershed infarct on the right side involving the lentiform nucleus. And digital subtraction angiography here showed near complete occlusion of the right internal carotid. So this on the left are the MRI images showing the involvement, showing the involvement of the caudate nucleus on the right and internal watershed infarcts, with the right ICA being completely occluded with no visualization on the MR angio. So this was the DSA. This was the DSA which was done, which was showing right ICA critical stenosis with mild flow distal to the artery. The left IC had no stenosis and the left MCA was filling fully. Left MCA and ACA, and there was cross flow from the left anterior circulation to the right side. So after shared decision with the attenders of the patient, we had taken a decision of going ahead with stenting. So the right IC, which was nearly completely occluded, we tried to access it via the guide wire and the microcatheter, but as you know, the margin of error was lot and it was very difficult to go through that narrow segment which showed flow beyond the occluded artery. So this was tried, but the patient, unfortunately, he could not take the procedure and he went into severe bradycardia with a heart rate of less than 20 and he went into hypotension. So the procedure had to be abandoned and he has to be shifted to an ICU. Luckily, the patient overcome his critical situation and he was all right the next day with his previous deficit. So post procedure, we can see that there is mild perfusion of the occluded segment has opened a little, but not fully. And at that point, he underwent severe bradycardia. So the third case was a 73-year-old female with no prior comorbidities referred from the other hospital. And she had 1 day history of right upper limb and lower limb weakness and decreased verbal output with an NIHS score of 8. Examination showed right upper limb, lower limb power with an MRC of 4/5 with Broca's aphasia. An MRI brain showed infarct in the left frontoparietal region with corresponding changes on the flare sequences. Digital subtraction angiography, DSA, showed near complete occlusion of the left internal carotid just above the bifurcation. So, the DSA of this patient showed that the right vertebral artery with the basilar artery was normal and the right ICA did not show any stenosis. But there was a cross flow from the right anterior circulation to the left side and the left ICA showed critical stenosis. So after shared and informed consent with the patient attenders, she was taken up for a stenting. So this was a critical stenosis of the left ICA. Then we tried to get access using the microwire, microsheet, microcatheter and the guiding sheet. And angioplasty was done not once but thrice throughout the length of the ICA. This is the first balloon angioplasty which is being done. This is the second. And this is the third. So a stent was placed first in the upper segment, followed by above the bifurcation. Post-procedure DSA shows complete flow through the left ICA into the MCA and the ACA, and subsequently it shows that the cross flow from the right has reduced to the left. Right has reduced to the left. So the first case, as the artery was completely occluded, 100%, the patient was managed conservatively with dual antiplatelets and physiotherapy, and he was transferred to a medical oncology department for his further management of periampullary carcinoma. And he was at the point of transfer, he was at the MRS of 4. The case 2, who underwent bradycardia and hypotension, after recovery, his blood pressure was maintained at a higher range of 140 to 160 systolic, and he was managed conservatively with dual antiplatelets after failed attempted intervention for stenting and discharged with an MRS of 1. The case 3, after successful stenting and balloon angioplasty, was discharged with an MRS of 2. So here we have 3 cases with varied management and varied results. So the discussion, carotid artery disease or carotid artery stenting, the trials like what should be done, surgery or stenting, started from year 1991, in which the NACID trial and the ECSC trial were done to show how much was the stenosis and what should be done for the patient. The NACID trial in 1991 was in favor of carotid endarterectomy and showed that higher grade stenosis of 70 to 99% had better results with endarterectomy. And the comparison between ESET and the NACID showed that the NACID trial underestimated the amount of stenosis compared to the ESET trial. There were various other trials for carotid stenting, like carotid stenting with the use of an embolic protection device for compared with endarterectomy, showed that there was in patients who had either symptomatic carotid stenosis of at least 50% luminal diameter or asymptomatic stenosis of at least 80%, it was found that patients with severe carotid artery stenosis and increased surgical risk, there was no significant difference in long-term outcomes between patients who went carotid artery stenting with an embolic protection device and those who underwent endarterectomy. So all these trials favor both carotid artery stenting and carotid endarterectomy. So SPACE 1 trial was a trial which tried to find out whether carotid artery stenting was non-inferior to carotid endarterectomy. And after 2 years of follow-up, it was found that recurrent ipsilateral ischemic stroke was similar in both the treatment groups. In 2023, there was a SPACE 2 trial which said that the effect of carotid endarterectomy and carotid artery stenosis was similar to the best medical management. So the latest trial is the CREST-2 trial, which is trying to show whether carotid revascularization and medical management for asymptomatic carotid artery stenosis is useful or not. So till now, we were saying whether carotid artery stenosis or the carotid endarterectomy in a symptomatic carotid stenosis. But in 2003 guidelines have approved carotid artery stenting even for patients with asymptomatic carotid stenosis. So in the first 2 cases, systolic blood pressure after 24 hours of carotid artery stenosis should be maintained below 130 by millimeter of mercury to prevent post-stenting ICH due to varied mechanisms. But there are guidelines to tell when carotid artery stenting has to be done and endarterectomy has to be done, and at what percentage of stenosis it has to be done. But there is no consensus regarding the optimum blood pressure in patients with critical stenosis, and the general guideline practice generally says that we maintain a higher systolic blood pressure to allow for adequate perfusion via cross flow from the other side in patients with good collaterals.
Thank you so much for the 3 varied cases. What I would like to impress upon is the first case, while did not have a trans-communicating collateral, and the other 2 having that, we need to see the adequacy of the collateral before we attempt to stent these vessels? Because what I feel is both these vessels are chronic occlusions, the first, second and the third. And maybe the first one could have been acute occlusion because it did not have a cross flow or a good collateral. But the other two have good transcommunicating collaterals. So the adequacy should be assessed both by DSA and by other modalities prior to attempting a stent.
So any more questions? Thank you, sir.
Thank you, sir.
So our next platform presenter is Dr. Angiraj. So he will be talking on intrasecular, I think, endovascular approach for intracranial aneurysm, institutional experience from Assam. I request Dr. Apratim and Dr. Mandar, please, we're having e-poster which is there for as a judging the e-posters, which is there at the receptions registrations area. If you can kindly help us doing the, judging the e-posters. So all the residents who have, you have submitted your e-posters, please be there for assessing to present your e-poster, please.
Good afternoon, everyone, in this August gathering. Today, I am going to present on endovascular management of intracranial aneurysms and institutional experience, presented by myself, Dr. Angiraj Bhattacharya, guided by Professor Bhakanta Kumar Boisya, Dr. Asim Boro, and Dr. Gorky Medhi. Now, first, we come to the three key words in the presentation: endovascular, internal or within the vessel; DSA, digital subtraction angiography; and aneurysm, that is ballooning or localized swelling of the wall of an artery. Informed consent has been taken for all the cases presented here. Intracranial aneurysm are abnormal dilations of the intracranial vessels in which all the layers of the vascular wall are affected by degenerative changes that lead to distension of the vessel. Subarachnoid hemorrhage is the most devastating clinical presentation. The goal of preventing hemorrhage or rehemorrhage can be achieved by excluding the aneurysm from the cerebral circulation. Endovascular management is one of the ways by which we can achieve this goal. Most intracranial aneurysms are clinically silent until rupture, which is unpredictable and sometimes associated with subarachnoid hemorrhage, intraparenchymal hematoma, and interventricular hemorrhage. The randomized ISET study has clearly demonstrated the superiority of endovascular treatment, EVT, of ruptured aneurysms using coil technology over surgery. Although for unruptured aneurysms, a direct comparison between EVT and surgery is not yet available, yet EVT has been widely used in this subgroup as well. Coming to the materials and methods, it was a retrospective study conducted in the Department of Neurosurgery, CN Center, GMCH, for 2 years from September 1st, 2022 to August 31st, 2024. The study population was 106 patients. Data collection was done by electronic medical records of eligible patients, which retrospectively reviewed to extract relevant data. Coming to the criteria, the patient with both ruptured and unruptured intracranial aneurysm confirmed by DSA were included in the study. Patients who were willing to give written consent were also included in the study. The patients which are DSA negative, the patients with other metastatic lesions in the brain, patients who are not willing to give written consent were excluded. We have used three tools in this study, the WFNS, the Hunt and Hess, and the modified Fisher scale. As we approached, we thought of the three core principles of endovascular treatment, that is creating a stable construct, balancing coagulation, and promoting endothelialization. Out of 106 patients, 80 patients were done simple coiling, 15 balloon-assisted coiling, 3 stent-assisted coiling, 3 plus-minus flow diverter plus-minus coiling, and 5 patients have been done parent vessel occlusion. Details of the endovascular procedure, including the approach, the extent of coiling, intraoperative findings, and the use of adjunctive techniques were recorded. Intraoperative complications such as the vascular injury and the injury to the surrounding structures were documented. Post-operative outcomes were assessed based on clinical parameters, radiological findings, and complications. Radiological assessment included post-operative X-rays and CT scans to evaluate the effectiveness of coiling. Post-procedural complications such as neurological deficit, speech abnormalities, visual deterioration, etc. were documented. Patients were followed up in the OPD to assess long-term outcomes. Descriptive statistics were used to summarize the demographic and clinical characteristics of the study population. The study was conducted in accordance with the principles outlined in the Declaration of Helsinki and approved by GMC's Institutional Ethical Committee. Coming to the results, we saw that 64 patients out of 106 were male patients, whereas 42 were females. There were, there are more than 64 patients were above 60 years and 42 were less than 60 years. There was a slight female preponderance, that there is 56 patients out of 106 were female patients. Headache was the most common presenting symptom observed in 100 patients, followed by difficulty in speaking, vomiting, and blurring of vision respectively. EVT achieved complete occlusion in 85%, that is 85 cases, and partial occlusion in 21 cases, that is 20% of the cases. This was done by DSA before the patient was discharged. Intraprocedural rupture, there were 0 cases which had intraprocedural rupture. Post-procedural complications were observed in a very small subset of patients, with vasospasm being the only complication occurring in 3 patients. Of these, 2 patients were presented with hemiparesis and 1 patient presented with slurring of speech post-procedure. Later, both of them improved. The length of the hospital stay varied among patients, with majority, 95%, requiring a hospital stay of 7 to 14 days. There was 1 patient, we had a mortality of 1 patient who expired on post-procedure day 10. That patient pre-procedural GCS was also very low, that was E2, V2, M4 on presentation. We did follow-up on the basis of modified Rankel scale score. During follow-up at 3 months, 105 patients were in the group 0 to 1 and 0 patients in the other groups. While in 6 months and 1 year follow-up, we had 103 patients in 0 to 1 group, with 2 patients each in 2 to 4 groups. Summarizing the results, a total of 106 patients were included in the study, with 53% female. Headache was the most common presenting symptom, followed by slurring of speech. Post-operative complications were observed in a very small subset of patients, with vasospasm being the only complication. The length of hospital stay varied among, with the majority requiring 7 to 14 days of hospital stay. A follow-up with MRS score at 3 months, 105 patients were in the score group 0 to 1, whereas 103 patients were in the same group in 6 months and 1 year. Now we would like to show a few clinical cases. The first case is a case of simple coiling. The patient was a 57-year-old male with headache of 7 days. Vomiting was present. The patient was drowsy at the time of presentation. CT scan was done, which showed subarachnoid hemorrhage. Subsequently, DSA was done, which showed anterior choroidal artery aneurysm. This is a post-procedure coiling DSA image. The patient was mobilized early. The patient, this is a first photograph is a post-procedure day 2 image, and the second case image is of the patient after 1 year follow-up. In the second clinical case, it is a case of balloon-assisted and stent-assisted coiling in the same sitting. The case is a 63-year-old male with headache for 2 days. Vomiting was present. The patient was alerted and conscious at the time of presentation. The CT was done, which showed dilated ventricles and subarachnoid hemorrhage. Subsequently, DSA was done, which showed a fusiform ACA aneurysm and left MCA bifurcation aneurysm. Balloon-assisted coiling was done for the saccular MCA aneurysm, and for braided stent was used for fusiform ACA aneurysm. These are post-procedure images. This was a CT scan done at the time of discharge. The patient was also ambulatory at the time of discharge. This is the after 1 year follow-up. Here we can also see the braided stent. The third case is a stent-assisted coiling. However, we do not have a pre-procedure image of this patient. This is a post-procedure image of a parapicom aneurysm. Here we can see the solitaire stent extending from the right MCA bifurcation to the cavernous ICS. This patient was also discharged without any deficit. The fourth case is a case of liquid embolics. The patient was a 16-year-old male with headache for 3 days with vomiting. The patient was alert and conscious at the time of presentation. We saw a DSA was done, which showed a distal PCA aneurysm. NBCA cast was used. This patient was discharged very early on post of day 2. The third case is a very interesting case that came to us from the Department of Ophthalmology. Is a 5-year-old male with history of vomiting. The patient came to us for ptosis of the right eye. MRI was done and subsequently DSA was done, which showed bilateral cavernous ICA, giant aneurysm with thrombosed right ICA. Pre-procedure image of DSA. Coiling was done. The X-ray was done at the time of discharge as per criteria of Ayushman Bharat. And we called the patient 2 days back for follow-up, 3-month follow-up. The patient had much decrease in the ptosis of the right eye. These are some other cases of aneurysm pre and post DSA or procedure DSA images in our institute of some A1 segment aneurysm, basilar trunk aneurysm, PCOM aneurysm, Dhaka aneurysm. Finally, coming to the conclusion, intracranial aneurysm has been treated with clipping over the last 3 decades in our institute, but for last 2 years, endovascular treatment has been used parallelly, which shows promising results. Endovascular treatment has shown excellent results in short-term follow-up. Further prospective studies with large cohorts and longer follow-up durations are warranted to validate our findings and further optimize the outcomes of endovascular treatment. This is an acknowledgement image of the neurosurgery hybrid OT in CN Center GMCH, where we have a team of neurosurgeons, intervention neuroradiologists and intensivists working together as a team for results. Thank you for your patient hearing.
Thank you. Any questions you have? Okay, thank you so much.
Thank you.
So can I have a question, please? One question. Just so do you have follow-up of these patients who have endovascular? Yes. So how many months you have follow?
Sir, we have done 3 months follow-up, 6 months follow-up, and 1 year follow-up, sir.
Follow-up doing DSA?
Sir?
Angiography? You have done DSA, digital subtraction angiography?
Yes, sir. Yes, sir.
So how many percentage of patients who had simple coiling had recolonization?
Sir, we had actually 15% of the patients. In check DSA, we have seen partial occlusion and recanalization, sir.
Okay, so you feel that 15% patients needed second stage treatment?
Yes.
Like, huh?
Yes.
Okay. Right, and any procedure-related complications you have observed during this one, like during coiling, rupture of aneurysm itself?
Sir, we did not have any intra-procedure complication. Post-procedure vasospasm we saw in 3 patients. But both of them, all the 3 patients improved prior to discharge, sir. But we had a mortality of 1 patient, sir.
Okay. And all are SH, ruptured aneurysm?
Yeah, no, sir. There were some
incidental also?
Most of the patients were ruptured aneurysm only. Few were unruptured aneurysms as well, sir.
Unruptured. Right. Thank you.
Thank you, sir.
Thank you.
So, thank you very much for wonderful presentations. And so we are coming to an end near. So may I request Dr. Namal Bora sir to say a few words before we have vote of thanks and other. Before vote of thanks, we'll have award functions, and I request sir to say a few words.
We all can appreciate the fact that after 3 days of this kind of exercise, anyone would necessarily get fatigued and tired. But it was a very difficult job, which looked almost impossible to accomplish. But because of hard work, dedication, commitment of Dr. Biplab Das, it became possible. He could stitch together people from diverse background to come to Guwahati, give their presentation, and these presentations were really of international standard. Quality of the presentation, quality of the deliberations were very high. But their challenge was that a conference of this kind of theme, it's not easy to sustain it for 3 days. Not easy to sustain it for 3 days, even at international level also. But he wanted to do it so that everybody get an opportunity to use this platform to share their thoughts and experience, learn from each other. So that's why his job became much more difficult. But you did a good job, I must say. You did a good job, really good job. Those whoever has come to the conference will go back home with a very good experience, and each one of them will have something to take back. Thank you very much for all these efforts. I will also thank the team who is supporting you to make this possible. And at the same time, I would also thank all the participants who has patiently stayed till the end of this session to make the validatory function possible. Thank you, everyone.
Thank you, sir, for your kind words and, of course, this support and guidance in all steps. So we'll be just waiting for 5 minutes because our e-poster is going on, and then very short award for our poster presentation, platform presentation, and a quiz. Just for 5 minutes, another 5 minutes, please.
professor in our university. So she has taken it on. I think most business is down in there, maybe laboratory. But at least this maybe the statistics are on all that. Yeah. I am in the organizing team. Brochure will come out. Yes, sir. Yes. They are more offended if the neurosurgeon does call them. Sure, sir. My major joined here, I joined in 2017. First year I did 20 DSA, 2000. Now in a month we are doing around 30 DSA and 7-8 coils. But one thing good we have is we are 4 neurosurgeons practicing together in group.
Hi, good evening. So we are excited. I think residents are more excited here because we have wonderful presentations from them. E-poster was lovely, and quiz was more. So much of competitions was there. So anyway, this is lovely to have you all here. And as we said earlier, participation is more important. This is a learning process. The award is just a simple recognition. All of you have done wonderful presenting cases and discussing, taking inputs from the experts is more important. That is how we learn. So never feel disheartened someone who is not in the list of awards. It's nothing like that. This is may not be your day, but as judges has chosen some of the better presentations today on this day, so I have to come with the result. So for award functions, I will request Dr. Nomal Chandra Bora sir to come over the dais, please, sir. And Dr. Anand Vaishnav, please come over the dais. Dr. Jana, please come over the dais. Dr. Mosami ma'am, please come over the dais. So we will handing over the awards. First is we are platform presentation. Is paper writing is complete now? Platform presentations. Can you show me this? So the platform presentation result is here. So we'll start, we have Dr. Angirash Bhattacharya. So he has presented experience of endovascular approach in aneurysm and follow-up. So he has been given 3rd prize in SNBR 2024. May I request Dr. Yes, please, this side. May I request Dr. Anand Vaishnav to hand over the prize. Thank you. So the second prize goes to Dr. Subhangi. Dr. Subhangi Thakur, she presented a series of IC occlusions where endovascular approach was done, and also she talked about hypoperfusion infarct. For handing over her award, may I request Dr. Maushami ma'am to hand over the. Well, the platform presentation, the first position goes to in a young patient having a stroke who was evaluated intensively and later on found to a carotid wave. And this was presented by bilateral carotid wave. This is the first prize goes to Devashish Huta. So may I request Devashish Huta to come over the dais. To hand over the first prize, may I request Nomal Bora Surface. So now we are coming to e-poster. That is more interesting because we have first and second position is tied up. So we thought we'll go for 2 first prize and then we have a second prize. So our second prize goes to Dr. Sehbaz Anis. May I request Dr. Sehbaz please come over to hand over the second prize, may I request Dr. Jaina to hand over the second prize. So the first prize, we have two. So I think you all both participants already know the name. One is Dr. Shikha Priya. May I request Dr. Shikha Priya, please come over. And I will request again Dr. Jaina to hand over the certificate. So our tied of first prize again goes to Dr. Subhangi Thakur. Congratulations. So to hand over the certificate, may I request Dr. Anand Bishop. Our quiz was very interesting. So we had intense, competitions in the quiz. We had 5 rounds, and then rapid fire rounds also we had. So the results is here. I think they might be knowing the result as well. So the third prize goes to Dr. Felgam. May I request Dr. Felgam to come over the dais and request Mosumi ma'am to. Second prize goes to Shikha Priya. Dr. Shikha Priya, please. Handing over the certificates, I will request Dr. Anand Vaishnav, please. Well, the first prize, it's already known, Dr. Subhangi. Well done. To hand over the certificate, may I request Dr. Nomal Bora, sir. So I think our function is over, but as said, it seems to be like the day one of our conference. It's still so energetic, and seeing you all, especially the support and all. And but all good words comes to end, of course. So I take this opportunity to thank you, everyone, each and everyone who is associated with this initiative to take the message to make more aware about stroke among us, among public, to make a network among ourselves to improve the quality of services which you can provide to our patients. I take this opportunity to thank you, my chairperson, Nomal Bora sir, for his wonderful, I don't know what's the word I to say. So his guidance, his words has been so inspiring, motivating all the time. Thank you, sir. I'm thankful to the course director, Boshra sir, our co-director, Goshami sir, and our all organizing committee members, including my colleague, Dr. Arindam Kakati, Dr. Lakha, everybody's. So it was really wonderful to working with you all. It was lovely. We are looking forward for more interactive session. I take this opportunity to thank you all my delegates, faculties who is coming from different regions of India. They have taken out their so much of important time to come over here. They're being one of the best experts in this field, and our international faculties who have taken out the time to connect with us from Stanford University, from Miami, from Europe, who have been there doing lots of work. They are being the authority in that subject. I thank you, all my delegates, my friends, and I thank you, our event manager, Aditya, and more that's there. All team members who have been sitting, they have been doing their works whole day and night. I take this opportunity to thank you, all the support from the sponsors which we got. Thank you all for being here. You have taken so much of pain for doing this work successful. You working day and night. You have been supporting us. Really wonderful. Thank you all. I might be missing some of you members, and especially I thank two of our anchors. They did a fabulous, wonderful job. I mean, like the way they present, I was fabulous. I mean, they catch up the points and the describing. So today I had to, do some sort of anchoring, presenting. I was surprised how to do that. They did lovely. It was wonderful. I don't know. So anyway, but we found this 3 days, as I said, it was so much of a wonderful interacting, so high academic interactions with you all, learning so much of points, taking it to the next level. We hope this will be a step forward to take it forward, so that we can practice more scientific, effective, and practice which is really helpful for patients and others. I take this opportunity to thank you, all of you. Thank you very much. Have a wonderful weekend. Thank you. We'll see you again. Thank you, ma'am. Thank you, everyone. Thank you, sir. So saying so, I conclude today's vote of thanks. Thanks a lot. We'll be looking for another sessions down the line. We'll come up with a wonderful program. Thank you very much. Also, nevertheless, I cannot forget, this is incomplete completely, because the way I got support from my